Thank you, Dr. Amar. Good morning to all of you. So I wish to welcome all of you to this our first session of this is on fluid and electrolytes for the pediatric surgeon. This will be talk will be given by Dr. Shivani Dogra, who is an assistant professor of pediatric surgery, PGI-MER Chandigarh. So in pediatric surgery, she is a neonatologist, and she will be sharing her experience how among the pediatric surgeon, how she feels, and what are the important fluid and electrolytes, which is a very important aspect of management, especially in neonatal and perinatal period. So, Dr. Shivani.
Thank you, sir, for a kind introduction. I think I'm audible. Am I audible now? Okay, sir. Thank you for this kind introduction. So I'll be presenting the first session of today's meet, and it is fluid and electrolytes, especially with the pediatric surgeon's perspective. So to start with, this is a brief, just a brief purview of what I'll be presenting. A brief physiology of the fluid balance, the common fluids which we are giving, and what fluids we should give in different scenarios. And I have picked up the surgical scenarios so that that is helpful for the target audience in this today's session. First, to start with a brief physiology. The fetus, as we know, it has got a very high total body water, and as the gestation progresses, this the free water, it decreases, and in a term baby, the total body water is around 75% of the total body weight, and this water is significantly higher in the premature babies. However, as the baby grows, this body water, it decreases, and it reaches around 60% of the body weight at around 1 year of age, and then it decreases, but not to that extent as the child grows. And this is, we should all know the basic physiology of this fluid compartment of our body. This is very important because I will be discussing later on what is the distribution of various electrolytes in these compartments, which can help in the better understanding of the electrolyte and fluid management of these children. So the total body water is basically divided into two compartments, intracellular fluid as well as the extracellular fluid. In the fetus, as I've already mentioned, and then in the newborn, the extracellular fluid volume is quite high. And there is a lot of diuresis during the first 2-3 days of life, which decreases this ECF volume. But still, the ECF volume is significantly higher in the newborn age as compared to the bigger children and the adult life. However, as the age progresses, the extracellular fluid volume decreases, and the ICF, that is the intracellular fluid, it increases, and it constitutes intracellular fluid in the adult life and in the bigger children. It constitutes around 30 to 40% of the body weight. And this ECF is further divided into the plasma and the interstitial fluid, as we all know. So knowing the basic distribution of electrolytes in a body, which we all know, I guess, and which we have studied in our MBBS days, is that the composition of the electrolytes in the ICF and ECF is very different. We know that sodium and the chloride are predominant ECF ions, and the potassium is basically distributed inside the cells. So this knowledge has got a very important role in practical management of the children. This is I'll give you an example. Like whenever there's hyperkalemia, so we try with our management to shift this potassium inside the cells. And this distribution of the sodium and potassium in the cells is basically maintained by the sodium potassium ATPase pumps, and as a result of which potassium is concentrated intracellularly and sodium is in the intravascular compartment. Now, after discussing this physiology in brief, now I'll be discussing a very practical question, that which fluid should be given and how much. And I'll be discussing mainly in the perioperative period, or the children who are needing surgery, or the children who have underwent surgery. So the perioperative fluid management is basically divided into three parts. First is the maintenance. Then these children usually come with to us with various fluid deficits. So we have to replace all those fluid deficits also. And there are several, like there is ongoing losses of these fluids also, because we are putting different drains. Many of them will be having polyuria. So these ongoing losses also need to be replaced. First, coming to the maintenance fluids. As you all know that we lose the fluid by two ways. First is the sensible losses, which is through kidneys and the GIT. And there are a lot of insensible losses also, that is through the skin and the respiratory tract. So the aim of the maintenance fluid is to replace all this fluid. This is the traditional holiday and cigar method, which we all know of fluid replacement, which we do which we follow in the pediatric age group. That is, for the first 10 kg, we give 100 ml per kg per day, and then subsequently for each kg body weight which is above that, we add 50 ml per kg, and a child who weighs more than 20 kg, we add 20 ml per kg for that. So for example, if we have a 15 kg child, the child will receive 1000 ml for the first 10 kg, and for the next 5 kgs, then we'll give 250 ml. So the child has to receive a total of 1250 ml in 24 hours. However, this holiday cigar method is not followed in the neonatal age group. This is due to different reasons. Neonates have a different requirement as compared to the pediatric age group. In term babies, we start maintenance at the rate of around 60 ml per kg per day. And then we go on increasing by 15 to 20 ml per kg per day. And to reach a maximum of around 150-160 ml per kg per day, that we reach around 5th to 7th day of life. And we give only dextrose during the first 48 hours. And after 48 hours, we add sodium and potassium after the diuresis has been established. In the preterm babies, we try to give more of the fluid because they have more losses. The skin is premature, the surface area is high. So in preterm babies who are less than 1.5 kgs, we give 80 ml per kg per day of the fluids, and then we gradually hike it. In ELBW babies, that is the babies who weigh less than 1 kg, we try to give even more fluid. We give around 100 ml per kg per day, and then we increase as per their losses, and we reach a maximum of 150-160 ml per kg per day. And these ELBW babies, it's very common that they'll get hyperglycemia. So sometimes we even give for the first day, we give 5% dextrose also in these babies, small babies. But the maintenance which I have discussed, it is not it has not to be followed strictly. There are special circumstances when we have to either restrict the fluid or relax the fluid. For example, first I'll take the fluid restriction. There are various cardiac conditions where we need fluid restriction, but it is a common misconception among the surgeons that they feel that if there's a cardiac condition, we need to restrict the fluid. But that is not the case. The first question that has to be answered whenever a child with cardiac condition comes to us is that whether the cardiac condition is associated with the high pulmonary blood flow or a low pulmonary blood flow. For example, VST, PDA, they are associated with high pulmonary blood flow. So we need to restrict fluid in these patients. However, there are certain conditions like the tetralogy of Fallot. In these conditions, we don't need to restrict the fluid. Rather, we have to give fluid on the higher side. So it's very important to basically understand the physiology of the cardiac condition and then to give fluid accordingly, not blindly restrict the fluid in cardiac conditions. And another important thing where fluid restriction has to be strictly followed is myocardial dysfunction. This is a very common condition in our ICUs because there are many septic children who develop low ejection fractions. So myocardial dysfunction has to be dealt with fluid restriction. And SIADH, which is again a very common condition in the perioperative period, that has also been dealt with fluid restriction. I'll be discussing SIADH in detail later on. And now there are certain conditions which need fluid relaxation. For example, if there are extra losses, if we are putting a child under a warmer, if child is having fever, diarrhea, emesis, certain other conditions like gastrocrisis in which we expect a lot of fluid losses. So we have to relax fluid in these cases. There are certain surrogate markers of dehydration. For example, I am talking about the neonates. If we feel that the child is looking, if the hemoglobin is on the higher side, if the sodium is on the higher side, that are indirect markers that the child is dehydrated. So we need to relax the fluid in these conditions. And there are a few guidelines which tell that if we are expecting that there's a SIADH may be present in these conditions, that we can restrict the fluid to around 50 to 80%, especially in the sick babies and the children who are in the perioperative period. But still, there's no consensus about this restriction, blind restriction. Now, this is extreme restriction of fluid that we do in the patients who have complete shutdown. That is the anuric regime we apply. So the anuric regime has to be started only when we are sure that we have taken all the measures, that we should not restrict the fluid in a child who is in complete shutdown if we think the child is still dehydrated. So when all the measures have been taken and the child is still not passing urine, then we have to start with the anuric regime, which is simply we give just the insensible water losses, which is around 40 to 50 ml per kg per day, and plus the ongoing losses, which may be in the form of surgical drains or small amount of urine output that child is passing. And we try to avoid potassium. We don't add potassium in this fluid, and the sodium also is added in very small amount. And another important point which I want to make at this point is in renal shutdown, renal failures, a lot of time we find hyponatremia, but this is rather, this hyponatremia is not due to a decrease in the sodium content. It is mainly due to the dilutional part. So giving excess of sodium won't help. Rather, restricting fluid will help in this condition. So we have to be very sure about what condition we are dealing, then we have to manage that accordingly. Now, after the maintenance, I've discussed the maintenance fluid. So I'll be discussing that there will be number of children who will come to us in shock or dehydration. So how to deal with them? The first step in managing these babies would be first to assess the dehydration. So there are various parameters on the basis of which we can assess this dehydration. Simply, if we know the pre-illness weight, we can calculate the dehydration, but in our setting, I don't think weight is done so frequently. So in neonates, we can use this parameter. However, in bigger children, the weight is not frequently done. So pre-illness weight is not a very useful criteria, but if available, that can be taken to assess a degree of dehydration. And other parameters which need to be assessed include the mental status, the thirst, the skin pinch, the eyes, the mucous membranes. These can be seen, and these can be clinically assessed for dehydration. There are certain vitals like heart rate, the CFT, the blood pressure, which can be used to assess the dehydration. But blood pressure is the last thing to crash. So it's not like the BP will fall only when all the compensatory mechanisms have failed. And we should always remember to measure to ask for the urine output. It is a very simple question which will give answer to a number of which will help in assessment of the hydration status in a big way. Because if the child is passing urine output adequately, that means either the child is not dehydrated or there is some degree of dehydration. So if the child comes to us with shock, so what to be done next? We need to give boluses, and we have to give isotonic boluses. So isotonic boluses means normal saline boluses, and it can be given. We can give 1 to 3 ml, 1 to 3 boluses of 20 ml per kg of the boluses. But nowadays we have to be very cautious while giving boluses. There are a number of studies in the pediatric age groups which have showed that these boluses can increase the mortality, because especially in the sick children, these sick children can have myocardial dysfunction associated with the sepsis. And then when we are giving boluses, so they can get decompensated. So while giving boluses to these children, we have to be very careful, and after clinical assessment properly, we have to give further boluses. And another thing is, if we have a child with cardiac condition, then also boluses should be given very carefully. Then management of the dehydration. If there's some dehydration and if the child can take orally, then we can give around 75 ml per kg in 4 hours. That can be given orally or through IV route. And in case of severe dehydration, we have to give 10% correction. What does this 10% correction means? 10% correction means around 100 ml per kg of the fluid has to be replaced. So this fluid has to be replaced maybe in smaller children, that can be replaced over prolonged time, and in the bigger children that can be given in 3 to 4 hours. So after this, I'll be discussing briefly about the replacement of the ongoing losses. So in the surgical units, we see there are different drains, there are NG losses. So these need to be very carefully, these need to be replaced. But before replacing, we have to know about the electrolyte composition of these body fluids. So the NG fluid, we should know that it contains a high sodium content, a high potassium content, chloride content. So this has to be replaced properly. So we should know which fluid has to be replaced with which fluid. So ml to ml replacement of the fluid should be done. Now coming to the maintenance fluid. So I've answered a lot of questions regarding how much fluid should be given. So now coming to which fluid should be given. So the maintenance fluid which we are giving, basically they have 3 contents: the water, the electrolytes, and the glucose. So I'll be briefly discussing these now. This is a table which is showing the composition of common IV fluid preparations which we are using. I guess most of the units are using isolite P, ringer lactate, normal saline, DNS, half DNS. So we should know the basic composition, whether this fluid contains potassium or not, what is the dextrose content of this fluid. This should be known in whenever we are using a fluid in our unit. So a basic concept which I want to highlight at this point is a lot of time we are using the term tonicity, that this fluid is hypotonic, this fluid is hypertonic or hyperosmolar. So what is the difference between tonicity and osmolality? So this concept should be very clear in our mind. So tonicity, it is a relative term. It is the net vector forces on the cell in relation to the semi-permeable membrane. So this is very relative. The osmolality, on the other hand, it is an absolute term. It is osmoles of solutes per kg of the solvent. So osmolality will remain the same, whether it is inside a bottle, whether it is inside the intravascular compartment. And another important thing is that the basic understanding should be the tonicity of the IV fluid is basically dependent upon the sodium content of that fluid. So any fluid which is isotonic to the plasma will contain a sodium which is around 135 to 150 milliequivalent per liter. So I'll give you an example. Ringer lactate, it has a sodium of around 130, which is isotonic. So similarly, normal saline, it has got sodium of around 150, which is isotonic. So the tonicity of a fluid always depends mostly on the sodium content. But osmolality also depends upon the dextrose content of the fluid. This is very important. The dextrose will not affect the tonicity of the fluid because it is rapidly metabolized. So you can understand this better from this table. So there are certain fluids. For example, I'll give an example. You can take the example of this NS, normal saline. So the normal saline is isoosmolar and isotonic fluid because it does not have any dextrose and it has sodium which is 154. However, if we add 5% glucose to this, that is DNS. So the DNS still remains isotonic because the sodium content won't change. However, it will become hyperosmolar because we have added 5% glucose to it. So this concept of osmolarity and tonicity is very important when we are giving the fluids. So now the next question, which we need to answer is, what fluids should be given, isotonic or hypotonic fluids? For years, we have given for years, we have been giving hypotonic fluids. We have been using isolate P in our units. I think some there's a lot of disturbance. I think, yeah, now it's better. So now the consensus is that in all the sick children who are beyond the neonatal age group, they should receive isotonic fluids. What do you mean by isotonic fluid? That is either DNS or ringer lactate or other balanced solutions. Hello? Yes.
5 minutes are remaining.
Okay. So I think I have to rush a lot. Okay, ma'am, I'll be discussing briefly the rest of it. So, but the problem with these isotonic fluids is whenever we are giving normal saline is that there's hyperchloremic metabolic acidosis. So nowadays, more of buffered solutions are being given. Now, coming to the next component, the maintenance of the glucose. The maintenance of glucose is like when we are giving the normal fluids which we are using in our unit, we should always remember that when we are giving this, the caloric requirement cannot be fulfilled with the glucose which we are giving with the fluids. So whenever we are anticipating that the children will be on prolonged IV fluids, so we should decide about giving parenteral nutrition to these children. Giving glucose in the perioperative period is also, there are a lot of controversies, but now the consensus is that we should give low glucose during the perioperative period, around 1 to 2.5% of the dextrose containing fluid should be given. Now, briefly coming to the electrolytes, the normal sodium content of our serum is around 135 to 145 millicoulomb per liter, and the normal requirement is around 3 to 4 millicoulomb per kg per day. Hyponatremia is a very common problem in the surgical babies, and the most common reason, as I've already mentioned, is giving hypotonic IV fluids and as well as condition SIADH, which is very common secondary to the stress and the pain which these children are having. So the hyponatremia can cause a lot of issues. It can cause neurological symptoms because of hyponatremia. There's decrease in the osmolality, as a result of which the free fluid, it rushes towards inside of the cell, causing cellular edema and raised ICP, and which can in turn lead to seizures. Whenever I'll be discussing this table very briefly because we are running short of time. So whenever we are having any child with hyponatremia, that is sodium with less than 135, it is very important to first ascertain what is the cause for that. Either if that hyponatremia is associated with euvolumia, if it is associated with dehydration, or the child is looking puffy or is hypervolemic. So the management will be different for all these three states. If the child is dehydrated and the urine sodium is less than 10, then most likely the child is hyponatremic due to some losses, either vomiting or diarrhea, and soon we need to replace that. However, in case of normovolumic hyponatremia, that is in cases of SIDH, so we need more of fluid restriction rather than giving sodium, because that will rather worsen the state. So in SIDH or any condition in which there is normal or increased extracellular volume, we have to restrict the fluid rather than giving extra fluid, extra sodium from outside. So another important thing when we are treating hyponatremia is that rapid corrections of hyponatremia should be avoided. only when the child is severely hyponatremic, that is sodium is less than 120, or the child is symptomatic, is having seizures, then we need to.
Excuse me, Dr. Shivani?
Yes, ma'am.
Our time limit is over.
Yes, ma'am.
Last 1 minute is.
Okay. Ma'am, then I think, okay, I'll try to rush. Ma'am, can you give me 2-3 more minutes? Whenever there's severe hyponatremia, then we should try to give 3% NaCl, and we expect each ml per kg of 3% NaCl to increase the sodium by around, like each ml will increase it by 1 milliequivalent. So if we give 5 ml per kg of 3% NaCl, that will increase the sodium by 5. So if the child has presented to us with seizuring and sodium of 125, then giving this bolus will increase it to up to 130, and then we can calculate the rest of the correction. So this is roughly a table which tells us how to diagnose and manage SIDH. So basically, this simply tells that when there's hyponatremia, along with high urine osmolarity and high urine sodium, then that indicates SIDH, and the management is simply fluid restriction. And if the sodium is very low, then we can also give furosemide. Hypernatremia, this is not very common in our setting, but still we see a lot of children, especially who come with stoma losses, they come with hypernatremia, or even hyponatremia, but hypernatremia also they come with. So the important thing in hypernatremia is that they will be relatively preserved, because the intravascular compartment is preserved. So there will be, in later stages, they will become irritable. They can throw seizures also. This is because there's shrinkage of the brain and there's tearing of the bridging blood vessels. So hypernatremia, very important thing to consider is that during the initial stages, they will be well preserved, they'll be having a doughy skin. The other classical features of dehydration may not be present in these children. And again, hypernatremia has to be corrected very slowly. So practically for all of you, I want to tell it's very cumbersome to calculate the corrections for hypernatremia, and can take long, like it will be a very tedious process. So practically what we should do is we should give n/2 or something between n/2 to n/4, and we should increase the maintenance by around 30%. That should take care of hypernatremia, and we should frequently monitor the sodium. Regarding the hyperkalemia is also a very important electrolyte abnormality which we see in our ICUs. And the management, I think I'm running out of time, so I have to describe it briefly. How we manage hyperkalemia, as all of you must be knowing, there are important things which I want to tell is that Caxilate is the only treatment which will decrease the potassium load. Rest. Excuse me. I have to describe it briefly. There's a lot of disturbance. Actually. Excuse me, ma'am. Somebody can. Now coming to the hypokalemia. In hypokalemia, I just want to mention this only, that when there's severe hypokalemia, then we should give the stock solution. If the potassium is more than 2.5, we should try to increase the maintenance. The stock solution, a simple formula, 90 ml saline, 10 ml KCl, we should give it at the rate of 1.5 ml per kg for 3 hours. So we should know the basic like formulas for the treatment of these electrolyte abnormalities. Hypocalcemia is like it is common, but not very common in our setting. But basically, sir, this is the last slide. This is his last slide, sir. So 10% calcium gluconate has to be given 1 ml per kg, and it has to be given very slowly. So there were a few case scenarios, but I don't think we have time for that. Thank you. So I think I've finished. So if there are any questions, so I can answer those. Am I audible? Sir, am I audible?
Shivani. Thank you, Dr. Shivani, for an excellent talk. Somehow we are running already 5 minutes late now. So
Yes, sir. So, okay, sir.
there is just one question maybe. Fluid restriction, what you told,
Yes, sir.
is it recommended in the post-operative period in the neonate also? And what kind of fluid if you want to give?
So it's a very clinical thing to do. In the neonates, I have already mentioned, as in pediatric age group, we don't have the consensus to use the isotonic fluids. We are still using isolite P only, N/4 or isolite P only. And regarding the fluid restriction, it is very clinical, especially like it has to be, the neonate has to be assessed clinically, and we need to give fluid accordingly. If the baby looks dehydrated, then we have to relax the fluid. Otherwise, we have to restrict the fluids. But we can't give any blanket statement about restriction. So are there any more questions?
Thank you, Dr. Shivani. Now we move to the next session. Dr. Rasik Saha and Dr. Mohar, our speaker.
अभी रुक जाइए आप इधर रखो.
Hello, should I get started? Hello, can you hear me? Shall I get started?
Okay, please start.
Yeah, Dr. Lee is a professor and surgeon-in-chief of Children's Hospital in San Francisco, and he's also the director of the Fetal Treatment Center, UCSF. And he has a long history of about 35 years in the field of fetal surgery after Michael Harrison. Over to you, Dr. Lee.
Thank you. Can you hear me? Can you all hear me okay? Can you hear me? No. Can you hear me?
Yes, we can hear you.
Okay, thank you. So thank you for the kind introduction, and thank you to Dr. Shah for the privilege of presenting to you all. And I'm going to present to you about our experience with fetal surgery, and keeping in mind that this is many, many people's work. And again, it's a real privilege and an honor to present to you all here. And thank you for your attention. When first looking of the fetus as a patient, it's important to understand that the fetus is shrouded in mystery, shrouded in membranes, and difficult to see and difficult to treat. The first concept for treatment of the fetus was that there were simple anatomic defects which could lead to disastrous physiologic consequences. Perhaps the best of those that we think about and often as pediatric surgeons is diaphragmatic hernia, a small hole in the diaphragm leading to pulmonary hypoplasia. And of course, there's many other examples. And I would be remiss if I didn't mention my senior partner and mentor and friend, Michael Harrison, who in many topics, it's hard to know who was the real person who was the pioneer and the father or the mother of a field. And I think the whole world can agree in this area. It's Dr. Michael Harrison, and he's still active doing research, and it's just a pleasure to continue to work with Michael. So if you look at many of the people who throughout the world who do fetal surgery, the origins come at San Francisco, a second generation, third generation, or even fourth generation trainees throughout the world. At UCSF, the Fetal Treatment Center was founded in 1981. It was the first of its kind in the United States and really in the world. And I think the success was predicated on the fact that it was a multidisciplinary team approach, and everybody checked their egos and participated while being respectful of others. There was also importantly university appointed oversight because there were many ethical dilemmas in treating a fetus because of the potential risks to the pregnant woman. Just a few things about the Fetal Treatment Center. We evaluate complicated pregnancies. We see about 500 cases a year annually, and about 10 to 15% have some sort of surgery before birth. 1/3 live close to us in the Bay Area, the rest coming from the rest of the world, and about 1/3 of these patients deliver at UCSF. One of the things that we're very proud of is that we try very hard to collaborate with our partners throughout the world, and when appropriate, we'll send the patients back to them. Of course, as I was talking about before, there are some ethical dilemmas. We have to judge the potential benefit to the fetal patient with the risks to the mother with anything that we do. And this is a very complicated set of circumstance. And of course, we could probably spend hours and hours talking about the ethics of this. But before any surgery was done in real humans, ethicists were convened and talked to our clinicians at UCSF, led by Mike Harrison, to discuss what should and could be done. And before anything was done in humans, of course, many hundreds of mice experiments, followed by larger animals, and finally non-human primates were done. One interesting thing that we learned from the non-human primate animals models was that we had to develop a new kind of stapler to open up the uterus. And of course, when we open up the uterus, we don't do it the same way that the OBs do, because then there would be a lot of bleeding. We do, at first, Mike used GIA metal titanium staplers, like we use for bowel anastomosis and the like. Unfortunately, we realized that the monkeys could no longer get pregnant afterwards, because the little metal staples would migrate into the uterus after delivery, and they would act like intrauterine devices. So Mike had to develop with industry, J&J, an all-new type of stapler that used absorbable material, much like we use for Vicryl sutures. So they're made out of PGA material that absorbs and is biocompatible. So lots to learn. And then, of course, the first human patients had fetal surgery. And again, here's the stapling device that Mike and industry came up with. It looks sort of like a TIA stapler, but in fact, it has two staple lines and cuts in between. Now is used throughout the world. Interestingly, it has not changed at all since the first time it was developed. It's probably one of the oldest devices. The industry partners have threatened many times over the years to stop making it because they don't make any money on it. The market's very small, but of course, every time they say we're going to stop making it, those of us who use it lobby them, and they have continued to manufacture it, even though I think that there is really no real market for it. So over the years, and this is, I think, one of the things that I contributed when I started, was that when I started here at UCSF over 20 years ago as a junior faculty, one of my areas of expertise was minimally invasive approaches. And so we do things fetoscopically, or even just with ultrasound guidance and needle, with needle-based approaches. And that's increasingly becoming common. Some of the things that in our fetal treatment center that we do, we have high-level diagnostic imaging. And I would say that our ultrasound colleagues in particular are really phenomenal. And about 50% of the patients who come to us have their diagnoses changed or modified when they come to us. And it's obviously very important that before we do any therapies that, of course, we have the best diagnosis possible. We meet weekly in a multidisciplinary conference with about 60 doctors and nurses to go over every patient that has complexity. And then we have non-directive counseling with the families and go over all the options. As I said before, we co-manage the patients with the referring providers. And we arrange for delivery at UCSF if necessary, but if the family and the providers would like to go back locally, and we provide no benefit over delivering locally, then that is always a clearly viable option. So we work with many different specialties, and it's important that there is no one fetal doctor. It's a combination of many, many different types of physicians and advanced practice providers and nurses and other healthcare professionals, including social workers. This is just a partial list of some of the conditions that we treat, and I'll go through a few of these. The first diagnosis, the first condition that Mike treated was urinary tract obstruction. When you have posterior urethral obstruction in a male fetus, it can lead to obstruction of the bladder, which then leads to ultimately severe kidney damage. And then when you have kidney damage and no urine, then you have anhydramnios, and then you can get lung hypoplasia as well. And with two organ systems affected, the lungs and the kidneys, this is obviously a lethal defect. The question was, could we relieve the obstruction to the urinary tract and prevent ongoing renal impairment? Again, a simple anatomic defect, obstruction of the urethra, leading to disastrous physiologic consequences, renal failure, and then potentially pulmonary failure as well. So the first case that Dr. Harrison did was an open vesicostomy, so open fetal surgery, opening up the bladder to the amniotic fluid so that there was a way of egress of the urine. And in fact, the very first case that he did, it worked. And that patient is over 35 years old, and he's come back and visited us multiple times. Since then, this has progressed with using catheters that can be placed through small incisions, with one end being in the bladder and the other end being in the amniotic cavity. And sometimes we can even do fetal cystoscopy, where we put a scope into the bladder. Unlike when we do this postnatally, and I'm sure many of you do cystoscopy, we don't do it retrograde. We actually go through the abdominal wall into the distended bladder and then find the outflow tract of the bladder from the inside, and then we can try to open that up using wires and balloons and so forth. Now, of course, we can't do this if the kidneys are already end stage damaged. And so we have, along with many others, developed ways to identify by tapping the bladder and by ultrasound criteria which patients don't have end organ damage so that they may benefit from different types of procedures. If they have end organ damage and we do any procedures, then of course we're only doing more harm. We treat many tumors, CCAMs now, of course, known as CPAMs, congenital pulmonary airway malformations, sacrococcygeal teratomas, cervical teratomas, and pericardial teratomas. And most of the patients can be treated very successfully with postnatal therapy. Some do need prenatal therapy, and it's really based on size of the mass and how much blood flow they get, but really only when they're having high output failure and have visible high drops by ultrasound do we tend to treat patients with large masses. So on the screen left, you see an example of a large SCT, but this is one that for whatever reason didn't develop high drops because the blood flow wasn't so significant, and we treat this after birth, and you can see how vascular it is, and of course we have to be very careful. Sometimes, however, like on the patient on the right, they develop high drops, and we have to take this out prenatally. I do have to say that the sacrococcygeal teratomas, once they develop high drops, there's about a 50% mortality even when we do fetal surgery. And if we don't do fetal surgery, there's 100% high drops. If the patient is at about 30 weeks of gestation, then usually we would opt to deliver early rather than doing open fetal surgery. But again, about 50% survival when we do fetal surgery. And so high drops is a very serious condition with sacrococcygeal teratomas, as it is with all fetal masses. Here's a case of a cervical teratoma, and the fetus developed high drops. You can see the scalp edema, and there was fluid in the abdomen and throughout the skin. And this patient came to us from St. Louis. The woman was pregnant at 24 weeks. And we said, look, if we don't do anything, you're probably going to have demise. So we said, well, maybe at best, based on our experience with sacrococcygeal teratoma, we might be able to offer 50% survival. So she thought about it for a long time and then decided that she wanted to have fetal surgery. And so we did the fetal surgery, and here you can see after we resected it, the mass is now gone. We put the fetus back. In fact, they went back to St. Louis. They delivered via an exit procedure where they intubated the patient on placental bypass. And this patient that I did with one of my partners, not Mike, but another one of my partners, about 19 years ago, came back and visited me last year as he was graduating from high school. The family says he is the smartest of his of the family, including his 3 other siblings. He's an active athlete, and I believe this year he just went to college. So really a remarkable success story, and just showing what we can sometimes accomplish with teamwork, but of course not always does it come out so favorably. Speaking of exit procedures, when we have large neck masses that are not hydropic, sometimes it can be difficult to gain access to the airway. And this is another procedure where you can see us doing rigid bronchoscopy to establish an airway. Sometimes these masses are not only protrude extrinsically, but sometimes there's involvement of the airway. Occasionally, usually we're able to intubate these patients on exit procedures. Sometimes we have to use bronchoscopy. A couple of times we've either had to resect this on exit as an exit procedure, leaving the umbilical cord attached, and the fetus / newborn is getting oxygenated blood through the umbilical cord. And you can see on the picture on the right, the fetus is halfway out of the uterus, but the umbilical cord is still attached. And only when we establish an airway do we then deliver the baby and divide the umbilical cord. Like I said, a couple of times we have had to resect the mass or do a tracheostomy, because we can't intubate through the mouth. So these are oftentimes very dramatic cases. Also want to talk about the evolution of CPAM treatment. Most CPAMs we treat after birth, but sometimes they become hydropic. And typically when you have hydrops, there's about 100% mortality without treatment. The first treatment that Dr. Harrison came up with was using open fetal surgery. And he found that there was about a 50% survival for hydropic CPAMs in utero with open fetal surgery. However, we did note in our long-term follow-up efforts that there was significant long-term morbidity. They almost all required pneumonectomy because the mass was so big and we had to do it quickly. And they often delivered early because of preterm labor. A great story was that actually when I was training before I got to San Francisco, I operated on a patient that had come to see Dr. Harrison, and he had offered open fetal surgery to the mother of the patient, but she had declined at the last second, and the fetus was hydropic. And I did a right lower lobectomy, and the kid is now 25 years old and completely healthy. And I asked our team why this was, and they didn't know. And so we dug into it a little bit, and I found two other patients with one of my postdoctoral students, Kojin Sao, who now leads his own fetal center in Texas. And what we found was that all these three women had decided to have fetal surgery initially, had gotten steroids in preparation for fetal surgery, which we don't actually give steroids anymore. And they had decided at the last second not to have surgery, and they all delivered healthy babies and had elective surgery to remove the CPAM subsequently. And when talking to some of our brilliant lung biologists, they felt like CPAMs, the microcystic ones in particular, were like immature lung tissue, and they felt that the steroids caused the immature lung tissue to mature, and when they matured, they stopped growing and regressed. We now know that all over the world, people have adopted this treatment with steroids that I was lucky enough to come up with. And we've almost put ourselves out of business because now nobody sends us CPAMs anymore because they treat them with steroids, the large ones, and they get much better. And so we have the story of initially we would see the CPAMs and couldn't do anything about it when they became hydropic with 100% mortality. Then Mike found this treatment with open fetal surgery in which there was 50% survival. And now for hydropic microcystic CPAMs, survival is 85%. And similarly, when we have macrocystic CPAMs with high drops, we can put in shunts just like for the bladder. And there is about 85% survival doing it that way too. Congenital diaphragmatic hernia is one of the longest stories. And as you all know, don't have to tell a group of pediatric surgeons, when you have congenital diaphragmatic hernia, you have lung hypoplasia due to incomplete formation of the diaphragm. We found that, however, we could stratify the disease severity with ultrasound, looking primarily at two things. One is the liver hernia up in the chest. If it isn't, then these patients actually all have almost 100% survival in our hands, unless they have cardiac disease or some other severe anomaly. And then the other is the LHR, the lung to head ratio, and lower lung to head ratio is worse. And so initially, Dr. Harrison did a clinical trial in which he looked at liver down CDHs and did open fetal surgery, but we now know that they didn't need it and the surgery was too much. You can see how hard it was to do in utero. He would put meshes on them, do thoracotomies as well, repair them. And while they did survive, we realized that they didn't need it. And so then we went back to the drawing board to see if there was another way that we could create lung growth without closing the diaphragm in a minimally invasive way. And at that time, two groups, the group in San Francisco led by Mike Harrison, and then the group in Boston led by Jay Wilson, both were looking at, could we occlude the trachea? Could we block the trachea and then cause lung growth, like we see in this rare condition called congenital high airway obstruction syndrome, where there's a blockage or tracheal stenosis, and then you're left with big lungs because the fluid causes lung growth. And so lots of animal experiments were done, and a minimally invasive procedure was developed in which a balloon could be put into the trachea, and the lungs would inflate and grow. A trial was done, and what we found was that, and you can see Dr. Harrison was the first author. Many incredible people. Roberta Keller is one of our great neonatologists. Sam Hoggood is the head of our whole university now. I'm on this paper, and Craig Albanese actually runs Columbia Children's Hospital in New York City now. But what we found was that the treatment for CDH, the neonatal treatment, was improving. So even though we thought we had picked out very severe CDHs, the prenatal tracheal occlusion in this prospective randomized controlled trial didn't help over standard postnatal care because the standard postnatal care had become so much better, and survival in both groups was 75%. We had predicted that it would be 25% in the standard postnatal care group before birth. This was done through a maternal hysterotomy, fetoscopic tracheal occlusion, so no, I'm sorry, fetal laparotomy, fetoscopic approach, so no hysterotomy, and then we delivered these patients via exit procedure. So then subsequently, our colleagues in Europe, led by Jan de Prest, started doing this all through a small incision, just like we do for some other fetoscopic procedures, and then removing the balloon at a second fetoscopy with only the most severe cases. And you may have seen the report that recently came out that showed in a multi-institutional worldwide trial that there is probably a benefit to tracheal occlusion and unplugging fetoscopically in the severe group, and maybe a benefit in the moderate group. It's controversial in the United States because a lot of the United States centers feel like even without tracheal occlusion, they can get similar survival just with standard postnatal care. But that's a very, I would say, controversial topic. Another disease and the first disease that we didn't do that isn't a lethal disease that we did fetal surgery on is spina bifida or myelomeningocele. There was another NIH-sponsored trial that looked at standard postnatal care, meaning postnatal repair for myelomeningocele versus prenatal myelomeningocele repair. You guys have probably seen the report that was published in the New England Journal of Medicine. But briefly, the primary outcome variable was the combination of death or need for VP shunting by 1 year of age. And other primary outcome variables were developmental outcome and motor function. And really the take-home message was that there was a small but significant improvement in shunting rate in prenatal surgery. There was no difference in developmental outcome, and there was a doubling in the incidence of being able to walk in the prenatal surgery group. So prenatal surgery was better for the children. It didn't cure the disease, but improved things significantly, but was obviously not a cure. That had to be balanced with the fact that the women would need C-section delivery after each subsequent pregnancy because of the risk of uterine rupture. Twins are another condition that we treat. Twin-twin transfusion syndrome is probably the most common, and by the time they reach stage 1, there's about a 50% mortality, and by the time they reach stage 2, there's about a 90% mortality. Monochorionic twins share a placenta, and each twin is different. When they have severe polyhydramnios and oligohydramnios, then often they need treatment. This is based on the Quintero staging for twin-twin transfusion syndrome. Fetoscopic treatment for stage 1 is somewhat controversial, but definitely needed for stage 2, 3, and 4. By stage 5, there's been demise of one twin, and so there is no need to treat. The vessels for the umbilical cord go into the placenta, but some of the vessels cross over from one twin to the other, as you can see in this picture, and then that leads to a net shunting of blood flow from one twin to the other. One twin gets too much blood and goes into heart failure. The other twin gets not enough blood and goes into renal failure. And so this is a autopsy or a pathology picture of a placenta, and you can see in this injection study with the umbilical cords, there's many blood vessels that go into the placenta, and that feeds the fetuses. But in the middle of the picture here, you can see some blood vessels crossing over, and those are the ones that we go after when we treat with fetoscopy. What we do is we go in with a 3mm scope. We use a laser to divide the blood vessels that go from one twin to the other, leaving the normal vessels that feed the fetuses alone. When we do this, it has a much higher rate of survival, with about a 70% both fetuses survive, about another 15% only one fetus survives, and about 15% of the time you still have demise of both fetuses because of the severity of twin-twin, or they deliver too early. Obviously, like many places in the world, we now use ultrasound and MRI, and the MRIs and ultrasounds are used in conjunct with one another and very complementary. Some of the research of the future, led by my partner Tippy McKenzie, are using advanced diagnosis with genomics, but also treating not anatomic defects, but cellular and molecular defects. A lot of things are being done at UCSF. My partner Tippy McKenzie has just become the whole director of the Stem Cell Institute at UCSF, and treating a variety of diseases with cellular and molecular therapies that really is the way of the future, and not just limiting to anatomic defects, including using maternal stem cell transplant for a variety of diseases. Another thing that we are focused on is really long-term outcomes, because when we do these fetal treatments, we're left with children that survive but may have whole different conditions than what we're used to. And so our life clinic, or the long-term infant to adult evaluation and follow-up and evaluation clinic, is the first of its kind and funded by the state of California to see patients with severe anomalies. And we're really devoted to the lifelong care of children with complex birth defects. And when I think of our fetal center, we have the duality of research and clinical care. And what at one point starts as research becomes clinical care, and then we do further research on it and then develop new strategies for it. And so it's sort of like the yin and the yang of the hospital and the university working together, keeping the mom, the fetus, and the neonate at the center of things. There's a variety of current studies going on, as I was mentioning, for CDH, amnio infusion for renal failure, and many other things, including fetoscopic repair for myelomeningocele, which we're not doing, but many other centers are. So I'll stop there, and I really appreciate your attention. I know I covered a lot of ground, but I greatly appreciate being able to present, and I appreciate your invitation. Thank you very much.
Thank you, Dr. Lee. It was an excellent, and we all, there are 165 and 40 auditorium. We have few questions. I'd like to ask first question, that how you will decide in PU valves whether you want to put you want to do vasectomy or put the catheter or do fulguration of valves?
I can't hear you so well, Professor Shaw. There's an echo, and I couldn't hear you so well. Could you repeat the question, please?
In PU valves, how will you decide about in which patient you will do vasectomy catheter insertion versus fulguration.
Okay, so I think the question is for posterior urethral valves, what treatments do we use? And I think increasingly the most common treatment is becoming shunt placement. I think that's what's done most. I personally feel like it's not a great treatment because you then have lifelong urinary tract problems because the bladder becomes shrunken and compressed and you don't get adequate cycling. They need bladder augment. And so we are trying to do minimally invasive approaches. And one of the things that we've done with a few successes, but not really able to reproduce it, is placing a curved needle into the bladder, only under ultrasound guidance, placing a wire through that needle, through the bladder, to the urethra, out of the penis, and then placing a balloon catheter over there and dilating that. I would have to say that that is one of my goals before I retire in maybe 5 to 8 years, is to be able to perfect that procedure because I feel like the other procedures that we offer work but aren't that good. So I would say that I'm still not really happy with all the procedures for urinary tract obstruction, which probably is the reason why you're asking the question of what we do. So thank you for that.
Dr. Hello, Dr.
I'm sorry I lost you, sir. Unfortunately I lost I can't hear you. I don't know if others can hear me still. Any other questions, or happy to entertain any other questions. But I also suspect that we're running late on time too. Let me see.
The question I was, this is Dr. Mohanabram from Cochin. The question I
Yes,
was
sir.
asking is, one in our center, one of the problems we find is at the moment, the sentinel criteria for fetal intervention in PUV is oligohydramnios. So the mother comes to us, say at 20 weeks, 23 weeks, there is no oligohydramnios, urine parameters are normal. So we tend to wait, and then by 26 weeks, then they go into oligohydramnios. At that point, we cannot do fetal cystoscopy because of the angulation of the urethra. So
Yeah.
now Roano and all group has suggested that we should, not only the oligohydramnios, but if there is parenchymal changes to the kidney or increasing hydronephrosis, that should be form a criteria for intervention. Do you agree to that?
Yeah, so thank you. I think that that is a really excellent point. And I think one of the great frustrations with urinary tract obstruction, posterior urethral valves, is that if you're too aggressive in treating, then you're probably treating many babies that won't need it. If you're not aggressive enough, then you end up not being able to treat them because of progression of the disease. So I think that basically that the biomarkers that we have to assess the severity of the disease aren't good enough right now. And what we need ultimately are better biomarkers. I don't know whether it's, we've done a lot of research in this, and actually there was an Italian group that showed that different types of collagen are increased in urinary fluid in fetuses and neonates before changes in electrolytes. And that's something that we found also. And so I just think that we need something better, because I don't think, it's sort of like, appendicitis, before we had good ultrasounds, and before we had, it would probably be like treating appendicitis in the 1800s. You would take out many normal appendix, or, if you didn't treat them, then many patients would get very sick. So I think that is the fundamental problem. And I share your frustration with, the whole area. And that's why I also think that a needle-based approach, because it's minimally invasive and because it augments the bladder tap that we're already doing, I think ultimately would be the best thing, because it wouldn't be very invasive. But it is a difficult thing. I share your frustration.
Thank you. Thank you. Another question I have is, do you use amnio patch?
For myelomeningocele?
No, for amnio patch, because one of the problems we have is amniotic fluid leak. So do you use amnio patch? You put what you call platelets and cryoprecipitate, and then
we haven't. I would say that hasn't been, for whatever reason, maybe we don't have a huge problem with amniotic leak in our cases.
Yeah, but we have lost some babies after fetal and after even PUV ablation. But we are using the curved fetoscope for laser ablation.
Yeah.
I mean, maybe a needle technique will be a much better option.
Maybe so. Yeah.
Thank you.
Thank you, sir.
The last question is in CDH. Hello.
Yes.
Yeah, in CDH, what is the evidence today of criteria or predictor on sonography, in which patient it will be useful, and what we should advise to the parents?
Yeah, I think that is, again, there recently was the publication from Depressed and others in their worldwide group of the total trial, the severe and moderate trial, the moderate groups. And I think in the United States, there is some thoughts that the survival from the worldwide study for the non-fetoscopic group seem very, very low. But I actually feel like if you have a CDH with an ODE of less than 25%, which is the severe group, I do feel like there's a survival benefit. And so we would offer tracheal occlusion for the severe group, ODE less than 25%. I think for the moderate group in the United States, I don't think it makes sense. I think the survival in the moderate group is, I don't think that there will be a survival benefit in that group.
Thank you, Dr. Lee. Thank you, Dr. Lee, for an excellent talk, and we all have enjoyed it well. And I think the pioneer work done by the center started by Dr. Harrison has saved thousands of fetuses by, in last 30, 40 years. And we have also started fetal medicine center in Mumbai. And we are early. We have done 2 TTTS syndrome and 1 PU valves, posterior urethral valves. So with this, we will conclude this talk. And I will invite our next chairpersons to take over. Thank you, Dr. Lee.
Thank you so much, and I really appreciate it. And it's been a pleasure. So thank you so much.
Thank you. Next up here.
Okay, we go on to the next speaker and the next topic. And it's a pleasure to introduce Dr. Sunil Shroff. He's a senior consultant in urology and transplantation at Madras Medical Mission Hospital at Chennai. And he's the managing trustee of Mohan Foundation, which is a NGO which is pioneering organ donation in India. And he's been the past president, Nephrology, Urology and Transplantation Society of SAARC countries. And Dr. Shroff will be talking on future of organ transplantation, the ethics and the practice in India. Over to you, Dr. Shroff.
Dr. Shroff, are you able to hear us? Yes, can you? Yes, we can hear you. Yeah, we can see your screen now. Yes, Dr. Shroff, you can begin. There is some slight hitch. We can't hear you. Can you test the mic, Dr. Shroff, please? We can see your screen, but we can't hear you.
Can you hear me now?
Yes, you can. We can hear you now, Dr. Shroff.
Well, I was not unmuted, that's why. Anyway, now I'm unmuted.
Wonderful.
So, thank you. So
Can we go full screen?
this is full screen on my this one. Is it not on yours?
No.
Okay, let me go back again then. Give me a minute. Is this full screen now?
Clearly. No, there is. I can't see your screen.
Okay, give me a minute.
I can see you.
Yes, 1 second. Can you see the full screen now?
Yes, wonderful.
Thank you. Let's get started.
We can see the full screen now.
You can see the full screen, yes?
Wonderful. Yes.
Thank you. Let's get started. I think we're running a little late, so I'll try and see what best I can do. Over the next 30 minutes, I'm going to give you some perspective on ethical consideration of organ donation and transplantation in India and its practice. And thank you for the introduction and thank you for inviting me. I'm going to look at three aspects, basically, the ethical consideration and the practice, and then the way forward, looking at the future. If you look at the global scenario today on kidney disease, many of the estimates of screening in many countries have shown that 10% of the adult population have a marker of kidney disease. So chronic kidney disease is becoming an important contributor to the morbidity and mortality for non-communicable diseases. If you look at the global activity of transplantation in about a couple of years back, you'll see that we do about 100,000 kidney transplants every year, 35,000 liver, 8,000 heart, and so on. Although we do 153,000 solid organ transplants, it only takes care of 10% of the global needs. So there's a huge shortage of organs, and there's a huge gap between demand and supply. And most of the transplants happens in the developed world, but the majority of the population live in this not so developed world. So there is a disparity. And so the gap, this is a slide which shows the widening gap between demand and supply. So this is the demand of organs. This is from US. It's similar in most countries. And the supply is here on the brownish bar. So there's a huge gap which keeps increasing. And that is the reason why looking at the ethics of organ donation and transplant is so important. And if you look at the principles of ethics today, which we look at, which we generally discuss, The first one is do good to the patient, do no harm, truthfulness, justice, confidentiality, and autonomy of the patient. In doing good, the first priority when it comes to organ donation is there is a donor who is not a patient, who is a normal person. He is donating an organ through, for doing some good to somebody else. So safety of donor is, very, very important. And we need to keep that in mind. By and large, the, kidney donation is a very safe procedure. If we investigate a donor well, the long-term effects on health is minimum. However, in India, the incidence of diabetes and hypertension is rising very rapidly. And if somebody very young donates who doesn't have diabetes, hypertension, we don't have any study in India to know what would be the incidence of this in those young donors later on, and how many would lead to kidney failure. So this is a point of worry in trying to do good. The next one is do no harm. But we know that any surgery has some mortality, however minimum it may be. And in living donation, a nephrectomy, the mortality estimated in most of the literature is 1 in 3,200 donor will die. This may be acceptable, but when it comes to living donation of liver, the death of donor in India is perhaps about 2%. It's internationally accepted as 1%. I think in India, initially at least, it was slightly higher. And the morbidity, the long-term morbidity can be as high as 30% in living donors of liver. So the worry is, why are we doing this living donation in liver? When, a donor is a normal person, he's not a patient. You're not trying to save a life of a patient. That donor is doing out of altruism or love or whatever. So is this ethically acceptable? And the third principle is tell the whole truth, free of conflict, duty to warn the patient. So in case of living liver donor, when the mortality and morbidity is high, why is this risk acceptable to surgical fraternity? What kind of consent form we should devise to tell the truth? Should this risk be quantified in the consent form? Should this type of donation be allowed to continue? The fourth principle is justice. Don't discriminate. Respect and support. Follow all laws. Let's take a look at a case history, to see on justice, how it works. Let's take a 2-year-old severely sick child with biliary atresia and needs liver transplant in a government hospital. The procedure will cost to a taxpayer anything between 15 to 20 lakhs. Should we spend this kind of money on one case when the same amount can be spent for eradication of some other disease like polio and malaria and all that? Generally, in a poor family, a severely ill child is viewed as a medical and economic liability. You pediatricians will know it better. And they'll allow the child to die so the family can have another child. So should they let go if they can't afford? Is this justice acceptable as a society? I don't think so. The liver or kidney transplant surgery is expensive. So one can argue that one should, try and, spend the money of the country, especially if it comes to government money, to some other areas of prevention and saving children with having diarrhea, malnutrition, and so on. The next comes confidentiality. I'll tell you another case history which I encountered. I had a 35-year-old kidney failure patient requiring a kidney transplant. A 32-year-old recently married brother was projected as a donor. He was a real brother. All investigations were done. Case goes through all formalities. Brother, after everything is over, 2 days or 3 days before the surgery, brother and wife came to me and asked me that the wife was very worried with the donation process, and she it was not happening with her consent, and she was not happy to donate, but they were under family pressure. So they requested me to reject the donor on some medical grounds. So I was in a big dilemma what to do here. On whose side should I tilt? The choices I had was ignore the request. Go ahead. I couldn't do that. Accept the wishes of wife, reject the donation. That again was ethically challenging to me. Or accept the wishes. So what I did was, I mean, I could accept the vision, send them to psychiatric evaluation, but that also was not acceptable to me. So I thought of a plan. I counseled the wife and husband, explained to them the risk of donation. And then I got another living donor family, any living donor, recipient, donor together, and made them speak to them to understand the risks and to show them the quality of life after kidney donation and the recipient's happiness. And I told them, go and speak to this family and come back and talk to me after 48 hours. And that resolved the crisis, and the wife accepted and went ahead. Autonomy. Patient has right to make their own decision and choices. And this is the actual problem now at the moment, as far as our field of outreach is concerned. Especially with information technology being available, internet being available, there's so much exchange of information. And this has led to a lot of shift of looking for donors online. I'll give you an actual case history again. There's a gentleman in England, 45-year-old with chronic kidney disease, waiting for a transplant. The waiting list in England was 4 years to get a cadaver kidney. He had no relatives. So he spots on internet a hospital website in Sri Lanka, which is advising for arranging for transplant, by providing young donor. So the gentleman in UK contacts the hospital in Sri Lanka, goes to Sri Lanka, gets a transplant successfully. He beats the healthcare system in UK, pays the donor family, gets back to UK, and is back to work in 3 months. So this is self-determination, autonomy. And this autonomy is the one which is, causing problems as far as living donations are concerned. So the question here is, exploitation of poverty in Sri Lanka was done. Is this acceptable? WHO is also, many international transplant societies are worried about its cross-border medical tourism, which is on the increase. And wherever you have, low human development index, high poverty, there is, commercial organ donation, child labor, prostitution flourishes, and some of these countries are very vulnerable to organ commerce. On eBay, many years ago, there was a sale going on for a kidney, and the auction went up to 1 million before it was stopped. So for kidneys, they generally said one to care and other to spare. So selling a kidney is a very attractive option in a community with high poverty index. In fact, in China as well, you have execution of prisoners. If you take the argument that you should pay a donor, why should you pay? The transplant business is very big, whether it's in US or even in India. Almost 8 billion in US, 500 crores in India. And the main driving force for this business is organ donor and donor families. And organ donors, however, do get no money. If they don't get money, is this acceptable? So the feeling is the donor families deserve something in return for the valuable contribution to the society. But there are strong arguments against it as well, because if you put money into place, then it devalues altruism. So there are strong concerns against financial incentives. The Transplantation of Human Organ Act, which is the law in India and similar laws across the world, consider this illegal, this valuable consideration to donors. Because compensation can coerce poor people to donate to the advantage of the rich. It's very rich, very rare for a rich person to donate to a poor. There have been a few examples, not that there have not been, but they're very far and few. There's so strong arguments against compensation. And compensation has made a kidney a commodity and has created a black market. Even if you want to give compensation, how much should a kidney be charged is another question you all need to ask. Most of the donors get about 50,000, 1 lakh, 2 lakh, maximum 3 lakh, nothing more than that. So let's look at how much actual cost of a kidney should be. The normal span of a kidney transplant is average 10 years. And if you get the cost of kidney to the cost of dialysis, how much will it work out? Just do a calculation. If you cost the dialysis 2,000 rupees, 3 hemodialysis per week, 4 times a month, 12 times a year, 10 years, the total cost comes to about 28 lakhs for 5,760 hours of dialysis. But a kidney works 24/7. It doesn't work just for 4 hours as it is done for dialysis. So that if you compute that cost, the actual cost will come to about 4.38 crores. This is just the cost of transplantation. Doesn't include investigation, drug, and all that. So if you actually want to value a kidney on the market, the minimum value of the kidney should be 4 crores, nothing less than that. There are some interesting papers on financial considerations. And this is a very good paper in JAMA from Madhav Goel. And he did a study in India. And his conclusion was, among paid kidney donors in India, selling a kidney does not lead to long-term economic benefits and may be associated with the decline of health. What was seen was, then when you donate out of love or true affection or altruism, the good feel factor is there. But when you donate out of the money, there's no good feel factor. So the donors, after donating the money for money, they get depressed after some time. They're not able to go back to work. They are mostly people who do hard labor, and that leads to, they doesn't give them any benefit and actually leads to psychological disadvantage as far as their health is concerned. So this is about the ethical aspects of organ donation and transplantation. Over the next 10 minutes, I'm going to talk about the transplant practice in India and South Asia, and then we'll talk about the way forward. I've taken South Asia because we have similar problems. There's 8 countries. South Asia has only 4% of the world landmass, but has 1/4 of the world population, 5 times that of US. It's the most densely populated part of the world. Our incidence of kidney disease is 232 per million. What it means is, if I convert into numbers, we require almost 400,000 kidneys per year to transplant in this region, but only 95,000 will receive some kind of renal replacement therapy in the form of either dialysis or transplant. So you're not even covering 1/4 of the population as far as you giving them help is concerned. There are also risk factors in an access in South Asia problem, because biologically in Indians, because of low birth weight and genetic predisposition to kidney disease and inadequate nutrition, our nephron mass is less compared to the Western world. There's also, environmental factors like increase in pollutants, increased exposure to communicable disease, lack of clean water, and there is, limited access to healthcare because some of them people have to travel great distance to reach a tertiary care, and they don't have a health insurance, so the expenses are out of pocket. So there's limited access in healthcare. So the disadvantaged population of the region reacts very slowly to illness due to lack of access and knowledge. There is also other barriers for organ donation and transplantation in our country. There's mistrust, there's acceptance of brain death concept, religious and cultural aspects in organ donation. If you actually look at, the dialysis, the limited access to dialysis and transplant surgery, if the whole region, if you look at, we did this calculation some time back, and this is a busy slide, but all I want you to do is concentrate on the lower, on the total. We have, 2,850 dialysis units in which we have about 15,000 dialysis machines being served by about 2,000 nephrologists. We have 1 nephrologist per million population compared to 40 in Spain and 28 in US. So lack of trained manpower and infrastructure hampers preventive measures of early diagnosis and prompt management of chronic kidney disease. In the region, 5 of the 8 countries do disease donation. 5 of the 8 countries do living organ transplant. 2 of the 8 countries do disease donation. India is the only country in the region which does multi-organ transplant, including hand transplant and uterus transplant, by the way. And this is a young lady who had hand transplant in Kochi. If you look at the organ transplant rate in this region, again, this is a busy slide, but look at the lower part. The population is about 1.7 billion. The kidney transplant, the average age is 8 per million. And the number of transplants we do is close to about 40,500 in the region. And I told you earlier how much is the requirement. Almost 400,000, against which we do only 14,000 kidney transplants, and the rest of them get some form of dialysis. This is a slide from the Global Observatory on Donation and Transplantation. And if you look at these slides, you have some bars showing, different color bars. Most of the Western world, and advanced countries do most donations are disease donation. The yellow is the living donation. You see here, the US, the North America. But in Southeast Asia, if you see, most of donations are leaving very few disease donation. So there are, there are societal issues which are barriers in donation. I told you earlier there is mistrust in healthcare system. The private healthcare, along with media, perpetuates this mistrust further. There's misconception of brain death. Doctors, they say doctors will not save life of a loved one if I say yes to donation. There are some religious and cultural barriers. This is a study in Times of India done with Mohan Foundation in 2015 of 8 large cities to look at the mistrust in healthcare system. And what they found was that all those who were aware of organ donation but had not signed up for a donation, almost 43%, the reason was in 29%, it was if I agree to donate my organs, the hospital staff won't work hard enough to save my life. Maybe I won't really be dead when they sign up for death certificate, almost 32%. So the mistrust is very deep. And this mistrust is perpetuated further by movies in our movies and television in our country. The Mohan Foundation staff did a talk to an IT company some time back, and the employees did not want to register for organ donation. When we asked them why, they had a movie had been released, and that showed that organs were being stolen. So, the staff were worried that the organs would get stolen. So the HR head very reluctantly had written all the donor card, although very enthusiastically he called us for a talk. And then there are personal beliefs that rich and famous will go on top of the list when they need an organ donation. That also is there among the youngsters. Sometimes language used in the ICU is not right. When you're counseling the donor families, where there's a brain death in ICU, when the ICU doctors are counseling, the language used is kept alive for organ donation. If he's alive, why should he donate organs? Why can't you save him? Kept on life support instead of saying artificial or mechanical ventilation. So this kind of language provides hope to the relatives and creates, sometimes this creates mistrust because of poor communication. There are some cultural reservations. Most religions believe in organ donation. But among the Hinduism, Buddhism, Jainism, Sikhism, there is a belief of rebirth. Sometimes people will feel that they won't be born in the next life with that organ. Among the Muslims, the disease donation rate is low in South Asia because they feel the removal of an organ violates the sanctity of the body. In fact, one of the Muslim families who donated didn't want anybody to know that they donated the organs for their son because of the backlash they feared. But we did a study in one of the government hospitals in Chennai, and we had about 188 brain deaths where we had 58 who said no to donation. Religion as a cause for saying no to donation was only 24%. There are other reasons for not donating, and one of them was mistrust. The other barriers is knowledge deficit. There's a poor knowledge among organ donation, not only among the public, but also among the medical professionals. They don't understand brain death that well. There's also a barrier in the ICU because the counseling of the family by trained staff is not done in the ICU. There's also lack of surgical training in retrieval, how to perfuse, and so on. So what's the way forward in all this big scenario? What we need to look at is the first is the public willing to donate? Most of the times people say when the doctors feel the public will not say yes to donation. And that again is wrong. And I'll show you why. The other thing is what is the potential of brain death in India? And what we require is capacity building and how we can do it. What's the current state? Let's look at that very briefly. Let's look at the other, kind of barometer of corneal donation in India. Corneal donation in India is almost 70,000 every year. In Sri Lanka, since in 1961, when Eye Donation Society was launched, it has donated 54,000 corneas to 57 countries. They donate corneas to China, Pakistan, all over the world, in fact. So corneal donation is high in parts of South Asia, especially India, Sri Lanka, Nepal, Bangladesh have an eye donation program. And most of the donations come because families initiate the conversation and they ring the eye bank and say, we want to donate organs. In India, 96 families donate their corneas of their loved ones every day. That is 38 per million population. 30,000 people donate blood every day. So will to give is there in the society. If provided we can restore some trust, provided we can, support the families in a conversation for organ donation. Because there is a lack of equity, imbalance between the private and the public sector hospitals. Most of the cadavers or diseased donor pool in the private hospital is very limited, and most of this pool is in the government hospitals because most road traffic accidents land up in government hospitals. But the government hospitals do very less transplants because of the lack of infrastructure support, not that they don't have skilled staff. By numbers, if you look at India, there's the highest number of kidney transplants. But if you look at per million population, it is low. Requirement is very high. So as I said, we need to restore the equity and we need to look at our pool of brain death. We need to get the government hospitals to start doing transplants so that when there are donors, they can also get those donations happening. And so the less affordable, start getting also transplant. And then if we restore this equity, then the distrust will go away slowly. We also have models of excellence in this part of the world. We have the Sindh Institute of Urology and Transplantation in Pakistan. This is Dr. Rijvi. He's doing a tremendous work. All transplants, he does about 400 transplants every year. Everything is free in that hospital. There's no cash counter. We also have in India examples of Sathya Sai Center, Sathya Sai hospitals in both in Bangalore and Puttaparthi. We have IKRDC in Ahmedabad, the Institute of Kidney Disease. We have Tanker Foundation in Chennai. We have National Kidney Foundation in Bangladesh. They're all doing tremendous work. National Kidney Center in Nepal, all examples of excellence. Then, of course, the Sri Lanka Eye Donation Society, established by Hudson Silva. The president himself donated his corneas in Sri Lanka and set an example. What we need also is to do some social re-engineering. We should educate the public, of course, but we also need to educate our doctors and paramedical staff on disease donation. The failure of donation, especially disease, is because, as I said earlier, that most hospitals concentrate their efforts on organ transplant, but not much on, organ donation. So you need a trained hospital coordination team to manage a potential donor in ICU. You need to be proactive in referral, and you need a transplant coordinator to obtain consent. So the hospitals need to create a hospital level committee which guides them for all these donations. And a successful model requires everybody to work together, the government hospitals, the private hospitals, the public at large, and the NGOs. We wrote this article in American Journal of Transplantation recently that in India, we require bold policy changes to meet the need for organ transplant in India. And what we recommended was that the potential of brain death in India is huge because we have almost 8.4 million deaths every year. 1 to 4% of such deaths are due to brain death. That translates to about 84,000 to 336,000. We have high road traffic accidents. 67% of road trauma, leads to some kind of head injury. So we have 400 deaths every day, almost 147,000 fatal road traffic accidents in India. As I said, 67 head injury. So potentially we have almost 90,000 brain injuries in India, and many can be converted to brain death and organ loss. We also need to, so in this area, we need to understand that, we need to, train ICU staff for brain death certification and maintenance, how to request for organs, train the transplant coordinators, train the surgeons, as I said earlier, and also to sensitize the police. And how do we do that? As a foundation, we have trained 2,700 coordinators in the last 7 years. We also had 14 workshops for organ donation in ICUs. We are trying to do our bit. We also conducted 6 surgical workshops with one Dr. Sonal Asthana in Bangalore in the MS Ramaiah Medical College. And we have trained surgeons for heart, liver, and kidney transplants, especially from government sector. So as an NGO, Mohan Foundation does awareness, training, counseling, and networking with the government. One of our key areas is training of transplant coordinators. Coordinator is a key person who coordinates with the donor families, the recipients, with the police, gets the consent, does everything on the ground, because as doctors, we're very busy. We don't necessarily have the time. So we undertake training program for transplant coordinators regularly. And their consent, their speaking to the family triggers the whole donation process, but they start the conversation with the family. This is an example of our one success model, which we started in 2010. We signed a memorandum of understanding with the government hospital in Chennai, and see what happened in 10 years. 299 brain tests were certified, 291 families were approached. 198 families said yes to donation when a trained transplant coordinator spoke to the family, of which 136 went on to multi-organ donation, 66% conversion rate. And in one hospital, from one hospital, we got so many organs, multiple organs. In fact, so much so that one of the transplant coordinators was a heart transplant recipient. She got a heart from a government hospital, so she came to do a course in Chennai. So we put processes in place in hospitals as well. This is a long list. I don't want to go into the details of it, but this is what the transplant coordinator is trained to understand each step and to take an action accordingly as required. Since the COVID, we also have started some online training program. As I said, we have trained close to about 2,700 or almost 2,800. We do face-to-face, and we have also started an online training program. The online training program has become very popular. We've trained 348 over the last 1.5 years. And because of the low cost, we are getting coordinators from surrounding countries, from neighboring countries getting trained, including Spain, in fact, coming for this training program. We have an online training program on Moodle, which is a free source. So we have multiple programs for transplant coordinators, for grief counseling, for surgical retrieval, which is all done online. We have an MOU with the Oxford group, who come as faculty for organ retrieval workshops, which we do, and 6 workshops which we have done. We have an MOU with NHSBT as well, which I signed in House of Lords to bring good practices back to India. These are some of the surgeons who got trained at MSS Ramaiah, Advanced Learning Center. This is a faculty from England, Dr. Rutger. And the impact of surgical training is so much that 18 heart transplants was performed in 2 public sector hospitals. This gentleman from Madurai Medical College, had never seen a transplant before. He came for the training program and performed the first heart transplant program in Madurai Medical College. This is our total transplant activity in the country for all kidney, heart, liver, lung, pancreas transplant. The numbers are going up slowly, as you see, from 2008 to 2019, the green bar is going up. Last year was a bit of a dampener because of the COVID, but we're doing more and more transplants with better training and so on. And our donation rate has gone up almost 4 times in the 5 years from 2012 to 2016. If you see, these are the donors, 196 in 2012 and 723 in 2016. So the line went up. And so equally the liver donations happened, kidney donations happened, heart, lung, all kinds. I'm almost coming to the end.
Hello.
Yes, this is
Dr. Shroff, the time is up. So can
Yes.
we sum up in the next minute or so, please?
That's where I'm coming to. So we do 3 multi-organ disease donations every day. And we are also creating communal harmony because Hindus are donated to Muslims and swap donations happen. This is if you are living in Jaipur, do visit this. This is a donor memorial for the organ donors of the country called Angadata Circle, inaugurated last year. This is my team in various cities of Mohan Foundation, which is working very hard to make this program happen. Thank you very much.
Hello. Thank you very much, Dr. Shroff, for a wonderful talk. And we are proud on behalf of all the pediatric surgeons of India for the people like you who are doing such pioneering work for this transplantation. One quick question is that you said normally there is a life of about 10 years for the transplanted kidneys. From a pediatric perspective, do you have any solutions for the long-term outcomes that we expect in the child? And what is the future in terms of tissue engineering that's happening in India on transplant counts? Thank you.
Yes, thank you for this question. Pediatric transplant, I'm very passionate about it. And, we have tried to make policy where we have pediatric donors as well, by the way, disease donors. So we're trying to tell the government that a pediatric donor kidney or liver or heart should go to a pediatric patient. In fact, so much so that some of the parents of even, as young as 2 months, have come forward. Anencephalic kids. We had two, requests from parents who had an anencephalic kid. So I think there is an opportunity here to develop a pediatric transplant program. We are doing pediatric heart transplants as well. Liver we are doing, kidney we are doing, but we're not doing enough numbers. And the numbers are not there because we don't have enough units. And also because it's not supported by any kind of insurance, unfortunately. So opportunity for pediatric transplant is very big. And I think, I myself have done maybe about a dozen cases in all my span of 20 years in India. I could have done much more. But as I said, the opportunities are lacking. And there are very few dedicated pediatric transplant centers. And I request this August audience to look at this as well and help us to develop more centers so that there is a future for the kids. The second question is tissue re-engineering. You're absolutely right. The ethics of this century is not about what we can do. The ethics is, should we be doing it? To be honest. Now, should we be taking fetal tissue, aborted tissue to treat Parkinson's? All kinds of tissue engineering. I did have a few slides, but because the subject is so big, I unfortunately could not cover. Yes, stem cells is being talked about. Tissue re-engineering is talked about. We're also talking about, the kidneys taken from the pigs and doing xenotransplants. And this has been around for the last 15 years. But with all this pandemic of viruses coming, are we going to import some of these viruses from animal kingdom to human kingdom? And how sure can we be that these viruses will not be a vehicle coming in if we do take these kidneys from pigs? The transgenic pigs are being, done, in Oxford and in some of the centers in Europe. Very, very lot of research is going on, but we still haven't overcome still don't understand the internal milieu. We still don't understand the immunological problems which we can encounter, which we still cannot overcome the rejections. So there are a lot of these challenges, but tissue re-engineering is definitely attractive. You'll be happy to know that the first organ to be completely regenerated has been the bladder. The nephron, one of the nephrons also has been tissue engineered in Wake Forest Hospital, in their research center. So I think give it another 10, 15 years, we might have a solution. But do remember one thing, it'll come at a cost. It's not going to come cheap.
So much, Dr. Shroff. It
Yes.
was a brilliant talk and an eye-opener for all of us. So on behalf of the Indian Association of Pediatric Surgeons, Professor Arvind Sinha and me, Dr. Rajiv Redkar, thank you for delivering this wonderful talk.
Thank you, sir.
God bless.
Thank you.
I call upon the next speaker, next chairperson.
Other than Dr. V.R. Ravi Kumar sir, and we all know him. We all have been his students. We have heard him in conferences, orations, and the topic he's going to talk about is acid-base PG interpretation for pediatric surgeons. Something even I would like to learn from him today. and many times more in future. I tend to believe that probably we need to have some ICU courses for the pediatric surgeries residents, maybe in few institutions, because this is something that we need to spend time on to get hang of things. So with all that, with my co-chairperson, Dr. Kuril, Padam Shri, Dr. Kuril, I invite Dr. Ravi Kumar to start his lecture, please.
Dr. V.R. Ravi Kumar is teachers of teacher. Doesn't need introduction. Anyway, formerly he was professor of pediatric surgery, Coimbatore Medical College Hospital in Coimbatore. And he has been past president of Indian Association of Pediatric Surgeons. And has contributed chapters on acid-base balance, fluid and electrolyte. And in various textbooks, written a book on PSD also. So we look forward to wonderful lecture by none other than Professor V.R. Ravi Kumar. Good morning, sir.
Good morning. Are you able to hear me now?
Yes.
Yeah, I can hear you.
Yeah. Thanks, Dr. Ravi Ramadwar, Ravi Kanoja, MR, administrators, and Dr. Sarin and Dr. Kuril. I'll try to confine myself to the basics of acid-base balance and interpretation of arterial blood gas analysis, which is ill understood by many postgraduates because we are not posted much in the ICU setup. Now, primarily, acid-base balance is hydrogen-ion balance. The major clinical problem that you face is the overproduction of hydrogen ions, either by the endogenous disease like diabetic ketoacidosis, renal tubular acidosis, etc., or by the addition of exogenous acids like poisoning, like methanol poisoning, salicylate poisoning, isonitrotic acid hydrozide, or iron poisoning, etc. Now, these produce changes in your blood, which alters your pH. And when the pH is low down, it's acidemia. When it goes up, it is alkalemia. Now, the process which produces that is called acidosis, which it involves the respiratory system, can produce a respiratory acidosis, respiratory alkalosis, which we will deal a little later. And then similarly, when it happens in the metabolic acidosis, which is primarily metered by the kidney, and metabolic acidosis and metabolic alkalosis. The problem in interpretation of arterial blood gas analysis is how to arrive at mixed acid-base disorders so that you can adjust your ventilators, drugs, etc. in the ICU setup. Now, daily activities produced untold amounts of hydrogen ions in your body. And then, but in the body, the strong acids and strong alkalis that are liberated during metabolism are neutralized by weak acids and their conjugated salts, like your soda bicarbonate or disodium monohydrogen phosphate, monosodium dihydrogen phosphate, etc. So these are bicarbonate and carbonic acid. Since the carbonic acid level depends upon the partial pressure of the carbon dioxide in your blood, it can be rewritten as a bicarbonate and carbonic acid. If you have a metabolic acidosis due to low level of bicarbonate, your carbon dioxide gets washed out. Now, carbon dioxide can also get washed out in a respiratory alkalosis. Now, the problem in an APG is to find out, is it as a result of compensatory mechanism or as a result of disease process? Now, if you see the hydrogen ion concentration in nanoequivalents at 7.4 is a normal pH, it is about 40. But when there is a drop of 0.3 in the pH towards the acid side, it is about 80 nanoequivalents. It is about 40 nanoequivalents more. But a similar drop at the alkaline side, 0.3, it is only 20. So that means in acidosis, you get a more hydrogen ion disturbance compared to alkalosis. Hence, acidosis is more important and more serious problem than alkalosis. When a disturbance produces more acids or strong acids or strong alkalis, they are neutralized by what is called buffers. These buffers may be immediate, produced by the bicarbonate carbonic acid mechanism or a hemoglobin buffer mechanism. Respiratory, which comes a little later, but very soon. And finally, the main compensation is developed by the renal system by the phosphate buffer or proteinate buffer systems. Now, bicarbonate is the most important anion in your body. Nearly 5,000 milliequivalents of bicarbonate are every day completely reabsorbed by the proximal convoluted tubules. But this bicarbonate that is reabsorbed is not adequate for normal metabolism. You need to regenerate bicarbonate. The regeneration of the bicarbonate is quite simply done by the glomerulus when, for example, the sodium chloride ion is split into sodium ion and chloride ion, which will combine in the cells where the carbon dioxide combines with the water in the presence of carbonic anhydrase to form the bicarbonic acid. It splits into hydrogen and bicarbonate ion. Ultimately, the sodium will join with the bicarbonate to form the soda bicarbonate, which will get reabsorbed into the body. So simple administration of sodium chloride, for example, in a child with a congenital hypertrophic pyloric stenosis, it can regenerate bicarbonate or in a stage of shock, etc. Similarly, bicarbonate is also regenerated from disodium monohydrogen phosphate, which gets excreted as monosodium dihydrogen phosphate, and in the process produces a bicarbonate ion. So bicarbonate gets regenerated and is the most important ion in the body. How to know from your things whether it is a metabolic or respiratory problem that you are dealing with? See the directional change of pH and PCO2. Now this is, I am putting it here so that you know what the normal equation for pH, bicarbonate and this. See in a respiratory acidosis, for example, a child in whom the endotracheal tube gets blocked, the PCO2 goes up. But when the PCO2 goes up, the pH goes on the acidic side. That means it drops down. So if the PCO2 goes up and the pH goes down, that is, if they are in the opposite direction, you are dealing with a respiratory problem. So that child has got a respiratory problem. On the other hand, if a child has got a metabolic acidosis, now what happens in metabolic acidosis? There is a reduction in the bicarbonate and carbon dioxide gets washed out from the body. Now, once the carbon dioxide gets washed out, and then ultimately the pH also drops down because the bicarbonate is less, and therefore the pH goes down. So if the PCO2 and the pH, the drop is in the same direction, you are dealing with a metabolic problem. So that's how you differentiate respiratory and metabolic problem. How to know whether it is a primary problem or compensatory? For example, the PCO2 of 20 here may be compensatory to metabolic. But if the child has got a hyperventilated and in the ICU, and then the carbon dioxide can get washed and you can get alkalosis. So is it a compensatory to metabolic acidosis or is it a primary alkalosis? How to know that? Now, if the PCO2 is low, is it a primary respiratory alkalosis or metabolic acidosis? See the pH. If the pH is alkaline, it is respiratory alkalosis. If the pH is acid, it is metabolic acidosis. Now, similarly, if the PCO2 is high, it may be as a result of respiratory acidosis, or it may be compensated to metabolic alkalosis. But usually, in a metabolic alkalosis, the PCO2 ranges between about 45 to 50, 55. But if it is 60 or 70, gross changes always indicate respiratory problem. So see the pH. If the pH is acid, it is respiratory acidosis. If the pH is alkaline, it is metabolic alkalosis. So what you need to have is that PCO2, pH, and bicarbonate level. If you have all three, then you will be able to interpret all your metabolic problems in the children properly. Now there is a certain amount of relationship between the chloride and bicarbonate. You know, a condition hyperchloremic acidosis. When the chloride level goes up, the bicarbonate gets eaten away and then it falls down. On the other hand, in a child like a congenital hypertrophic pyloric stenosis, which is losing lot of chlorides, the bicarbonate goes up producing metabolic alkalosis. So there is an inverse relationship between the chloride and the bicarbonate. Keep it in the back of the mind when we interpret ABG for this patient. Now, many of us, when we have an electrolyte estimation, we do not calculate in our ward rounds what is anion gap. Anion gap is the cation is, the chief cation is sodium 142 minus chloride and bicarbonate, and then the normal anion gap is 12. But on the other hand, if there are higher values, the higher values indicate acidosis. But occasionally, you can get an acidosis with a normal anion gap. It is called a NAGMA, normal anion gap metabolic acidosis, which is not a great problem to treat with. This happens in diarrhea, type 1 RTA, then Addison's disease, any bowel fistula, etc., etc. See here, the bicarbonate is low, and then when it is low, it shows it is metabolic acidosis. But the chloride level has gone up due to dehydration, and then as a result of that, the anion gap is only 12. So this is a normal anion gap metabolic acidosis, which is easy to treat. Compared to that, you see here the anion gap is 24, which is significantly high, and it is called high anion gap metabolic acidosis. It is due to methanol poisoning, uremia, diabetic acidosis, formaldehyde, etc., and salicylate poisoning, etc. So the high anion gap needs an aggressive treatment. Now, when you have an anion gap, and then you need to know your albumin level. If the albumin level falls down, for every gram of the albumin level that falls down, there is a correction factor of 2.5. So at that time, the corrected anion gap for 1 gram drop of anion is 12.5. Now here you see for 2 grams it is 5 and 3 grams it is 7.5. So the corrected anion gap is 17.5. For that individual, that may be the normal one, and above that will be an abnormal anion gap inside. Now, this is a one that many postgraduates do not know or understand this problem. Expected PCO2 in metabolic disorders based on measured bicarbonate. That is, if you know your bicarbonate, you know what is the expected PCO2. Expected PCO2 is different from measured PCO2. Measured PCO2 is what you get it from your electrolytes. See, for example, this patient, the bicarbonate level is 12. Add just a constant called 15. Of course, there are some calculations using 1.5 multiplied, etc., etc. I find this is very convenient. Add just 15. 12 for 15 is 27. Now, if the measured PCO2 is 40, even though 40 PCO2 is normal in the normal set, in this patient, this 40 PCO2 is higher than the expected PCO2, and therefore this child has got a respiratory acidosis in addition to this problem. So this is the one It's called the Winter's formula. Now, acid-base balance, remember, most of the problems can be diagnosed and corrected by doing routine electrolytes. Acid base is necessary for children who are acutely ill, who will need ventilation, and those who are already on ventilation. Interpretation of the ABG should always be done with the estimation of electrolytes. Draw blood for electrolytes and ABG at the same time, and if the child is sick, draw blood for liver function test to show the albumin level also, because your anion gap depends upon your albumin level. Now, ABG tells you what are the acid-base problems, oxygenation, and ventilation. Now, we have got what is called the measured volumes. These are measured by pH, PCO2, and oxygen saturation. And then you have also got a calculated data. In the calculated data, bicarbonate level is given. But it is better to use measured bicarbonate from electrolytes rather than the calculated data. Now you see terms are used: ACT, STD, DE, etc. These terminologies you should understand. Now, is a SCO3 standard 30.5. Now, this is the standard bicarbonate. It has been written there is equilibrated by PCO2 40, etc., etc. Forget about it. Standard bicarbonate is the bicarbonate that you see in your electrolyte estimation, in your blood estimation. There's a standard bicarbonate. What is actual bicarbonate? Actual bicarbonate is the standard bicarbonate plus dissolved carbon dioxide. So if your actual bicarbonate is higher than the standard bicarbonate, it will indicate there is more carbon dioxide is dissolved, and therefore the child has got respiratory acidosis. Now you find here is the base excess, it is 6.6. The normal base excess, either it may be negative in acidosis or it may be positive in alkalosis. It is about 2.5 plus or minus. But in this patient, you find it is 6.6. That is, it is on the alkalonic side. So here you found that the child has got respiratory acidosis, but it has been compensated by the increase in the bicarbonate, which takes part by the kidney. But since the kidney takes a lot of time to get the bicarbonate, it indicates that this acidosis has been there for quite some time, and therefore it is chronic respiratory acidosis with metabolic compensation. So that is how you read your ABGs, etc. Now this child has got a pH of 7.8. It will indicate it is alkalemia. Then the PCO2 is 21. Now you see the pH is raised, but the PCO2 is down. They are in the opposite direction. If they are in the opposite direction, you are dealing with a respiratory problem. The child has got a respiratory acidosis. Now, child has got a bicarbonate of 19 milliequivalents, which is quite significantly low, and therefore has got an acidosis. Now, see the anion gap is 28, again indicating acidosis. So this child has got a metabolic acidosis with respiratory acidosis. Now, this is a fellow who has got a diabetic, who was about 70 years, had a cardiopulmonary arrest. You see the pH shows acidemia, and you can see the PCO2 62 is quite significantly elevated, and then pH and PCO2 are in the opposite direction, and therefore has got a respiratory acidosis, and then the bicarbonate is low. That less than 15 means metabolic acidosis. Base excess is 11. Again, it indicates a negative base excess means acidosis. Anion gap is more than 12. Again, acidosis. So it will indicate, see the HCO3B anion acidosis. So this child has got metabolic acidosis with respiratory acidosis, because the patient had cardiopulmonary arrest. Now see here, the pH is 7.50. That means what? It is alkalemic. Now PCO2 is 29. It is washed out. PCO2 is washed out, and therefore is it a primary respiratory alkalosis? Because you find it is respiratory because the pH and PCO2 are in the opposite direction, and therefore you got a primary respiratory problem. So this, but the bicarbonate is normal. It is a normal level. That means it is not compensated. So if it is not compensated, it is an acute respiratory alkalosis. Now again, some more. Acidemia, 7.25. PCO2 is 19.3. Bicarbonate is 12. So the bicarbonate is 12. pH is 7.29. PCO2 is also low. That means it's got a metabolic acidosis. But is this PCO2 that is there, is it got a, has it got an additional respiratory alkalosis in addition to the metabolic acidosis? That's the question that can be done by Winter's equation. What is Winter's equation? Add to the bicarbonate 15. If you add 15 to the bicarbonate, it will become 27. Since the expected PCO2 is 27, but the present CTO2 is 19, it is much less than the expected. He has got a respiratory alkalosis in addition to metabolic acidosis. So that's the one. So you find here metabolic, is there a respiratory alkalosis? You find that is 27. Since the measured PCO2 is 19.3, expected PCO2 is 26, the child has got a metabolic. So that's the one. So this is the last couple of slides. Now you find here, this is an acidemia. Now there is a rule that what is your pH? 7.40. What is your PCO2? 40. So the last two digits of PCO2 and pH are same. That's because they are compensated. So now see here, the pH is 7.29, but the PCO2 is 29. So the last two digits of pH, that is a 2.29, and the PCO2 29 are the same. That means they are compensated. It is a compensated problem in this child. This is a metabolic acidosis because it is 14. Now the last two digits also pH, and then the anion gap is 26, and therefore this is a metabolic acidosis. So for example, the last two digits of PCO2 corresponds to the last two digits of pH, then it is in a compensated stage. For example, normally the blood PCO2 is 40, the pH is also 40. Now this is an excellent chart given by Emmanuel Goldberger, who wrote a book on fluid and electrolytes. The first line in his book is there, he states, remember, at the end of the table, there is a patient. Whenever you inject something, remember, at the end of the table, there is a patient. He has formulated this chart. You can see this chart that is there. If in a pH is 7.4 and the PCO2 is 40, it drops into the normal area. But on the other hand, if the pH is 7.2 and the PCO2 is 80, it falls into the acute respiratory disorder. So like that, you will be able to find out what exactly the patient is suffering from. So this is a very nice chart, and I can post it in our group. You can take a copy and keep it in your ICUs, etc. Now, whenever you take blood for ABG, make sure that the IR or somebody who takes the blood doesn't talk with for some time, for a long period, sometime take it there, by which time the oxygen will be consumed by the RBCs, then the PO2 will become less, the PCO2 will become more, and then there'll be a lot of changes in that one. So the delay alters the reading and make sure that the report, and then the most importantly, when you order any investigation, make sure you read them. You read them immediately. Don't wait for when you order an investigation for ABG and then look at it in the evening. And that's the main things. Many of us do that because we are very busy with otherwise. But every investigation that you get done, make sure that you read them completely. Lastly, some people do venous blood gas analysis. But the venous blood has got a lower pH level, less oxygen, higher PCO2 level than the arterial blood. Therefore, venous blood gas ABG values should not be used interchangeably. But there are some centers where they do the venous blood gas. Initial arterial blood gas is also done, and then do serial venous blood gas to find out the progress of the individual rather than poking the child if you don't have a central line for the child repeatedly. Now, Roche has introduced a machine which is a calculated thing like a small calculator where the arterial blood gas values are given by the venous sample when you, introduce a pulse oximetry value also to that. So with the machine, you can take the venous blood, add pulse oximetry value, you will get an arterial blood gas analysis. I mean, if it comes to India, then we can, it's a simple matter to have a venous blood and the oximetry, oxygen values, and you will get an arterial blood gas analysis. Now, take home message is keep repeatedly analyzing the ABG report. Always view it in the background of the clinical scenario. Every lab value, you have to look at it in the clinical scenario. For example, if somebody says hemoglobin is 6, but the patient looks pretty pink, and then and even the nail bed looks very pink, and the hand also looks pink. I mean, you don't give much importance to the HB value. Similarly, you interpret what the patient's condition is and then treat accordingly and not the lab value. Thank you very much for your patient hearing, and I hope I have completed in time.
And since we already...
Hello?
Thank you, sir. It has been an excellent presentation of such a complex problem, and I think all the audience have enjoyed it. And since we are running short of time, so therefore, we can permit one quick question from the audience. And if there are no questions, then thank you, sir. We look forward to the next lecture.
Thank you very much, sir.
Thank you. Thanks very much. Right.
Ravi Kumar, sir, can you hear us?
Yes, please. Yes, please.
Yes. Thank you, sir. Thank you so much.
Sure.
Good morning, friends. From the morning, you've been listening to good lectures on all basic sciences. And the next lecture is on blood and blood products. Today being World Trauma Day, the importance of blood transfusion is prime in our mind. And I would request all of you to download the E-IAPSCON app which the government of India has made, so you can know everything about availability of blood in various centers. And today we have Dr. Nitin Shah, consultant pediatric hemato-oncologist from PG Hinduja Hospital, an authority on this subject, to give us a lecture on this particular topic. Over to Dr. Nitin Shah.
Well, thank you. Thank you everybody for inviting me here, and I'm really having pleasure in attending this surgeons meeting. Let me start with as to why we should use components and not give whole blood. Remember, a whole blood has essentially red blood cell, platelets, and plasma, besides having WBC, which of course are sort of no use. So say platelets, you store the blood in refrigerator, the platelets become dysfunctional. So you can't use the whole blood stored in a fridge to give platelets. Coming to clotting factors, if you store the blood, say, for 24 hours, most of the meaningful factors like factor 8, factor 9, factor 7, 5 would disappear because they have short half-life. So again, you cannot replace as whole blood. And when you give whole blood to someone who needs just to say increase the oxygen carrying capacity, like in a patient with anemia, you're actually wasting by the whole blood by giving him the other two components like plasma and platelet, which are not necessary. Whereas the same whole blood could have been actually made into three components and satisfy need of three people. Not only that, it's a waste, but it's a hazard. Like suppose a severely anemic child, if you give whole blood, you may actually push him into failure. And if you don't give a leukodepleted blood product and you give a lot of donor lymphocyte to the patient, it can lead to its own toxicity, including fever, reactions, and HLA sensitization. That's why no good blood bank will ever give you whole blood. Will always make that blood collected into components, at least one packed cell, one FFP, and one platelet. And some good blood bank will also have two additional bag, what we call penta bag, which will divide the packed cell into not one but three bags. So like you are all pediatric surgeon, you also practice a lot of neonatal surgery. So you have to give some 20 ml, 30 ml, 50 ml blood to a newborn. Why waste the remaining? So they can satisfy the need of three newborns from the same bag, or the same newborn who needs repeated transfusion can be given the same bag over the 3 times, because they can give you each time a 50 ml bag. So having talked about the need to give, I think there's a lot of disturbance. I can't. Someone needs to mute themselves. Excuse me, the admin, please. Yeah, okay. So let me start with some cases. Now, again, there is a lot of disturbance. At the Dr. Ravi Prakash, maybe your mic is on. Could you mute yourself? Dr. Ravi Prakash. Okay. So let's start with the first case. 1-year-old has congenital inguinal hernia. He has come for surgery, but from very far off, like say he's traveled overnight to come to you. And you have done he has come without appointment. You have done a CBC, shows hemoglobin of 6.5. MCV, that is the mean hospital volume, is 65. WBC look okay, differential looks okay. The platelets, if at all, are a little higher. Now the question is, which blood product will you use? Because you cannot operate on such a small child with 6.5 gram hemoglobin. The answer is that none. You will not transfuse this child. This is not an emergency surgery. To transfuse someone just because he has come from far off and to finish off their hernia surgery, or to worry that the patient, if you don't operate today, will go to some other surgeon, I think is futile, because as I will tell you, the blood products and blood are not always safe. So it's not urgent. This looks like iron deficiency. The small child can be put on oral iron. You repeat hemoglobin or CBC after 1 month, there'll be some rise. By 3 months, the hemoglobin will be almost normal. Whenever it is 8, 9, 10, you can operate it. So point I'm making is that all anemic children, if there's not an emergency surgery, should not be given transfusion just to make them fit for an immediate surgery. And this is the paper which talks about relations between perioperative blood transfusion and the outcome in a surgery in a pediatric patient. And you can say on almost 55,000 patients, of which almost 2,000 received blood transfusion of more than 25 ml per kg body weight, at the end, in the non-newborn pediatric general and thoracic surgery patient, the transfusions were associated with higher risk of skin and soft tissue infection and wound dehiscence. So how many surgeons would like the wound to get bad just because they transfuse unnecessarily? So transfusions are not only not safe, but they are counterproductive if you give them unnecessarily. So now let's come to a child where actually a transfusion may be required. A 3-year-old diagnosed case of acute empyema. He has distress in spite of proper antibiotic, and the pediatrician has sent a reference to the surgeon to say that maybe the pus is too thick. And anyway, nowadays we all believe that empyema is like an abscess, it should be drained. So he is referred for VATS. And now when you want to do the video assisted surgery, you find that the child's hemoglobin is 7, the WBC is high because probably he's got that empyema, and his platelets are normal. So now which blood product will you use? So now that's where the anesthetist will prevail upon you. If you ask me very frankly, even 7, 7.5, 8 is safe enough to give anesthesia to any child, but the anesthetist may not want to give anesthesia for someone having hemoglobin 7 or below. So perioperative anemia of 7 or below may be an indication to transfuse, which will be also the requirement of anesthesia, because ultimately the anesthetist had to give the fitness. So in this child, you will give him packed cell or the packed red blood cell and not whole blood. Case 3, 4-year-old child, a case of road traffic accident, brought extremely pale and in shock. That means he has bled a lot. Now you to find out where is bled, and you suspect that there is abdominal distension. So there might be splenic tear, which would be quickly fixed up by an ultrasound, maybe a bedside ultrasound, and would need an urgent exploration. Now, which blood product will you use will depend on the CBC. Now, remember, when he's come so pale and in shock after a road traffic accident, obviously he was normal hemoglobin to start with and has gone so pale that he has gone into circulatory collapse, which means he has lost a lot of blood. So this is the situation what we call massive transfusion. What is massive transfusion? Where you lose more than 1 blood volume in 24 hours, or you are losing more than half the blood volume in just 3 to 4 hours. That's the speed at which you are losing. Or like in an accident case, more than 3 ml per kg per minute of blood loss with unstable patient like your patient. So this child would actually need all the 3 products, because if you keep on giving only Paxil to this child, there is a lot of dilutional problem which is going to occur, because you are going to give him 3-4 bags of Paxil. There'll be a lot of hypothermia, hyperkalemia, metabolic acidosis. Even the clotting factor would be go haywire, and the patient may continue to bleed because of prolonged PT-PTT. And even when you do platelet count in such a child, it may look seemingly normal. Those are the platelets which you have transfused as a part of the Paxil or the whole blood, and which are not functional. So you have to actually give this child Paxil as well as FFP as well as platelet, but there is no need to give it as whole blood. It can be given as 3 different components given back to back, one after another. So you see this type of massive transfusion situation in patients who have this type of surgery or who have this type of accident with a lot of blood loss. In cardiac surgery, especially, you can have blood loss. ECMO, there is a lot of blood loss. And in exchange transfusion, which sometimes pediatricians do. Of course, nowadays we don't do much exchange transfusion with very supportive phototherapy. But if you are called to do, then again, that's the time where you need actually a whole blood like of picture. So all components are lost. There is dilutional coagulopathy, dilutional thrombocytopenia, there is hypothermia, metabolic acidosis, and shock. So you can still reconstruct whole blood. So you give, these are the charts which are available, but generally remember, you need to give them 1 Paxil, maybe half FFP and 1 or 2 platelet for a child who is small like 10 kg, and an older child, say 40 to 50, you will give 5 Paxils, around half of that as FFP. That's 2.5 bags of FFP and maybe 3 to 5 platelets. So almost 1:0.5 to 1 ratio or 1:1 ratio of Paxil to FFP to platelet. And remember, sometimes the fibrinogen may not be replaced very well by FFP, and you may have to actually end up giving them also cryoprecipitate. So Paxils are stored in refrigerator at 2 to 8 degree. They are very helpful for volume replacement unless there is a massive transfusion where you need the other 2 products. It also helps you to increase the oxygen carrying capacity. So perioperative anemia in a surgical patient, it is very good to give Paxil instead of giving whole blood. The advantage is less volume, so it doesn't overload the patient. It has less plasma, so it doesn't lead to any plasma-induced toxicity. It is less citrate as compared to whole blood. So again, your metabolic problem will be lesser if you are given a Paxil. It should be always ABO identical compatible, RH identical compatible, and Coombs cross match. Today, all good blood bank will do what we call antibody screen and give you the blood which is the most safe for your patient, and that's the reason why you hardly see any reaction. So full cross match, including a Coombs cross match, is required to look for minor blood group incompatibility. Generally, you give 15 ml per kg of Paxil over 2 to 3 hours. Don't keep it hanging for 4 hours and 6 hours. Do not reuse the same bag in the evening or the next day. It's a blood, is a drug. It has to be discarded after single use. If you want, ask the blood bank to give you the aliquots. They will prepare and give you in a closed manner rather than you trying to save the money by using the same bag over 2 to 3 times. One Paxil of 15 cc per kg will raise the hemoglobin by 3 grams. So that is what you expect, and accordingly you give that much amount of blood. Now in surgery, symptomatic perioperative anemia, emergency surgery in a patient with anemia, which is not correctable. Obviously, someone comes with obstructed hernia with a hemoglobin of 6 grams, you have no choice but to give transfusion. But in an unobstructed hernia, like the first case, it's criminal to give blood because you can always give them hematinics and wait for the recovery. Intraoperative. So when you expect the blood loss is going to be more than 10% of blood volume. So that will be like in massive surgeries where you are going to have blood loss, orthopedic surgery where there is a lot of blood loss, etc. You can actually even give volume by volume replacement intraoperative so that you don't land up into a sick child under anesthesia. Post-operatively, in a patient with a drain where a lot of blood is coming out, you would watch the CBC at 24 hours. If the hemoglobin has dropped to below 7, that may be the indication to give him top-up transfusion. And in a patient who is on oxygen, either by oxywood or on ventilator, or has got associated sepsis or associated respiratory problem where the oxygenation is going to suffer because of the organ function, you would want to keep a higher hemoglobin, maybe 8 or 8.5 rather than 7 as the cutoff for transfusion. Now let's move to the case 4, a newly diagnosed case of acute leukemia. The pediatric oncologist wants to do 2 procedures. He wants to do a first lumbar puncture to see for CSF involvement and also want to give me the first intrathecal chemotherapy. And he wants port insertion because it's a small child. He cannot do with peripheral line, maybe port or maybe PICC or some central line. Now you find his hemoglobin is okay, WBCs are low, but the platelets are very low, 20,000. So now the question comes as to which product will you use for lumbar puncture and what is the safe level of platelet for port insertion or any surgery like that. So first of all, the LP done by a trained person does not need platelet in general. But for the first time, you don't want a traumatic tap because it would mean, one, you won't know CSF was involved. Two, the patient at the time of diagnosis, a lot of blasts in the peripheral blood, it will contaminate the CSF and the brain. So some people keep it about 30,000. In the Western country, they will keep even up to 50,000 or 1 lakh to prevent a mishap of a bleed happening following a trauma of a needle. For port insertion, definitely everyone would insist a platelet of 50,000 above because we know anyone with platelet 1,000 or 50,000 above generally does not bleed spontaneously or on minor surgery. So unless they are life-threatening surgery where you need more than 100,000 like CNS bleed, etc., you can keep it at 50,000 for a procedure like port insertion. Now the question, which platelet? You will give a random donor platelet or a cinder donor platelet? So first of all, platelets are kept outside the refrigerator. Do not keep your platelets in the refrigerator once it comes to the ward because they become dysfunctional moment it's kept at below 22 degree. So they are kept on a platelet agitator at 22 degree in the blood bank and they are constantly agitated. They are moved so that they don't stick to the surface and become dysfunctional. So ideally to give the same ABO and RH if possible, but if it's not available, you can give a mismatch, but remember your platelet recovery will be less and there are chances of side effect. So you can give ABO incompatible. Remember, when you give an RH negative girl an RH positive platelet, there are enough RBC stroma in the platelet to lead to sensitization. So for every 3 or 4 platelets that you give, you would recover by giving 250 microgram of NTD so that the child does not get sensitized against RH and have trouble during pregnancy. Platelets are isolated from whole blood at room temperature and kept at 2 to 22 degree and on an agitator, and then the shelf life is only 5 days. So they have to be used within 3 to 5 days of collection or they have to be discarded. Never store them in fridge, and if by mistake sister kept it in the fridge, then you have to throw away that platelet. Now it should be infused quickly over 20 to 30 minutes. It's usually a 50 ml volume if it's a random donor platelet. So don't have to keep on hanging for 3 hours because the platelet become dysfunctional when they stick to one another. Do not use glass syringes because it sticks to the glass. So use plastic tubing. Of course, nowadays everyone uses plastic sets, so there's not a problem. Always give the platelet set through a platelet set which are shorter so that it can go faster. And remember, you have to use a leukocyte filter even while giving platelet, especially in someone getting reaction to platelet after repeated platelet transfusion, so as to remove the leukocyte, which are the main cause of this fever and reaction. So there are two types of platelet. From 1 unit of blood that you have taken from a donor, you make 1 unit of platelet, that's known as RDP or random donor platelet. Or if you want more platelet in a bigger child and not want to expose him to multiple donors, then you give him SDP, a single donor platelet, which is obtained by apheresis. So you subject a donor to an apheresis machine, take out almost 5 to 7 bags worth of platelet and infuse the remaining components back, and you can use the same donor again after 7 days. So you attach him to this apheresis machine and you can take as much platelet as you want without any trouble to the patient. So the advantage, SDP has more platelet than RDP, but also has more volume. So it is not concentrated. It's just that you get more number of platelet bags from same donor whom you can use again after 1 or 2 weeks. So you minimize the number of donors which you are exposing to. And of course, it's expensive. And SDP is not easily available. It has to be prepared on demand. So in emergency, you always use RDP, which are there in the blood bank, and SDP you can plan and always get an SDP. Now, indication of platelet in surgical patients, mainly used for bleeding in a case of decreased production, like malignancy, aplastic anemia, sepsis, etc. Rarely it is required in patient where destruction is because of immune cause, like ITP. Like you may be called to a life-threatening patient of ITP bleeding, and the surgeon, everything is given and his bleeding is not stopping. You have to immediately do an emergency splenectomy. So there, under IVIG and IV methylprednisolone, you will give platelet and take a nick, go to this clinic event, clamp it, and your platelet count will start rising. Otherwise, it is usually used for bleeding because of decreased production, like you have port insertion, central line insertion, procedures like in an IND or any other surgery done in a patient with low platelet, like say in a patient with malignancy. Now, prophylactic platelet, when do you give platelet prophylactically? So as I said, first lumbar puncture, many people want to keep it about 30,000. Of course, I don't use it because I do first LP on my own. For non-critical surgery, above 50,000 is the cutoff, like for epidural anesthesia, gastroscopy, biopsies, indwelling lines, transbronchial biopsy, liver biopsy, etc. And for critical site surgery like CNS, ophthalmic, etc., you will want to keep it above 100,000. One word, procedure like bone marrow, which are superficial, can be done without any prophylactic platelet and at any platelet count, because you can apply local pressure for 5 minutes and arrest the bleeding. Now, a 1.6 kg preterm with sepsis since last 15 days is in ICU, and now IV access is a problem. So pediatrician calls you to put a PICC line because they want to give antibiotic for a long time. Now his hemoglobin looks okay, his WBC is okay, his platelets are 1 lakh, his PT INR is prolonged because of sepsis, is a 1.6 INR, and APTT also is prolonged 50 upon 35. So now you are having a child who just has borderline low platelet and also has some abnormal coagulopathy. So which product will you use? So you have to give him FFP to prevent perioperative bleeding. If his platelets were below 50,000, you would have also given him platelets. And if he was anemic, then you would have given also transfusion. So that brings us to FFP. Now here what the surgeon did was that he gave 25 cc of FFP, and the rest of the FFP he didn't want to waste, so he kept in the ward refrigerator for future use. So this is how the FFP is kept in the blood bank. It is kept at -20° or below, typically kept at -80°, at which the shelf life is 1 year. So it's like a frozen blood product in the blood bank. So usually 250 ml volume, the blood bank will thaw it and give it to you. You don't keep hanging because, as I said, the vital clotting factor like factor 2, 5, 7, and 9 have a very short half-life. They will disappear if you keep hanging. It has to be given over 20 to 30 minutes. So don't keep on hanging for a long time. So obviously it has to be thawed at 37° by the blood bank and then given to you. And once it comes to you, you see for leakage, and if the bag is okay, you infuse it fast over half an hour. So you give normally 15 cc per kg. You can give every 12 to 24 hours in a non-anemic patient. But in a patient with cardiac decompensation, you should not give more than 10 cc per kg and not more than once in 24 hours. It is often misused as a volume expander, as a source of albumin. You can use albumin and don't use FFP. As a clotting factor replacement in a known bleeder. So a hemophiliac A8, say A, with factor 8 deficiency, who come bleeding and you want to do something, give him factor 8 replacement and don't give him FFP. DIC without bleeding, stable DIC, doesn't need any FFP. Increase INR, like suppose you have a patient of liver disorder, INR is high, but you are not doing any surgery, then you don't have to really give him just to correct that INR, because it is only for patient if the patient is bleeding. And last thing, the mistake that was done was stored in the ward refrigerator. You cannot keep it in the ward. It's a drug. It has to be kept in the blood bank. You can't reuse the same pack in the evening or the next day, because once thawed, it has to be used within half an hour to 1 hour. You can at the most keep for 10 to 12 hours, but that too in a blood bank and not in your ward refrigerator. So the true indication of FFP in surgical patients will be operating on a bleeder with unknown factor. Like first time patient has come, it looks like some hemophilia. You don't know factor 8 or factor 9, so you will give him FFP and arrest the bleeding and do what you want to do. Emergency surgery, like suppose a patient is there with vitamin K deficiency, late HDN, hemorrhagic disease of newborn. Now you need a decompressive craniectomy because he's very sick. You give him FFP and correct it, that bleeding tendency. Any surgery with deranged PT-APTT not correctable by vitamin K, like suppose a liver disorder, pre-cirrhosis, you give vitamin K, it is not getting corrected. You want to do some surgery, give him the FFP so that he doesn't bleed. Massive transfusion and extra transfusion, we already said before, you need to give FFP always. And in plasmapheresis, like in an HUS or a TTP patient, you will replace not by saline, but always by FFP from a donor. And the last product that I speak is a cryoprecipitate. It is nothing else but a concentrated FFP, which is rich in factor 8, von Willebrand factor, and fibrinogen, besides factor 13. So it's a very useful product for sometimes hemophiliac A, not for hemophilia B, to replace fibrinogen. Like in an obstetric unit, there is a lot of use of fibrinogen because it's a very rich source of fibrinogen. So use it in congenital hypodysfibrinogenemia, DIC patient, massive transfusion, torrential surgical bleeding, and other uses are like, as I said, factor 8 or von Willebrand disease or factor 13 deficiency. Now, as I mentioned about leukodepletion, so there is more than 5 into 10⁶ donor lymphocyte in, say, even in a packed cell. Now, they are the culprit for all non-hemolytic febrile transfusion reaction, allosensitization, which can lead to platelet recovery problem, graft rejection in a potential transplant setting, all viral infection like CMV, HIV, etc., transmitted to the donor lymphocyte. TAGVHD, transfusion-associated graft-versus-host disease, which has 95% mortality, can happen because of donor lymphocyte. I already said that if you give unnecessary transfusion, there is immunomodulation, and wound infection is also because of donor lymphocytes, and there may be pulmonary sludging. Those lymphocytes have absolutely no role to play, so you should always leukodeplete. And the best way to leukodeplete is inline filter. So when the blood is collected from a donor, it collected through a WBC filter, so that all the product which are then you are going to make subsequently will be automatically leukodepleted, and they'll be very safe to use. You have to gamma irradiate the blood product if you want to prevent transfusion-associated GVHD. For all other rest of the problem of lymphocyte-mediated toxicity, WBC filter are good enough, and you don't have to really irradiate every blood product. So one leukemic child developed anemia on chemotherapy, received transfusion over 4 hours, deteriorated after a few days, developed fever, diarrhea, skin rash, jaundice, and mucocutaneous lesion. This is how she's sick, rash all over, icterus, mucositis, and this is because of the TAGVHD or transfusion-associated graft-versus-host disease. So remember, in a newborn like preterm, intrauterine transfusion, primary immunodeficiency, secondary immunodeficiency, transplant setting, cancer patients, and if you're taking blood from a blood donor is your blood relative, then these are the settings where a TAGVHD can happen, and all this have to be undertaken after doing irradiation by gamma irradiator. So I just end my story. of course, this is not surgery, this is medical indication, but I will sensitize you why you should not use blood product indiscriminately. This boy was at 3 years brought with what looked like anemia, which was iron deficiency, 3 gram MCV of 56, came walking. He was given 1 unit of Paxil by the resident on duty out of fear that he may go into failure. He went home and came back after a year or two with massive weight loss, fever, diarrhea. This is what he became. Even today, you have transfusion-associated HIV infection as a complication, especially in the rural part where the stringent checking may not be possible. So the bottle of blood is meant to give life. Let death not begin its toll here. And we have to have blood audit, blood audit, blood audit, and blood audit in every unit of medical or surgical places, so that you use blood product judiciously. One, because blood is a rare commodity, and two, blood is not as safe as we all think. So the only way you can reduce your blood product use and give it correctly is knowledge of physician, right from top to the bottom. These are the IAP, Indian Academy of Pediatric National Guidelines 2006 book. It's of course 15 years old, but still holds true. And one of the guidelines is on blood component. When I was the president of the Indian Academy of Pediatric, if someone is interested, I can share this guideline, a copy with you. And with that, I will come to an end, and thank you very much.
Is there any question for Dr. Shah? This is the ninth lecture. As there is no question, this is the ninth lecture by Dr. Nitin Shah about the blood component transfusions. We really highlighted by these lectures of blood transfusion, which is often, very often used nowadays. And so many products of blood are used. It is saving the life of many patients, giving one component and saving the other component.
So,
Thank you very much.
With your permission, there was one question which said that when you do testing for
Uh,
HIV, can you still
for
get
his
HIV from blood?
illuminating lecture.
So the answer to the question in the chat box is that you do NAT testing, that is nucleic acid testing for hepatitis B, hepatitis C, and HIV, all the three. When you do that, you bring down the window period for HIV from say 20 days to 3 days. So if you have a very strong history of very nice behavior by the donor and is NAT tested, the chance of getting HIV through blood product is 1 in 1 billion. So it's almost unknown. So if you are NAT tested blood, be assured it's a very safe blood. But if it's not NAT tested, just ELISA tested, then there is a window period of 20 to 25 days, and you can have a mishap once in a while.
Thank you, Dr. Nitin Shah. It was a wonderful lecture. We learned a lot about blood and blood product transfusion today. Today being World Trauma Day, it's a very important for all of us to know about blood transfusions.
Thank you,
I
sir.
request actually all the younger postgraduates to visit the blood bank of their institutes, you know. Just they go to the radiology department, because most of us are unaware. We just order for blood and we don't know what really is being done in the blood bank. And the IAP guidelines, what you have said, is in long way going to help the students to learn. Now, there's one question from the audience. What do you do with the blood bank, bag of blood in the FFP if there is a precipitate in the FFP?
So the blood bank should not issue such a bag which has got precipitate, number one. Number two, they will also inspect for micro leaks because it's a frozen sample. So sometimes it may damage the plastic bag. Once that is done, only it is thawed at 4 degrees and then given to you. So if there is any impurity or any precipitate, you should not use that blood product and you should discard it and return it to the blood bank.
I want to ask, blood sets, as you said, for platelet, you have a smaller transfusion set.
Yeah.
So such sets are freely available,
Yeah,
different
they
blood
should.
sets for blood
They are
products?
freely available.
So,
and another thing is when you are giving platelet, random donor platelet, RDP, the volume is 50 ml. And remember, there's a lot of those platelet will remain in the set, which may be around 10 or 12 ml. So allow it to go to the last end. Otherwise, you will not be giving the full product. In a PRBC, it may not matter if 10 cc is left behind, but in platelet, it will matter.
thank you very much, sir. I, Dr. Bagdi, on behalf of the IAPS, thank you very much for this excellent lecture.
Thank
and
you,
I'm
sir.
sure everybody has benefited. Thank you very
Thank you,
much.
sir. Thank you.
So I think the biggest threat for the next coming century is antibiotic resistance. So especially when we are dealing with the pediatric patients, we belong to a high risk group. As we know, a lot of drugs are contraindicated like tetracyclines, fluoroquinolones. We have a higher resistance to MRSA and other carbapenem producing drugs. So now we are fortunate in having Dr. Dhanya Dharmapalan, who will guide us on the rational use of antibiotics in pediatric surgical practice. Dr. Soni will introduce Dr. Dharmapalan.
Of Indian Association of Pediatric Surgeons, may I take this opportunity to introduce our next speaker, Dr. Dhanya Dharmapalan. She is the national convener. She was the national convener, Rational Antibiotic Practices of IAP module in 2014. She is the national coordinator of Apollo Antimicrobial Stewardship, and she is also the co-lead Global Antibiotic Stewardship Committee, USA. And she also has to her credit over 50 publications, and she is the editor of 16 pediatric textbooks. So, Dr. Dhanya Dharmapalan would enlighten us on the topic rational use of antibiotics in pediatric surgical practice. Dr. Dhanya Dharmapalan.
Thank you for the kind introduction and thank you for inviting me. It's an honor to be here. So I shall be speaking on the principles of rational use of antibiotics in pediatric surgical practice. So before that, let me just talk about surgical site infections very briefly, that these are infections which occur up to 30 days after surgery and even up to 1 year if the patient has received implants. And these are either incisional infection or organ infection at the operation site. And it is diagnosed clinically by local tenderness, redness, purulent discharge at the surgical site, and there could be spontaneous dehiscence of the wound. And the common organisms which cause surgical site infections are reported to be Staphylococcus aureus, Coagulus negative staphylococci, that is cons, enterococcus, species, E. coli, Pseudomonas, etc. And with the broader use of antimicrobials, even we are getting reports of fungal infections such as Candida causing surgical site infections. And we are aware of the rising resistance. So even MRSA is also a cause for surgical site infections, especially in patients who are colonized with MRSA. Now, how does this infection occur? Usually by translocation of normal flora or resident flora to the sterile tissue during the surgery. So this could be, for example, the skin flora, which contains Staphylococcus species. During the incision can be translocated to the sterile surgical site. Or another example of resident flora is E. coli present from bowel can enter into peritoneal cavity. So there is a need for surgical site infection prevention. And we all know that they are common nosocomial infections. And as per the WHO data in the lower middle income countries, what they have done is they did meta-analysis of the incidence and prospective studies between the period 1995 to 15 and found the pool surgical site infection rate as 11.2 per 100 surgical patients. And it was highest for oncosurgery at 17.2%, followed by orthopedics and general surgery, while pediatric surgery also contribute to a significant proportion at 12.7%. So we know that surgical site infections increase the length of stay for the patient, morbidity and cost. And in fact, if the infections get multi-drug resistant, then there are limited options for treatment purpose. So that is why we need to use the antibiotics judiciously. Risk depends upon the type of procedure and patient-specific factors. I shall talk about the type of procedure, but patient-specific factors, I mean, is risks such as malnutrition, diabetes, immune-compromised condition, receiving corticosteroids for a prolonged time. So these factors can increase the risk of infection. In the last session, we also heard about injudicious use of blood transfusion also increases risk of surgical site infections. The best part of all this is these are preventable. So prevention is in our hands, and let us look how. So we know that antibiotics are the most important tool to prevent surgical site infection. But on the other hand, if we use it injudiciously, it can increase the selective pressure favoring antimicrobial rise. And we all know that antibiotic use itself is the main driving force to cause growth of multi-drug resistant bacteria and thereby colonization by drug resistant bacteria. Therefore, rational use of antibiotics is certainly the need of the hour. But we must understand the concept of prophylactic antibiotic versus therapeutic antibiotic. So what is prophylaxis? Is usually to prevent infections in high-risk patients or procedures. And here the antibiotics are chosen in such a way that they should be able to be effective against most likely organisms that can potentially cause infection in that patient. And this regimen is given only for a finite brief period. It's not given indefinitely. It's given for a short period, limited period, during which the infection is most likely to occur. Whereas on the other hand, therapeutic antibiotics are used to treat an infection which has already presumed or documented to have occurred. Now, this is a familiar classification for all the surgeons, that all the surgical wounds are classified as clean, clean, contaminated, contaminated, and dirty. Now, if you look at the infection risk, so for clean, where there is no acute inflammation, it's an elective procedure, there is no breach of the mucosa of the respiratory, genitourinary, or gastrointestinal tract, the risk of infection is very low. It's just less than 2%. But in other cases, such as clean, contaminated, and contaminated, where there is a breach of the mucosa of the tracts, or there is gross spillage, the infection risk increases from between 10 to over 20%. And the highest risk of infection is the dirty surgical wounds, where there is pus, necrosis, or abscess. And based on this classification, we can also see what can be done to prevent the infections. Now, for clean infection, the risk is so low that there is a controversy whether prophylactic antibiotics are actually needed or not, unless it is high-risk procedure. High-risk procedure means, say, a prosthetic implant, where the implant infection itself can be life-threatening to the patient. So in these situations, I will talk about it. There are certain low-risk category where even prophylactic antibiotics may not be needed. But in clean, contaminated, and contaminated, certainly because of the risk of infection, prophylactic antibiotics are needed. Whereas in dirty surgical wounds, it is not prophylaxis, but treatment of the primary infection. So this concept should be very clear. Now, what is the choice of prophylactic antibiotic? So the antibiotic has to be bactericidal, means it should kill the microorganisms. It should not be bacteriostatic like azithromycin, erythromycin, where they just inhibit the growth of bacteria. Because we have limited time, we want to kill the microorganisms before they can attack the surgical site. So it should be bactericidal. Second, it should achieve adequate local tissue levels at the site of surgery. Third, it should have minimal side effects for the patient. So if the patient is allergic to that particular antibiotic, you use another antibiotic. Fourth is it should be suitable as per host comorbidity. What I mean is, if say the child has a renal compromise, you're not going to use prophylactic antibiotic like vancomycin, which can actually cause further renal compromise. So you should be careful about host comorbidity. And it should be relatively inexpensive and not likely to select virulent organisms. Also, avoid antibiotics which are likely to be used in case there is serious sepsis in the same patient. So the prophylactic antibiotics should be ideally different from therapeutic antibiotics. So a very good example is cefazolin, which is widely used for most of the clean surgeries which do not violate the mucus or hollow organ because of its excellent gram-positive action. It is very effective against the gram-positive bacteria such as Staphylococcus aureus, which is methicillin sensitive, or Streptococcus pyogenes. So therefore, it is also used because of its narrow spectrum. Now, just for additional information, cefazolin belongs to the first generation cephalosporins. And the concept is that as you go from first generation to second to third, the gram-negative action increases. That is why in second generation, for example, cefuroxime has both gram-positive and gram-negative action, whereas third generation antibiotics such as ceftriaxone or cefotaxime have more of gram-negative cover, but they could be inferior to the first generation antibiotics such as cefazolin for gram-positive action. So because the third generation is broad spectrum, this is narrow spectrum. Now, regarding the timing of antibiotic, now original studies which have been done about 40, 50 years back have demonstrated that the effective period of preventive antibiotic action when you do an incision is the moment bacteria can gain access to the tissue, and this is over in 3 hours. That should be remembered. And this is very well demonstrated in this graph, a very important graph by Klassen et al., where they studied the risk of infections with regard to the timing of incision. And you can see very clearly that if the prophylactic antibiotic is given within 1 hour, the infection is lowest. And then after 2 hours, before 2 hours, of incision. But if you give the prophylactic antibiotic very early, that is before 2 hours, then there is risk of infection. Or if you give it very late, then dramatically the chances of surgical infection increase. So the best time to give the prophylactic antibiotic is 1 hour prior to the incision or max 2 hours prior to the incision. So the principles are, again, preoperative IV antibiotics should be given within 15 to 60 minutes of skin incision. And administration after the skin incision, that is more than 60 minutes before incision, will reduce the effect. But please do not give beyond before 120 minutes of the incision. But there are antibiotics such as vancomycin, fluoroquinolone, which have long infusion rates of about an hour. So only in these situations, you may give within 120 minutes of the incision. If a tourniquet is to be applied, there should be a 15-minute period between the end of the antibiotic administration and the tourniquet application. And it is the IV route most preferred. See, we have limited time. We are using bactericidal drug. We want quick attainment of the serum concentration. That is why IV route is most preferred. But there are situations where you may use, say, metronidazole as a rectal suppository in some bowel surgeries, but then they need to be inserted at least 2 to 4 hours before the surgery for the serum levels to be attained. Local topical antibiotics for prophylaxis is not recommended except for certain ophthalmic surgeries or maybe for burns. Now, duration of prophylaxis. This is also extremely important because this is another area where antibiotics are heavily misused. Actually, it is only one dose that is sufficient for most of the surgeries for prophylaxis. A second prophylactic dose is recommended to be given intraoperatively in very few situations, and that is if the surgical procedure is longer than 2 halves of the agent used. 2 half-lives of the agent. So what I mean by this is, for example, cefazolin has a very short half-life of just about 1 to 2 hours. So if the surgery prolongs after 4 hours, you need to give the second shot of cefazolin. So similarly, you need to look at the half-life of the antibiotic that is being used and time accordingly. Because if you don't do that, there is a possibility that the levels will dip during this or during or towards the end of the surgery, again increasing the risk of infection. Also, the second indication is if there is blood loss of over 25 ml per kg or hemodilution. In those situations also, because of problem of serum concentration dipping, you can repeat the dose. But persistence of antibiotic concentration beyond the surgical procedure actually offers no additional benefit to the patient. It can just increase colonization of multi-drug resistant bugs in that patient and even can later cause some serious infection. Continuing antibiotic prophylaxis until surgical drains have been removed also has no unproven benefit and is not recommended. So maximum duration is 48 hours. Beyond that, the surgical prophylaxis should not be given. And that too, this maximum duration is for certain surgeries, like say cardiothoracic surgeries. Now we'll just look quickly at few cases, like say, just for examples of some surgical procedures. Say orthopexy, we know it's a clean surgery. We know the infection risk is less than 2%. And what are the organisms which can cause surgical site infection? Mostly that which is present on the skin. So maybe Staphylococcus species. And we have already learned that the best antibiotic, bactericidal, best effect, narrow spectrum is cefazolin and given as single dose. There is no need to extend this, give another dose if the surgery is less than 4 hours. But there is no more evidence towards not giving any prophylaxis at all. And you will see papers like this questioning the role of surgical antibiotic for clean surgeries. Resection anastomosis of bowel. This is another example I just took. This is clean contaminated with likely risk of spillage. So here the infection risk is higher than clean surgeries. And what are the bacteria which are possible to cause infection are the gram-negative bacteria, anaerobes, enterococci. So we need to give antibiotics which are effective against that. Ceftriaxone in this case is a very good antibiotic for gram-negative bacteria, but it does not have anaerobic coverage. That is why metronidazole is added. Do not continue beyond 48 hours. That is very important because many times antibiotics are just started but not stopped, and we must know when to stop. Perforated appendicitis with peritonitis. Now this is a dirty wound. You have the pus already infecting the operation site, and here you are giving antibiotics to treat the primary infection, You may or may not add amikacin if in case you're not suspecting ESBL infection, maybe amikacin may not be added. And if the patient is in shock, maybe a higher antibiotic might be given, like say piperacillin, tazobactam plus minus vancomycin, depends on the severity of the patient. But here antibiotics are not for prophylaxis, but for therapeutic treatment. So this is the difference. And therefore the duration of treatment could be 7 days or more. But very important is to send appropriate cultures and modify as per sensitivity. For example, if this child comes in shock and one has started piperacillin, tazobactam and vancomycin combination, and then the culture comes back as methicillin sensitive Staphylococcus aureus, vancomycin is going to be inferior to the anti-staph agents such as ceftriaxone, coamoxiclav. The drug of choice, you know, is cloxacillin. So it's going to be inferior. It is only going to add to maybe renal problems to the patient. So therefore, you must know that we must modify the sensitivity, antibiotics when the cultures come back. Abscess drainage, again, I just talked about Staphylococcus aureus, is usually the culprit, or Streptococcus pyogenes. The drug of choice is cloxacillin. Unfortunately, cloxacillin is not available. Flucloxacillin is available, but little costly. The other options you can see on the screen, coamoxiclav, cefazolin, clindamycin. If it is not, there is no systemic involvement, the patient is not very sick, you can even escalate later after the culture if it happens to be MRSA to agents which are active against MRSA, such as linezolid or vancomycin. And duration of treatment is as per the primary infection, that is 5 to 7 days. But again, remember to send cultures and modify as per the sensitivity. So escalation, de-escalation is important as per the cultures. Now, this is a very good guideline that Government of India had released in 2019 for common infections. And it has been made with understanding of the prevalent resistant patterns across India. And in this booklet, you can see that this is for adults. Most of the antibiotics that have been recommended for surgical prophylaxis are the first generation cephalosporins or second generation cephalosporin. But for pediatric surgical cases, you would see that for uncomplicated hernia, cyst, excision, hydrocele, actually they have recommended no preoperative prophylaxis, as we discussed earlier. There is general consensus moving towards less of prophylaxis for very clean surgeries. And for clean surgery, which is likely to be contaminated, they have clearly talked about stopping at 48 hours. And of course, for dirty surgeries and contaminated, you can use as per the primary infection. We did a study in 2017 across 6 hospitals in India. And we noted that the third generation cephalosporins are excessively used everywhere, also for surgical prophylaxis. So please avoid using third generation cephalosporins, especially in the clean cases where you can resort to the first generation if necessary, because we know the rising rates of ESBL, and even now, ESBL are those conditions where the cephalosporins, third generation cephalosporins, become ineffective. So we must therefore use these antibiotics judiciously. So next steps are, it is not only important to educate oneself, but all the team members involved in the surgical care about rational antibiotic practices, may it be the nursing staff or residents or other OT assistants. And follow evidence-based practice for antibiotics with the 5 Ds. What are those 5 Ds? It's right drug, right dose interval, right duration, and right delivery. Delivery, I mean, whether it should be given rightly, parenteral or oral, etc. Designate responsibility for timely antibiotic administration. So this will really help if you identify a person who takes responsibility that the antibiotic goes within 1 hour of the incision. And you can have visual reminders for repeat perioperative antibiotic or stopping antibiotics. You can have checklist. And it is very important to audit the surgical outcomes in the patients with adequate post-discharge follow-up about the surgical site infections. Now, we know that very busy airports see up to even 1,000 flights taking off and landing on the airport. But there is fortunately no major mishaps happening. That is because the checklists have been a game changer in the aviation industry, where even the senior most pilot indulges in the checklist. And this has helped in the tremendous safety in the industry. And the same can be applied to our healthcare also to minimize human errors. So checklists do help to prevent, to help administrating antibiotics on time, and to overcome certain human errors because of busy busy schedule, etc. So please give a thought about that. And to summarize, please check if the antibiotics is needed for prophylaxis or treatment for that particular infection. And is the antibiotic choice that you have made appropriate to cover the likely organisms that can cause infection, whether it is more of gram positive, whether it is more of gram negative? Do you need an anaerobic coverage? So those questions are important. Is there any host factor which can change this choice, like allergy, like G6PD deficiency, like renal compromise, where you would not indulge in using an antibiotic which can actually harm the patient? Is the timing of the dose right enough to achieve good serum concentration at time of incision? This is extremely important to not give antibiotics, especially 2 hours before incision, more than 2 hours before incision. And is a repeat prophylactic dose needed? That question, we have limited indications, I explained it earlier. And is there a need to continue antibiotic? Do you need to continue beyond 48 hours, especially you need to look at. Strict infection control policies go without doubt to prevent the hospital-acquired infections in the patients. And also you need to monitor outcomes, educate, and keep updated with the latest recommendations. So I shall end with this line that we are ethically as well as morally obliged to our patients to not cause harm. We know that primum non nocere is the Hippocratic oath we take, that first do no harm. So we should not, first of all, we should not prevent surgical site infections. At the same time, we should not add to colonization of multi-drug resistant in that patient by giving unnecessary antibiotics, and should not contribute to the rising antimicrobial resistance in the community. Thank you.
Thank you, Dr. Thank you, Dr. Dhanya, for in our surgical practice. See, in our practice at PGI Chandigarh, we don't give any prophylactic antibiotic in clean surgical patients. But however, yes, it is sometimes become very difficult, because sometimes very important child is there, some VIP child is there. So you are always afraid whether you have to give prophylactic antibiotic or not. So this is the dilemma. But yes, it's true that in clean cases, we should avoid giving any prophylactic antibiotics. And as a surgeon, if we are busy in long surgery, see, recommendation is to give after 2 hours or 4 hours, whatever. But what happens, we are concentrating on our surgery, so we forget to repeat the antibiotic dose during surgery. This is the usual tendency what we face. And third point, I just want to tell everyone, see, we don't have any control over the use of antibiotic. I worked in Saudi Arabia for nearly 5 years. And there, if we write some antibiotic which is not for that, suppose for gut related surgery, if that is not for that, the pharmacy people, they call the doctor or nurse that why this antibiotic was written, you tell us. And if even the dose is wrong, they will ask for that, and they will not give after 3 days. They will not dispense any antibiotic unless you ask that there is this problem is there is wound infection, this fever is going on, then only. So there was always some upper hand there who are checking your prescription for antibiotic. That is the most important thing. Thank you, Dr. Dhanya. At least there is no question in the chat.
So thank you. I agree to your comments, and that is why antimicrobial stewardship program is so important. But our country is different because we have very small nursing homes where there are individual surgeons, and there is no monitoring from, monitoring can be possible at an institutional level, but it's not similar in our country. So every surgeon or every physician has to actually wear the hat of antimicrobial stewardship. So that is very important. First, and also increase the awareness around about it.
Thank you, Dr. Dhanya. Thank you very much.
Good afternoon, everyone. On behalf of chairpersons and august audience, I would like to move on our next session, which is on neonatal physiology and thermoregulation in newborn. I would like Dr. Vijay to give a brief introduction of our next speaker.
Good afternoon to all. Good afternoon to all. On behalf of scientific committee, I have an opportunity to introduce our next speaker, Madam Sheila Iyer. Madam Sheila Iyer is currently heading the Department of Pediatrics at the Vadodara Medical College, and she received his basic training from Vadodara and got advanced training from Australia. She has a special interest in the neonatology, nutrition, and growth development. She also has a special interest in hemophilia in India. So next, I will request Dr. Sheila to start her session.
Thank you so much. At the onset, let me thank the organizers for giving me this opportunity to be with the pediatric surgeons of India and with being really talking about a very important topic, though it's of physiology, for a newborn to really make a good. I'm just sharing the screen. Yeah, is it visible?
Not yet, madam.
Not yet?
Now it is.
Huh? Yeah, okay. I'll just a minute. Yeah. So coming to neonatal physiology of thermoregulation and in newborn physiology, it's very vital. If we look at, first of all, my greetings from University town of Gujarat, Vadodara. This is our department just behind the statue of Maharaja Sayajirao University. And definitely it's been a very, very cultural city as well. Many of you would have visited earlier that. Coming to my subject of neonatal physiology as far as newborn thermoregulation is concerned, probably a topic of very basic physiology, many times thought as it's more of required by nursing care, but I understand that most of the pediatric surgeons have their major practice, 70 to 75% with neonates, and it's really, really very dear to them also, as all our neonatal outcomes depend on 4 important parameters: temperature, oxygenation, perfusion, and the sugar. So there the temperature is the uppermost important subject that we need to take care of whenever we are handling the newborns. Thermal care is central to reducing morbidity and mortality in newborns. And thermoregulation is the ability to balance heat production and heat loss in order to maintain body temperature within a certain normal range. It's in the last century itself, in the beginning part itself, that temperature is very vitally associated with outcome in low birth weight babies, preterm babies, and they die more because of hypothermia, has been well known to it. And concept of thermoneutral range was given early in 1959 itself. So it's not new, but over the years, we really have become obsessed that we, unless until we take care of this, all our efforts at salvaging this tiny high-risk newborns, or even those babies who are not tiny, maybe full term, but with morbidity, this itself can definitely increase their vulnerability and the survival incidence. So in the next 20 minutes, probably what I would try to do is understand the physiology of thermoregulation in newborns, identify mechanisms of thermoregulation, understand the consequences of inadequate thermoregulation in neonates or the preventive measures if not taken well, identify strategies to support the thermoregulation, and review what are the best practices that we have at this juncture for thermoregulation. Our goals would be, whenever we are trying to keep a baby in thermoneutral zone or body temperature in a normal range, what we achieve is maximizing the metabolic efficiency, we reduce the oxygen use, and we reduce the caloric expenditure by the baby. In neonatal physiology, they are predisposed or vulnerable to poor thermal control because of the wet skin at birth and a high surface or a large surface area to body ratio via skin surface. Immature hypothalamus, lack of subcutaneous fat even for a term baby, and or adipose tissue, that is brown fat, for preterm babies, and poor energy stores and limited brown fat, which ultimately leads to limited thermogenesis and for heat production in a neonate. Then NTE, or a neutral thermal environment, is the optimum environmental temperature, which we all, as those taking care of newborns, need to remember that the environmental temperature has to be according to the weeks of gestation to ensure lowest oxygen and energy expenditure in a neonate. The neonate has to cope with either two extremes, is a thermal stress, most of the time with the excessive heat loss. But remember, a tropical country like ours, many times even heat gain, or the iatrogenic cause of heat gain in all now technologies occupied neonatal ICUs. They are an important cause that we should not forget. Hyperthermia also is an important part of thermal control. But let's come to the basics. What are the methods by which a newborn loses heat? It's evaporation, heat loss through a wet skin; convection, heat loss from cooler air circulating and making the warm air particularly more cooler when exposed; conduction, when the baby is put on to weighing scales or on trays or unwarmed mattresses. Heat loss through direct contact very commonly occurs. Even our sheets on which we take the babies on operating table, many times they are a little wet and cold. Ideally, they should be warm and dry. And similarly, radiation, heat loss from heat radiating towards the surface, like a cold window or a wall or an incubator wall exposed to. So the surrounding room temperature is a very important point that we need to note whenever we are taking care of newborns, even for normal newborns. See, this you can look at the various way of conduction, convection, evaporation, and radiation leading to the heat loss. Look at it. This is the baby who's coming out lustily crying, but early drying and wrapping or skin-to-skin contact with the mother and a head being covered by a cap or a hat is required. If that is failed, yes, we're going to directly expose this child to a hypothermic stress. So these are small things, but one has to look at it that prevention is the main criteria in dealing with neonatal hypothermia or neonatal thermoregulation instead of treating them after it has occurred. Similarly, acute, alert, active baby lying by the side of the mother, but definitely can lose heat through a conductive air currents, particularly if the surroundings are very cool. And we have been always looking at the comfortable temperature to the mother and the caregivers, or even in OT, it's surgeons. So we need to be really, really careful about the environmental temperature that we are going to use. Similarly, a baby put into the weighing scale without a dry, warm linen or a paper sheet there definitely exposes that to with convection, and again a heat loss can occur. So these are various ways a baby loses heat in normal circumstances. At the same time, we need to know how are we going to measure the temperature of a baby. Because in an adult ICU, probably when there is fever, we are looking at measuring the temperature. While for a newborn, we need to do it even in a normal baby once daily. In a term baby, we need to have thermometers, at least which can record up to 30 degrees centigrade. So low reading thermometers. In a low birth weight baby, 2 to 3 times in a day, 4 times in a very small baby, less than 1.5 kg or VLBWs. 2 hourly for a sick baby or at risk, or a baby getting exposed to major surgery. And frequent assessment by mother using touch, though it may seem to be crude, is to be encouraged so that we pick up early as the baby in the cold stress. These are the various methods how to be done. Probably we need to look at that our nursing care, nursing persons as well as mothers are trained in looking at hypothermia by human touch as well as by the various. And again, the duration for which you need to keep the thermometer. For a newborn, it's 3 minutes in axillary, or rectal, it's 2. Nowadays, rectal thermometers are not available, and most of them are digital thermometers. So they give a beep when the temperature is red. So this duration does become unimportant in those circumstances. This is the standard WHO classification of grading of hypothermia. And here, this has been well proven in all the studies that a baby in moderate or a severe hypothermia, increased mortality is seen in all those. So we have to be very, very careful that if at all we don't allow it to go beyond cold stress or mild hypothermia, a baby, and should not remain in a longer time for in any stage of hypothermia to decrease the mortality and morbidity in them. Okay, what are the factors which in a newborn cause this hypothermia, or they are affecting the thermoregulation very significantly as compared to adults? Is the brown adipose tissue, the body surface area, as I initially talked about, glycogen stores, which could be variable depending on the growth restriction and the gestational maturity. Body water content, we all know that it's much, much higher. And because of the surface area, you keep losing it very fast. Posture of the baby. A term baby has more flexed posture than a preterm baby and gets more exposed to heat loss and fluid loss. Plus, add to it the morbidities like hypoxia, hypoglycemia, developmental characteristics, some CNS injuries, sedation, sleep, everything can affect the thermoregulation of a newborn. Why are they more susceptible? That I already discussed part of it. One is large surface area, limited heat generating mechanism. This is very, very important compared to adults. Vulnerability to getting exposed due to dependency of the baby, because baby cannot say that is feeling cold or is getting cold. And it is going to be our responsibility to keep the babies warm. Additional factors in premature and low birth weight babies are decreased subcutaneous fat as well as brown fat. This brown fat is very, very unique to newborns. More permeable skin, again, more the baby premature, more permeable would be the skin. Poor homeostatic response, and the larger surface area in preterm again weighs more. So when we look at the physiology, mammals are the homeotherms. Homeotherms means you are able to maintain your near constant body temperature even when subjected to wide range of fluctuations of environmental temperature, because we find methods to do it. Response to environmental temperature changes, and it includes the sensory arm, central nervous system centers, and the effector arm. Skin and hypothalamus provide the sensory arm. Once these receptors sense that there is a drop in temperature, the central thermostat in preoptic area near third ventricle in central nervous system gives sensors to effector arm like vasomotor response, metabolic response, and sweating. All this are compromised in a newborn. Okay, this is just a basic summary. We'll a little bit dilate on it, that metabolic processes like brain, heart, liver produce the most metabolic energy, metabolism, glucose, fat, and protein. And the amount of heat produced by this varies with activity, state of health of the baby, and the environmental temperature. Voluntary muscular activity of the baby again would, and whenever the baby is exposed to cold, it would try to conserve the heat by assuming a flexed position. For a preterm, that is again a limiting factor. Peripheral vasoconstriction, and a very important aspect is the non-shivering thermogenesis, because the heat is produced by metabolism of brown fat. I'm coming a little bit details of the brown fat because they are unique to newborns. Brown fat basically is an important organ of non-shivering thermogenesis, and it's a preferred fuel and is a free fatty acid. The full-term infants have brown fat almost 4% of body weight, and it's laid down in the last trimester of pregnancy. So lesser the gestation or more the preterm the baby, the availability of brown fat for thermogenesis for non-shivering mechanism is going to be available is less. It is well established, but by 22 weeks of gestation, some establishment of brown fat starts, and 90% of the total body fat could be by 29 weeks of gestation, disappears by 3 to 6 months after birth, and it disappears early in cold stress infants. Hypoxia definitely causes impairment of this brown fat metabolism. Okay, which are the areas where there is a brown fat? It's in all the shaded areas. Plus you have scapula, kidney, adrenal glands, head and neck, and axillary region where you have concentrated brown fat in neonates. Okay, the characteristic of this brown fat is it is so-called brown because of increased presence of vacuoles and channels that more than the white adipose tissue. And these are more, I already told you that these are the areas where they are concentrated. Microscopically also, they are different compared to white adipose tissue. As soon as I told earlier, that environmental temperature decreases, there is increase in blood flow. Brown fat is very well supplied with blood arterioles and capillaries. Even thyroid hormone plays an important role for the brown fat to respond to norepinephrine, and the non-shivering thermogenesis inhibited by many anesthetic agents as shown in experimental animals. So for surgical, this one has to remember that as well. It has long been known that brown fat is the main reason for heat production by containing a protein called uncoupling protein 1. This dissipates the proton gradient from across the mitochondrial inner membrane, and the magnitude of proton leak may be the contribute to the increased metabolic rate when you find that a baby has become hypothermic. On stimulation, as we told that the cold receptors get stimulated, norepinephrine gets released from the nerve endings, and the effector receptors in the brown fat are activated. And the set of chain of steps start occurring, and the heat so produced is distributed throughout the body as a result of brown fat's proximity to blood vessels. A basic difference between the brown fat and a white fat. Okay, there are a lot of vacuoles, while in white fat are none. Good vascularity, good number of nerve fibers, more mitochondria. It gets stimulated by cold, while white fat gets stimulated by starvation, as it happens in adults and older children. And main function of brown fat is heat production, and which is what is most important, while for white fat, it is the nutritional calorie giving function, which is the white fat's function. So whenever a baby is exposed to cold, the receptors in the skin are stimulated, non-shivering thermogenesis is initiated, conversion of brown fat uses oxygen and glucose. That's an important thing that we need to remember. And that's how hypothermia leads to hypoxia and hypoglycemia. Like a child who is hypothermic, immediately we would check the saturation, may need oxygen if it's dipping onto it, and check blood sugar. If needed, we need to cover him up with that. And at the same time, maybe even extra fluid could be required there. So cold stress neonate will become hypoxic and hypoglycemic. Neonates would try to conserve their heat by peripheral vasoconstriction, increased anaerobic metabolism. Pulmonary vasoconstriction, again, prolonged hypoxia can lead to pulmonary vasoconstriction and pulmonary hypertension, raised pulmonary pressure, and further acidosis because of the anaerobic metabolism. So this is basically a major metabolic triangle is if you have adequate oxygenation, your temperature is normal, your blood glucose is normal, then the baby would be in the normal state as compared to if only temperature drops, oxygenation requirement could increase and the blood glucose could drop. So it's a very, very important metabolic triangle, three of them have together, along with that perfusion. One more thing which we need to remember, especially when we are taking care of preterms, the cold effect leads to decreased surfactant efficiency, so which could worsen our hyaline membrane disease. There is increased oxygen consumption already, as we learned earlier, increased utilization of calorie reserve. And when it occurs in the later part or in the post-operative recovery period, if it's occurring, your postnatal weight loss and poor response to weight gain could be occurring. So it's an important impacts which could occur soon after birth, during the stabilization phase or in the recovery phase. These are the common. One more thing, I think all of you know about it, that neonatal symptoms are all of them overlap. Could be any, it could be infection, it could be hypothermia, it could be hypoglycemia, it could be hypoxia. So you have all the symptoms which could be akin to a neonatal hypothermia as well. So we need to keep, and that's why we call it TOPS, immediate check of temperature. What are the methods by which we can treat this hypothermia? Mild, very simple. Remember that you put a cap on the newborn head, cover the mother and newborn with warm blankets, kangaroo mother care, skin-to-skin contact. For moderate, you definitely need an in-house treatment with a radiant heater or an incubator, heated mattress. And if there is nothing available, definitely start early skin-to-skin contact and keep the room temperature around 25 to 26. In severe, yes, very much associated with higher mortality, morbidity. And remember, your warmer temperature has to be around 1.5 or 2 degrees only higher than baby's temperature. The temperature difference gradient should not be very high when you are rewarming the baby. The rewarming process has to be a gradual and very, very important, and you have to take care that this occurs methodically with monitoring. Okay, so though it looks that it's been baby's head is covered, very important aspect, even in the ward, even in the during the operative phase, if not needed, the head needs to be covered. Okay, baby could be placed on this cling wraps, and that can decrease the fluid as well as the heat loss. Various incubators could be used. We especially when you are taking care of less than 30 weeks preemie, they would be a preferred. When in large NICUs, they are sometimes difficult with humidity control and other asepsis protocol not properly taken, can become for a portal for infection as well. These are very commonly used by most of our centers as well as all of you, radiant heat warmers. One more thing which we can do is do a cling wrapping over that so that the fluid loss also can be reduced, because open care system have a major impact is that fluid loss is not prevented when the babies are kept, especially very sick, surgically operated. They cannot be fully covered. A baby who is growing in NICU with a nest protocol, yes, you can keep him well covered with all position. But a sick or a baby who needs very intense monitoring, we need to keep them exposed. At that time, the cling wrap covers are the best to decrease the fluid loss. Just a minute. Okay, skin-to-skin contact, kangaroo mother care, though it started initially as a resource limited or restricted institutions, one of the methods, but now it is well accepted all over the world and has become an important aspect of bonding, keeping the baby warm, improved developmental quotient, and many other things. But one very important aspect is it keeps the baby warm. Various ways we try to do in our units. This we had to adopt to during the COVID protocols. Otherwise, mothers keep like this. Here, one thing which is missing is baby's cap, which should have definitely been there, while here it's there. So even during KMC, covering the head is very, very important. Okay. Other things is you monitor the temperature and observe for instability. Methods to keep baby warm, we've already gone through. Keep the neutral thermal environment in your nurseries, your postnatal wards, your post-op wards, your step-down care, your recovery room, everywhere. This is very, very important that one looks after, along with keeping the baby with all the other coverages. And then whatever you are using, you need to be very well aware about its function, its side effects, because when we are using technology, when you are putting the baby on a radiant warmer and your servo control probe is out, babies do get hyperthermic or heated up or scalded. Okay, so that is something which we need to remember. So when we look at the prevention of hypothermia, for conduction, warming blankets or drapes, which should be warm, head covering, very important. Warm solutions, infusions, transfusions. I think this is one thing which we need to remember, because whatever fluids are being given, sometimes the ICUs are cold, sister takes out from there, and when she starts giving those fluid to the baby, it can be disastrous. Convection, room temperature anywhere around 25 to 27. Keep neonate covered inside the incubator also, unless until in a high-risk phase of critical monitoring. You need to check that heated, humidified, inspired gases are there when you are giving oxygen, because high flow oxygen through an oxygen hood, which is not warmed, can lead to hypothermia. You can use plastic bags, wraps when you are taking care of preterm babies. Last one slide on hyperthermia. We are all, yes, obsessed with hypo. But in a tropical country like ours, during the month of May and June, we see very, very commonly dehydration, fever, and hyperthermia coming from our underprivileged population who are staying in their houses are not pakka, or they are in those under asbestos sheet. So, and the technology also can cause error and you can have hypothermia. So as a neonatologist or anybody who is taking care of newborn, hypothermia is also an important aspect which needs to be monitored, because newborns don't develop temperature very commonly. Even for sepsis, they come with hypothermia. So anytime body temperature more than 37.5 is fever, is frequently result of environmental factors. So that is something which we need to remember. It less likely to be a sign of sepsis, and however, regardless of cause, hyperthermia can have hazardous consequences. Okay, so that is something which we need to. Overheating from incubators, radiant warmers, ambient environmental temperature, very common. So even a baby under radiant warmer, under servo control, technology can fail. So the nursing staff has to monitor the temperature of the baby, maybe 6 hourly, 4 hourly, or 2 hourly, depending on the sickness of the child or the criticality of the child. Maternal fever, maternal epidural anesthesia, phototherapy lights. Now with LED lights, we have decreased this. Otherwise, this was also very high. Excessive bundling or swaddling in summer months. Infection, CNS insults like asphyxia, dehydration, all of this could lead to hypothermia. So we need to be sensitized about it, and many times have to pick them up. They could have come up with tachycardia, warm extremities, flushing, dehydration, lethargy, irritability, and a weak or excessive crying. And consequences of hypothermia would be hypotension and dehydration due to fluid loss, massive insensible water loss. It could lead to seizures and apnea and hypernatremia. So these are some of the severe signs and symptoms which could occur in a baby who suffers of hypothermia. And management, first is adjust environmental temperature, move away from the source of heat, undress partially or fully the baby. One should lower the temperature in your warmers and incubators. And remember, extra fluids needs to be given because they always get loose fluids along with temperature gain. And during the cooling process, the temperature has to be monitored every 15 to 30. And whenever in a severe hyperthermia, you are using sponging, the water has to be just 1 to 2 degree lower than the baby's temperature. That's why we call it tepid or a tap water sponging and not a cold water or a chill water sponging. Cooling devices are not recommended. That's very important aspect because somebody could put those cooling gels on the baby to acutely bring down the temperature. And if the baby in that sickness is not able to feed well or take orally, you need to give intravenously extra fluids or through the IG tube. That's an important aspect that one needs to remember with hyperthermia, that fluid loss is going to be significantly more. I think with this, I will conclude the thermoregulation and its physiology and the management of hypo and hypothermia. Thank you so much.
Thank you, madam, for covering the topic thoroughly. The topic which is usually overlooked by the surgeons. Since there is no question in chat box and we are running late in the session, we will conclude the session here. Thank you, madam.
Thank you. Thank you so much.
For the next session, it's an honor to introduce Professor Amit Dinda. I know him since last 17 years, and he's a brilliant scientist and an excellent pathologist. He's been working on renal pathology throughout his life, but over the last decade, he has focused on nanotechnology and guided many PhD students through this new technology, with him exploring the venue for India. So today, he's an ICMR scientist at the Department of Pathology, AIIMS. He's also the Chief Coordinator for the Center of Medical Innovation and Entrepreneurship at AIIMS. He also has honorary professorship of Deakin University, Australia, and he's the General Secretary of the Indian Society of Nanomedicine. Welcome, sir, and thank you for accepting the honor of being our speaker here today. We would like to hear more from you. We can see you.
Yeah, thank you. Yeah, thank you very much. I hope you can hear me. Thank you for giving me opportunity to interact with the pediatric surgeons. It's a very interesting and very important area which is coming up. And I'm sure after around 20 minutes, you will be convinced that in near future, the medical practice will be greatly influenced by application of nanotechnology in various aspects of medicine, including some of the surgical procedures. Now, if you look into in this slide, this I have borrowed from obviously one of the books. See, the nanotechnology applications are basically wide range, every sphere of life, ranging from textile, your renewable energy, environmental remediation, electronics. You are using these hi-fi, the cell phone and gadgets. Many of them contain several nano-based chips. Food agriculture, different industrial practices, including different kind of steels and other materials are actually using the nanocarbon and many other nanomaterial. We will be focusing mainly in the healthcare in the next couple of minutes. Now, what is nano? The concept of nano is very simple. We are generating the material or particle in the size of viruses. Now, in this small size, when you reduce this material, the material acquire a very special properties. Its actual surface area in relation to its mass increases tremendously, and as a result you can have a very interesting functionality coming into this material, and we can make these material out of the polymers, out of the lipid, protein, organic molecule, metals, ceramics, anything. And obviously this can be used for various purposes, which I am coming to. Now, if you look into the progress of the nano, I think now in 2020, after 2020, the new discipline of the nano system has been there. There are new industries mainly producing these different kind of nanomaterial, the nanopharmaceutical industry, nanoagri industry, they are coming up. So it's actually changing the total the disciplines, the new industry portfolios, and also the social impact is also becoming changing very fast. Now, if you look into the actual application of the nano and investment in industry, the more than $3 trillion is invested in the nanotechnology development. And in fact, to give you the example, I'll come to that point. Most of the vaccines which you are taking, Pfizer, Moderna vaccines, they are all using the different kind of nano adjuvant. Now, if you look into the nano, say this is actually area of cutting edge medicine. Now, also the other term we use is that the emerging technologies in medicine. Now, broadly, they can be divided into three categories. For imaging, the nanomaterials are being used in many a setup. Preclinical setup, there are a lot of these imaging systems are being used in animals, but in human system also, some of these imaging systems are coming up. This helps in early diagnosis as well as functional imaging. I'll come to that point. One of these systems we are developing for functional imaging for detecting sentinel lymph node. Similarly, you can do imaging and therapy together. Like you can image the metastatic cancer cells and activate the therapeutic molecule to kill them at the site of while you are doing the imaging or after imaging. In for therapy, there are a lot of these targeted therapies which is being used in particular in cancer therapy. There are multimodal therapy where we are using the photothermal or heat. We are using the magnetic current, electrical stimulation. So many of these things can be done together with the nanomaterial. And finally, I think the latest in the block is the nanobiological or nano electromechanical systems, and that is we call nanorobot or nanobot. Now these are coming up in a big way, and in near future, this is going to change our whole diagnostic practice. The huge labs which we are using to give your serum, the HbA1c, urea, creatinine, all those big instruments will be replaced by the simple bio-nanochip based system where these things can be performed even in the bedside, and also the data generated can be directly put into your system or even come to your mobile. So those kind of systems are also coming up. They are in the practice and also in trial in various countries, including India. Now, if you look into this whole scenario, basically wherever we are using these theranostics, imaging, targeted drug delivery, including there are a lot of tissue engineering where you are using these different kind of nanomaterial applications. But finally, the most important thing is safety and compatibility. So that's why nanosafety is becoming a huge subject in our regulatory science. I'll also come to that point later. In AIMS, we are fortunate to develop these nanomedicine research over the years, and where we have amalgamated the technical people and along with the basic scientists, because you need a lot of the physics and chemistry, particularly click chemistry, and also obviously the doctors has to be there in this team. Otherwise, application side would be very difficult to do. If you see that you can combine the medical and biological sciences with the technological side, and here actually we have expanded our research in the diagnostic area, in therapeutic area. In diagnostics, actually all these nanosensor imaging and molecular detection lab on chip systems we have worked with, and with different kind of nanosystems. And in therapy, drug delivery, thermal ablation, tissue engineering, and stem cells, which we are using our stem cell facility. And then the oligonucleotide delivery or DNA RNA delivery, gene delivery. Antigen delivery is the one which I'll show you some example where it's basically there are several, the injectable, the antigen can be converted into a oral vaccine development platform, and that will be much easier to administer and much more effective than even the injectable vaccines. And obviously it's not possible to give you all the examples of these kind of work which we are doing over here and others are doing across the world. But in the next 15 minutes, I think I'll give you some of the examples which will convince you that how this technology is coming into clinical practice in a big way. Now, the first, I think the most important thing is the nanotechnology application is the drug delivery. This drug delivery is more of a targeted drug delivery. Now, the greatest application of the nanotechnology is that when you are giving either a oral dose or a parenteral administration, you have to attain a serum level, a particular serum level, and then it will be effective in your site of the injury or site of infection or in the cancer area. Whereas in nanosystem, we can actually target our drug to that site of infection or site of disease, so that your serum level is not very important for us when we are doing targeted delivery. So as a result, the total amount of drug which is needed to give a efficacy or effective therapy is very, very low. In certain situation, it may be, I think, less than 1,000th of the conventional dose which you are using nowadays. So that's why it is becoming a game changer now in several of the areas. Now, the one of the very important example I can give you, we have developed the chitosan cholesterol base, the oral amphotericin B delivery and system, which the amphotericin B can be given orally. And in fact, now we are developing this system for clinical trials through FNDR, that is Foundation of Neglected Disease Research, which is the Indian Foundation of AstraZeneca. And we are hoping that in a year or so, the clinical trial will start. So this will totally game changer in the treatment of the systemic fungal infection, where it's a conventionally, I think you are using ambisome. We are using obviously cholesterol chitosan system, but instead of the parenteral injection, we can give it orally. And this is much less toxic than the conventional ambisome, and the efficacy and the documentation part also we have published. Then there are other targeting system we have developed, like you can target the macrophages, which are harboring many of the infection, particularly tuberculosis, where your payload can enter into the infected macrophages in the cells. You can do the folate receptor based targeting for breast cancer, and this the model we have shown that it can reduce this cancer in the mouse and rat model. And even the multiple drugs can be loaded in single nanoparticle, and particularly here we have loaded the 4 antitubercular drug in a single nanoparticle. Advantage of this system is that if you target them to the reticuloendothelial system and macrophages, their efficacy for the intracellular infections are pretty high. Now, cancer nanomedicine is very, very advanced. You know, many of you are using, particularly in the oncology sector, many of the medicines are being used nowadays. And these are the examples. I'm not going to the detail of these cancer nanomedicine. Mostly they are liposomal. Some of them are also containing the polymer. The molecules are paclitaxel, doxorubicins, and mainly these are the two which are most commonly being used. And there are a large number of these different kind of the nanosystems are in second phase and third phase clinical trial. And I think we have not reviewed now. I think a couple of them have already come into the market. So that means the nano drug delivery is no longer under research. This is actually in coming into therapeutic practice in a big way. Now, in Indian industry, if you see, is not also doing a great job. They are advancing very fast. If you just see, I think in the next 10 to 15 years, Indian nanotechnology market is supposed to grow almost to 1.6 billion US dollar. And I think the currently the infections and anti-infective therapies are also increasing the application of nano. So there is a lot of companies in India also developing nanopharmaceutical now. Now I will quickly give you certain examples of these the imaging system, how the nano can be used. The gold nanoparticle, it has got a very, very image intensifying capability, but you have to realize your particle size has to be very low. Otherwise, it will not go out through the glomerulus and in the urine. So we have shown that if you can keep the size between 5 to 10 nanometer, then the 90%, 99% of your the drug will be particle can be excreted through urine after 15 minutes, and that's why it may not have any sequestration associated toxicity. Now, these are the animal studies. You can see in the right side, the enhancement of this tumor can be done with these injection of this gold nanoparticle. And we similarly, the iron oxide nanoparticle can be developed for MRI based imaging. And here we can conjugate them with the tumor targeted receptor so that you can detect the tumor very early. And these kind of systems are also being developed, and in near future they will be replaced the conventional the systems which you are using for MRI. Now, in vivo imaging is also becoming very important, where we are using the near infrared range the molecules. Some of these molecules are already US FDA approved, like the indocyanine green, and these can be conjugated with the nanosystem for during the perioperative procedure, preoperative, and postoperative procedures. Also, the quantum dot or this kind of fluorescence can be used for, I think, in vitro system. They are toxic, so we cannot use them in vivo. And we have developed the indocyanine green based technology where you can use the by orally, if you can give, they can map your reticuloendothelial system, as you can see in these images. The one of these systems where we have developed the gelatin nanoparticle, and they are tagged with anti-cytokeratin antibody, and then also we have tagged them with the technetium 99. Now, if you inject them in the same way as you inject the sulfur colloid, radioactive sulfur colloid, or the other blue dye into subcutaneous tissue to detect the sentinel lymph node. Now, this system it should be much more specific, because the preliminary data also is very encouraging, and in fact we are now developing it for clinical trial. And this initially is developed by our collaborator in the ENT department, Dr. Tucker, and we will be, I think, trying to use it for head and neck cancer. And here the advantage is that if you add the technetium 99 labeling, then from outside you can use the map these the lymph node where the cytokeratin positive cells, that is the epithelial metastatic cells, are there. So they will be fluorescing very specifically, rather than non-specific, the sulfur colloid based the radionuclide when you use, they give a lot of non-specificity. So here we can develop a lot of the advantage of the using nanotechnology. Now, this is the sum up that how the functional imaging scenario is getting totally transformed with the application of nanotechnology over the years, including PET scans and other functional imaging. Now, I'll give you quickly the example of the vaccine development. As you know that I have told you the COVID-19 several vaccines are using nanotechnology. Now, the advantage of using nanotechnology is that the antigen can be carried to this lymphoid tissue, and the antigen presentation can be enhanced, and that's why you can get very enhanced immune response and heightened immune activation. Now, we have developed a 14 kD polycaprolactone based the nanoadjuvant, where you can load the antigen, and if you can give the antigen orally, and within the 3 to 6 hours, these are all absorbed, and you can see them in the mesenteric lymph node and also in the systemic lymph node like inguinal lymph node, and these are the around 60 nanometer particle size, and you can see them in both the mesenteric and inguinal lymph node and other lymphoid tissue. So that indicates that even after single dose oral delivery, the large number of lymphoid tissue, this particle can carry the antigen, and it produces a huge immune response. Now, we have used the polycaprolactone, which is a slowly degrading polymer. So that's why the half-life of these after one dose is almost the 4 to 8 months. So that means for this kind of vaccination, single dose will be sufficient. You don't need to give a booster dose for this. In fact, our preclinical trial with the mouse and guinea pig systems has developed excellent result for hepatitis B vaccination. And I have also initiated our work with the COVID-19 vaccine, oral vaccine development. Now, coming down to the photothermal therapy, which will be very important for the surgeons and you people, because here we can actually develop this particle. The easiest one is to develop the gold nanorod. The rod separate the gold nanoparticle. If you irradiate them, or if you show them the light of some of these wavelength, which is near infrared wavelength, then they can produce the heat. And this heat, you can see, they destroy the tissue. Here, one subcutaneous tumor is getting ablated with this photothermal therapy. Now, we have developed a interesting system for management of the superficial bladder cancer, which is very difficult to treat, where we have done the gold nanorod, covered them with the alginate, which is the mucoadhesive polymer. In the alginate, we have loaded mitomycin C. And when you put them, irrigate them in the bladder, it gets, because of mucoadhesive polymer, this particle gets attached to the surface epithelial cells. And for want of time, I'm not showing our validation experiment. And it really sloughs out very easily only the cancerous epithelium. and without doing any damage to these underlying the muscle and the tissue, we believe the mucosa. So this kind of system can be developed very easily with the application of nanotechnology. Now, silver nanoparticle is coming in a big way in anti-infective management of wounds and many other things. A new kind of dimension of being used also. And similarly, the new area which is expanding is the nanoradiopharmaceuticals. I think in a near future, this will change the whole scenario of the cancer therapy, where your radiotherapy dose can be reduced drastically without many side effects, and you can enhance the tumor ablation. Now, next comes the nanobot. I think I took this photograph from a science fiction book. See, this is the science fiction book where this kind of nanorobot can be developed, which actually find out your disease cell and catch them and kill the disease cell, or sequester the disease cell, take them away. So basically, these are science fictions, but now truly this is now feasible, and it is being done at least in the animal model. Now, this system, if I show scientifically, these are the micro nano electro mechanical system. You can imagine you can make a motor in the size of 2 to 3 micron. Now, those motors are available even 10 years ago, but nowadays the motors can be done in the nanoscale, say around 100 nanometer, 200 nanometer. So at that the small level, you can have your particle, which will be either carrying a mechanical device or it carrying a biomolecule, which in fact can be targeted to the cancer cells. So this kind of nanorobot nowadays is also possible to control from outside and also give it the artificial intelligence based system into this. So that means it's no more science fiction. I agree that these are being tried in the animal now very successfully. It will take a little bit of time before the clinical trials start, because we are little stuck with that how to retrieve these nanorobots after we inject them inside the body. So I think that there are different kind of research is going on, and I'm sure in near future this will help in the surgery also, where you are removing the dead tissue or abnormal tissue. You can use this kind of nanorobotic device which will scavenge that whole area under your control, and then you can take them out from the body. So obviously those are the technologies is very high end. Now, how do we power these nanobots? Like if just putting inside the body will not help them. So the three interesting technologies area is being developed. One is biohybrid. Here what you do, you pick up one bacteria, make them non-pathogenic and or virus, and put your the drug or any other material inside that. And say for example, Listeria monocytogenes has been used in animal model, and here this bacteria goes inside your system and target the tissue where this bacteria has a natural affinity to. Similarly, that is true for virus. The other method is that chemical method. I think you know that the battery, the electric current is generated with the electrolysis. There are different kind of ionization can be done. Similarly, one can generate by chemical reaction the energy, and which can have a nanorobotic function. The physical methods are also already being used. That is magnetic nanoparticle. You can move inside the body. You can use them for penetrating the different tissues. So and also the polymeric gripper has been developed. The photograph I shown like that, this kind of gripper polymeric nanosystem can go and detect or and catch the cancer cells also. So those very interesting areas of work are being done, and in near future it may come to clinical practice. Now the other very recent area of expansion where the antisense oligonucleotide are being used for treating many of these congenital diseases, which are very difficult to treat. So gene therapy, conventional gene therapy, this is a little more advanced kind of gene therapy where we are using antisense oligonucleotide, and then the using nanotechnology, we are actually targeting them to these specific tissues. Now, this is a mainly lipid-based system, and many other systems can be used to develop this kind of oligonucleotide therapy. I'm not going to the detail. This is the list of these therapy, the material which is now coming into the clinical trial, and already 2 of them have been sanctioned by US FDA for clinical trial. Now, all these nanomedicines or nanomaterial what we are developing, they are not classical conventional drug. They are also not the other way biotechnology or biological system. This is a hybrid system. So we are calling them non-biological complex drug system. And if you see, these are your different kind of drugs. And in between, you can see that the nanomaterial or nano-based systems are also coming up. So that means in the near future, obviously, the whole scenario of your classical management of cases will be modified by application of nanotechnology in a big way. For this, I think in our country is also advancing pretty fast. We are, I think, third in terms of publications in the nano area in the biomedical application, and the pharmaceutical industries are also doing very well. We have also developed the nanosafety regulations for Government of India. And I think I can conclude that the nanotechnology is definitely is going to revolutionize the medicine in near future, and it will be applicable to all branches of medicine, including maybe the surgery also. Thank you for your kind attention.
Thank you, sir, for your exciting talk on nanotechnology. This was the first talk of nanotechnology for the pediatric surgeons, and you've told us a lot about drug delivery, vaccines, and I'm sure all pediatric surgeons will be thinking about it on how they can explore it further into pediatric surgical anomalies. I've been listening to you about nanoparticles used with gold over these years. How expensive is it? And how do you look at Ayurveda, where they have been putting gold particles and silver particles in their compositions? Though they do not do it scientifically, we need to help them with that. So do you think that also involves some kind of nanotechnology?
Yeah, so basically the unfortunate part is that the actual Ayurvedic process to develop the different kind of bhasma, that is metallic nanosystems. So it is not, procedure has not been inherited properly from our ancestor. So the currently what the bhasmas we are developing, the majority of them are very mixture of the different size of particles. So that is creating the problem. As we have shown and published that if you can develop, say, the gold or Sarma Bhasma or gold particle in the range of 5 to 10 nanometer, then it is non-toxic. It goes outside the body very quickly. So similarly, you have got the iron oxide nanoparticle, but the issue is that it is really possible to use these nanosystems, and silver nanoparticle is already as anti-infective, and this is known in Ayurveda also. So that means it is possible that with refinement and little bit of scientific attitude, many of these the system can be brought back with a more quality consciousness. I mean, that is very important. And cost wise, it is not very costly, because the very small amount of gold and silver you will be needing to generate this particle.
Your nanobots were very interesting. So you talked about taking them inside the cell and finding it difficult to bring them out of the body. In future, is there any possibility of having biodegradable nanobots?
Yeah, exactly. So basically now I didn't show because of time. In fact, there are a lot of new materials which are coming up where its degradability is timed. So basically we know that they are getting degraded within 12 hours. So 6 hours like that. So immediately in couple of minutes, an hour, you can do your activity, whatever you want to do. And after that, they can be degraded itself. Yes, it is possible.
Thank you so much, sir. That was an excellent talk. Thank you so much.
Thank you. Thank you very much.
Thank you, sir, for a very excellent talk. Now we'll move to the next session.
Yeah.
The next session, I'll invite our chairperson, Dr. Ramesh, S. Ramesh, and Dr. Govind Dattar. Dr. S. Ramesh.
He's not there. Dr. Govind Dattar will be joining us.
Dr. Govind Dattar is joining us. And then we'll introduce our.
Meanwhile, Mr. Khalid Sharif may share his slides.
Mr. Khalid will be speaking on overseas opportunities for training for pediatric surgeons. Dr. Govind Dattar will introduce him briefly.
You can put your slides in slideshow, Dr. Khalid. Shall I come?
there used to be a stage fear phenomenon. Now I got computer phenomenon.
Introduction.
It's not my table. Introduce करो.
Mr. Khalid Sharif, we are delighted to have you here. Mr. Khalid Sharif is a clinical lead in the liver unit, and he's the head of the pediatric hepatobiliary and transplantation at Birmingham Children's Hospital. He's also the clinical director of pediatric surgery. He's the associate chief medical officer for international doctors at Birmingham Children's Hospital. He's also the associate chief physicians associate UK. So we are delighted to have you to speak on overseas opportunity for training for pediatric surgeons. I would request all the seniors and the junior colleagues and the residents to kindly hear his talk very nicely so that you can explore the future possibilities of going abroad for training. Mr. Khalid Sharif.
Good afternoon. Can you hear me?
Yes, we can hear you.
So thank you very much for a nice introduction. And after listening to very nice talk on nanoparticles, I was slightly worried that would I be able to live up to the expectations. So some of you who have been to Birmingham, this is how the Children's Hospital was, and still part of the Children's Hospital is like this, which is a classical old heritage building. And the front, we cannot change anything on this building. But for the future, this is our extension, and our new hospital is going to be, at the moment, is under construction, and it is going to be inaugurated in 2027. But this part, which I'm showing you, is currently working. So you can see that the change from a classical to this, box formation, colors, and if you come at light, it is illuminated in different colors. So that is how the technologies develop in the countries like ours as well. So when Amar asked me to speak about it, I was slightly worried to say that how should I put it? Is it the opportunities which looks good on the other side and I make it attractive, or is it the opportunity for our youngsters to jump out of the congested pool of the local challenges and then find the opportunities? So I will try to balance my talk in a way that there will be enough time at the end to ask questions, because this presentation is just to give you just a thought process. Just if you go on.
Mr. Khalid, can you please switch
Sorry?
on your video? We would like to see you as well while the talk goes through.
I did it, but somehow it's not letting me. I don't know what's going on. I put it on actually. There is some reason I can't share my video. I don't know why, but because I put it on and it's not.
It's okay, don't worry.
I think it's the internet problem from my end. So, like I was saying, that is it the opportunity of escaping from the day-to-day challenges, or is it the opportunity to get something which is better and then to make your future in a slightly different way, or shape your future in a slightly different way? So if we look at our British Association of Pediatric Surgeons website, pediatric surgery is no more pediatric surgery like we used to see in the past. You can see these are currently our established specialties. Some of them are completely independent, like hepatobiliary, urology, fetal medicines, minimal access. So the good old days of general pediatric surgery is now getting into specialized pediatric surgery, and also, which is the encouraging thing, and this is one thing which I I want to let all my seniors here know that how would it be make our youngsters to start moving into the field which in the past has been predominantly dominated by the adult people. The example I give you is the orthopedic surgery, the neurosurgery, the cardiac surgery. If you see even currently, most of the people who are becoming the pediatric, say for example, the cardiac surgeons, they come from adult background, then get the training in pediatric side and become pediatric surgeons, pediatric cardiac surgeons. And the challenge I have is that why can't we as a pediatric surgeons develop something in our trainings where some of our trainees then can get the exposure into those fields, and if they want to explore the options of going into the those specialities, then it makes it easy. Giving my example, I'm a pure pediatric surgeon from day one, and then I have to fight in the world of these adults to become a transplant surgeon. It's another full 1 hour talk, so I will not bore you all, but I can tell you that this was not a easy journey, and that's why I became very passionate about it. That whenever I get a chance, I will try to make the journey of my youngsters into coming into any field in pediatrics related. I will make it easy, and that's why it is my 10 and now it's 15 years now that I am fighting over it, and you will see that now I've reached to a point where I can actually directly support colleagues, help them to a little bit or guide them at least. So just taking it further, if I have to for the presentation sake, I have made it that somebody wants to have the opportunities only for short term, is it a medium term, or you're looking at a long-term opportunity. So there is a possibility in every field. Now, short terms, you have fellowships available. Some of the colleagues from India came to me for fellowship through the Commonwealth Office, and they have been with me for 6 months. Some of them came for 1 year. So, but that is something which is very limited. You can see because the Commonwealth Office take people from all over the world, and my current fellow is from Kenya. So they select the people from different places, and then obviously with the number of opportunities available, it's not huge. But if somebody who is already established, who just want to see 6 months to develop something, which then he can come back to India and develop that specialty in his hospital or in his area, that is a possibility. But my main talk will be around the medium term, which is 1 to 2 years. That's where I can directly influence now. And I will give you a little bit thought process around this, our long-term situation, that what is there and how my youngsters, if they want to achieve, want to enter into that side, what are the options there really. So if we look at the medium term, this is currently is called the Medical Training Initiative. It has been given different names over the years, overseas doctor training schemes and blah, blah, blah. But currently it is called Medical Training Initiative. And that gives you the opportunity that once you are qualified in your home country in a specialty, and we are talking to a pediatric surgery, you can come to UK for 1 to 2 years to gain further experience either in one of the subspecialties, which like I have shown in the first slide, or you want to just say that no, I want to just get my general pediatric surgical skills because that's where I'm working. I need the overall expertise in moving forward. Now, this scheme up till as some of you know, last year has been only for people who were outside Europe. But now we are equal with everybody, which means even the European fellows are also called the international doctors. So it means that they have to go through the same process which anybody from Asia or some other part of the world has to take. And that is the beauty of the scheme now. In order to work here, or you have to get the training here, which means hand-on training, you need 2 things. One of them is that you need to be registered with general medical practice, because otherwise you will only be allowed to just be watching, which I, as a surgeon, I know that you can understand, you can agree with me that that's not the training. You can watch it, but unless you have practically done it yourself or at least assisted in the process, it's not as having the experience of just watching. And the second thing is that you need to have a visa which allows you to basically work, which is the current challenge, and I'll cover that in a minute. So it is two things. Doesn't matter whether you come for 6 months, you come 1 year, you come for 8 years. You need these two things before you actually start working and start then entering into either a training program or enhance your training skills, or you just get to a very specialized short-term exposure. So the registration route at the moment with General Medical Council, one of them is the old classical one, if you remember, is the PLAB test. Now the PLAB test is going to be abolished. The plan was to abolish in 2024. Because of COVID, they have not delayed it. So the new name is called UKMLA, and it's the new test which will be launched in 2025. Again, that test will be done by everybody, including the graduates who are graduating from UK. So you can imagine that that test will have at least some time where our overseas youngsters will have to learn how to basically clear the test, because people here will be given that training during their third year, fourth year, final year medical school. But people from outside will not have any idea how to pass that test. As you know that currently there are very good academies available for PLAB, but people obviously will be setting up something to help. The other route which I will like to talk more is the route of what we call is this sponsorship by a approved sponsor, and that's currently the main route of medium term training opportunities available. All the other routes which I have, the JMC website tells you, are there, but they have got a long-winded routes basically. So what is the sponsorship scheme means? It allows the alternate routes to registration for international medical graduates. And the main ethos of this scheme is that it supports the training need of the international doctors. Meaning thereby in the past, people used to bring them only for service jobs, which currently is not allowed, which means that any post now which comes as an MTI post has a training component. And the second part, which they have made it very clear, and we have to obviously comply with that, is that this scheme should not be used for settling into UK. Meaning thereby that if you bring somebody here and then you extend, which is not possible, because the visa of this scheme is a kind of visa which finishes at 2 years, whether you have done 2 years training or not. Say, for example, if you go off sick, you have to go back home and for some emergencies. Once you land in UK, your clock start, and exact 2 years that clock stops basically. So that they have made these things so that there is not a brain drain from the countries like our countries in subcontinent, because the main worry people had was that this might be then used to attract people, and then there is a local shortage, which obviously is not a good thing to basically support. Just to give you an idea that what are the different UK institutes or UK organizations which currently supporting the application for pediatric surgeons. I have taken out all the other organizations. If you go to GMC website for sponsorship organization, it's a huge list, and I've just highlighted the ones which is only supporting the pediatric side. And you can see the Birmingham's, our scheme is there. Then you can have the Great Ormond Street, Hull, Leeds Teaching Hospital, Manchester. So essentially all the big children hospital don't have their own schemes, which mean that they help the international doctors to come for 1 to 2 years, and then to practice the field they want to develop. And then they have to after 2 years are awarded what we call is a fellowship certificate, and then they go back and practice in their countries. The Royal Colleges all the Royal Colleges are also offering it, but their scheme now is slightly becoming a challenge because if the Royal College accepts somebody, they need then the hospital which can accommodate that person. So for example, if I already have my own scheme and Royal College send me somebody, then you can imagine that I have to give preference to the priority to the person which has been recruited through our own process. So what are the basic requirements? You just need your primary degree to be verified from this electronic portfolio of international credentials called EPIC. You must have a postgraduate degree. So like MS in pediatric surgery is considered as a postgraduate for us. You must be practicing in the medical field in the last 3 years out of 5. So these two things, if I can, another message I would like to give to you all is, if somebody wants to come to the alternate route, then please don't take a break in your service in the last three years, especially last 1 year. And if you have more than 5 weeks of leave in the last 1 year, GMC will not let you be sponsored. Some of the colleagues, they go into the pharmaceutical industries or research industries. Please keep some part of your job in the clinical side in a recognized institutions, because you will need the reference from your referee. Now currently they have made it slightly loose that you need 2 references which covers last 3 years. So even you say, for example, last year you have not been working with somebody which can give you a reference, but at least if that person can certify that yes, you have been practicing pediatric surgery, you will get the sponsorship. And then is the evidence of English, which is the IELTS test. So it's not huge if you look at it, that it's the simple thing is that if you are in pediatric surgery field, if you have just qualified as an MS, you start planning because you are in the field anyway, and you can start thinking before you establish your private practice, that you come across, get some exposure and a fellowship certificate, and then go back and set your own specialized field. We do need some super specializations now coming, because that is the need of future. We can't have a person operating head to toe in a baby or in a 16-year-old child. So this is from the GMC website. If you can see, what we need is an offer from an approved sponsor, and then you can be given a full registration, and you only need your primary medical qualification to be verified, meaning thereby you don't need to have your MS degree qualified. Like I said, that our UK visa system changed since the Brexit has happened. So from January this year, UK had introduced what is called the UK point-based immigration system. And the points are given like this, that the first 3 points are fixed. So you cannot trade these 3 points, which is you need to have an offer from an approved sponsor. The job should be at your appropriate skill levels. So if you're coming as a doctor, as a surgeon, that is appropriate, and you can speak English, which is the IELTS. So if you have these 3, that somebody has accepted you as a trainee, then you already have scored 70 points. It's 50 points. And then what you need is a 20 point, which is you can be any one of these. And currently all specialties of pediatrics, as well as surgery, general surgery even, they are all considered in the shortage occupation list. So you get 20 points for that. So you make 70 and your application goes through. You don't need anything else. The long-term learning, this is the field which is that if somebody wants to come from the very beginning into pediatric surgery into UK and then go all the way to the top, that is an opportunity. But here the process is like this, that you need to have your core surgical selection and core surgical training, which is in India we call it as SHO level. Here it is called CT1, CT2. So you have to have that here, which means that if somebody has just qualified from any of our medical institutions, and he thinks that no, I want to get the full pediatric surgery training from UK, you can do that, but then you have to do the PLAB test and enter through the core surgery selection system. I'll just briefly touch how the selection process works there. But basically, you have to do 2 years of core training, and then you get the chance to be selected as ST3. Now, the number in ST positions are very limited, and you have to go through an open competition. So there is no guarantee that you will be entering into pediatric surgery. When you're applying, you sometime once you have completed your core surgical training, you might then end up into something which you didn't want to become. But the guarantee here is that if you enter into ST3 and you are selected, then you have a 5 years run-through training scheme. In the past, it used to be a granted certification, which means at the end you will be a consultant. Not anymore. Every year, if you hear the news, that a couple of people will be made to change their field of surgery because their training program directors don't feel that they can be a good pediatric surgeon. So they are made to either go into general practice or they have to make into the medical side. Even after graduation, people have been then taken off the specialist register. The structure is like this, that it's two principal stages. So you have to go through this 2 years of core training and what is required, and then it's this one just. So like I said, we have 100 specialized pediatric surgery training slots in the whole UK, but there are 24 centers, out of which majority of them are around London, but there are 1 in Ireland, 2 in Scotland, 1 in Wales, and then the remaining 21s are in England. But if you see, the recruitment process is through a formal application. There is a structured interview. You have to prepare your portfolio and then progress through a structured interview stations. And this is how it takes you through. So you have a 10-minute communication, 10 minutes through your portfolio, then 2 stations with technical skills, clinical, management, academic research. And so it is all the way through. And if I summarize it like this, this is how all the specialties have developed their selection programs. And you can see that once you are, this is the ST3 level selection, you have to have all these cleared before you actually move to the next stage. So once you have done that, it makes that you are back to if you are successful, you will reach the end, which means that you will be able to get the certification, and then you are eligible to practice as a full-time consultant in UK. The new thing which has just come, and you can see this is from January this year, that you can apply for a specialist registration directly from your home country. This is a document. If anybody is interested, they can start working on it. It's about 18 to 20 page long, which gives you the guidance over it. But what it gives you then is that you don't come as a SHO because somebody feels that, okay, I have done the training for 6 years. I'm already working as a senior registrar or, for example, assistant professor, and I want to go there as a consultant. Now, in the beginning, you can come as a locum consultant through a general route, which I have given you already. But if you say, no, I want to go there as a full-time consultant, substantive consultant, then you need to apply for, which is the Caesars route. And if you are successful, then you are eligible to compete in the open market with any post which is advertised for pediatric surgery. So this document is a guidance. So if anybody wants to take it, so I just want to summarize because I want to leave some time. So if colleagues, juniors have any questions, they can ask. There are a number of options. There are various support mechanisms now available. If anybody wants to avail, the opportunities are available at every level, starting from SHO to consultant, and these can be tailored to the need of the person who is coming. I put my email address down. Amar is there. There are a lot of other colleagues around who can give you my contact. If anybody wants to gain further support, I am here to help. So I will stop here, and if anybody has any questions, I'm more than happy to take those questions.
Yes, thank you very much, Professor Khalid. Now here is a question for you.
Thank you for your excellent talk and letting us know what are the various ways to go to UK and get trained. The international surgical training program is very good, which the general surgeons have adopted to a large extent, and the pediatric surgeons are not adopting it to a large extent, though few of us have gone there and got trained through that. Regarding the entry into the specialist register, there are two ways. One is to go through the PLAB, as you mentioned, and the second is to have a big logbook, and a lot of paperwork is involved in that to get through directly into the specialist register. Can you enlighten us more on that? How difficult is it, and what everybody should be aware of maintaining logbooks and their curriculum in place, because it takes time to go back and collect all your data for 4-5 years.
Thank you very much. I think that is the reason that in the past there was no clear guidance, and then that's why it was taking so long. So now you have this guidance document available, which give you what is required, what is the different sort of, for example, evidence required. So if you collect it, then it is not difficult to get it, because once you have all those things submitted, then the Joint Committee of Pediatric Surgery evaluates it, and then it's very hard for them to accept it. You have to remember that the situation here is that the numbers goes up and down, meaning thereby that you have few colleagues retire, and then you have consultant posts vacant. They will be very lenient. Once they start seeing that there is a saturation coming, for example, because they know how many pediatric surgery trainees, which are the what we call is a national training number, are reaching their final stages. So say, for example, next year, 2022, if there are 10 slots available and there are only 6 applicants coming from within the UK, they will start relaxing your process, and majority of the people gets it. Second thing which I have seen so far is I will because I don't have information around other specialty in pediatric surgery, I don't know anybody has been so far granted Caesar application from their home country. Everybody who got it is from UK, because once you come here, you can then start working around the people, you can get the references, and then it is slightly easy. So if anybody wants to achieve that side, I will request that come through the MPI scheme, make your contact, and then you can start working in terms of making the way through. But it is dependent on what you want to achieve really.
With the EU guidelines getting relaxed, there are a lot of Europeans now coming into UK to work. While it is still a problem for Indians, with you there in your position and other Indians who are there, can you help the Indian trainees to get jobs there by telling them about the curriculum and the hardcore training that they undergo in India,
exactly,
which makes them equitable to the training in UK, except for communication part and how to behave with patients right from the antenatal period. We're giving a lot of information and spending time on each patient. You see that part is still lacking in India because of our patient load, but the rest of the things, there's a lot of exposure here. So can the training in the UK get narrowed down? Like, is there any scope for that?
Yeah, that's what I'm saying. So the Europeans are not coming anymore because they have to compete like anybody coming from Asia. So they have to do the English test, for example. And most of them, they can't do the English test.
I can't hear you.
Can't you hear me? Can you hear me now? Can you hear me now? Hello, I don't know whether you can hear me or not.
We can hear you.
Okay. So what I was saying was that the Europeans have now gone. There is no European coming because they have to do the same kind of competition like ours, anybody coming from subcontinent. So they are equal now. So that challenge is gone. But the challenge we are facing is this is the opportunity now. So instead of just coming into pediatric surgery, if somebody gets, say, for example, 1 year in pediatric orthopedics in somewhere in India, or even adult orthopedic, somebody doing some pediatrics there, they get the chance to get into, and those are the specialties I can give you. In my hospital now, I have 3 pediatric orthopedic consultant posts vacant. I have 2 neurosurgeons required. I have 3 plastic surgeon I needed today. But the problem is that those kind of people are not being given the guidance, and our curriculum, all of you seniors who are there, if they can make something like in the UK, they have made it that adult trainee get 6 months of pediatric surgery training, that if our trainees are given 6-month specialty training during their 5-year training program or this MS program, at least that specialty will make them eligible to apply to the MPI in those fields as well. Otherwise, you come as a general pediatric surgeon and the numbers are small, or you come as an SHO, which I think will be somebody who has already done an MS. I think that's not fair with that person, basically.
Thank you so much for your talk. Thank you so much. We move on to the next session. I thank Professor Govindatar for chairing this session. For the next session, I would like to invite our president, Dr. Ravi Ramadwar and Dr. Ramesh Babu to chair this session. Both of them have worked a lot towards insurance for pediatric surgical kids. Please welcome, sir.
Where is it? Mute. It's already unmuted. Amar? It's a pleasure to welcome Dr. Prakash, the Managing Director of Star Health Insurance. He himself is a general surgeon with an FRCS from Glasgow, and he is very well known for many innovations in insurance sector. And the Star Health has special policies for diabetic patients, cardiac patients, cancer policy, and even children with special needs like autism. When we from IAPS approached for insurance cover for children with the congenital anomalies, this was around a year ago, he was so encouraging and said, why kids alone? We will include women also, right from ART, fetal therapy, neonatal care, and surgical treatment. So let us hear from him regarding the innovations by Star Health Insurance to help these children. Over to Dr. Prakash.
A very good afternoon to all of you, and thanks, Dr. Ramesh Babu. This is a very exciting, a very interesting session I have been hearing from the morning, from fluid electrolyte balance to blood components to the ultimate nanotechnology. I was just hearing your speakers, and it's really amazing to look at the works, particularly when Dr. Hamin Lee spoke about the in vitro surgeries and the advancements that are happening. How, like, even a very simple anatomic anomaly, if not addressed on time, can result in serious physiologic consequences, like in diaphragmatic hernia or PUV. So I'm equally excited to know about these advancements, and I only wish and pray that health insurance should come a long way to understand the advancements that are happening in this field. Dr. Shroff, he spoke about transplantation, and he was suggesting how we can create a trained hospital coordination team. That was very interesting, because he was just trying to say that there is some poor knowledge about transplantation, not only to the public, but also to our professional colleagues. In the same way, there are also a lot of information that we need to know apart from our practice in clinical medicine. This comprehensive outlook can really help us to extend our tentacles and get the right respect and earning what we really deserve. So having, like, as a doctor who moved from health insurance, healthcare services to health insurance space, I see that, there are a lot of areas to be addressed, and I strongly feel that doctors are yet to be compensated for all the efforts that they are, and the contributions they are making towards saving lives. So naturally, when Dr. Amar Shah and Dr. Ramesh Babu, they have initiated for a talk with our senior expert doctors in Star Health Insurance, we could understand the advancements that are happening and the need for people. See, whatever the infrastructure expertise that are available, end of the day, if there is no financial support, most of the expertise cannot be fulfilled. So naturally in India, hardly 10% of the people have some form of health insurance cover. Whereas in developed countries, we have been listening to my previous speaker was talking about opportunities in UK. You see that majority of them, close to 80 to 90% of them have some form of insurance cover. Whereas in India, people who are at a threat of a disease or who have a strong family history or who are likely to have medical treatment, only they look at insurance cover. Ideally, more and more young and healthy people should come forward and take insurance. And in that way, now the people are waiting for diseases to be covered. And insurance companies are waiting for young people, healthy people to come and buy insurance. So this is the issue which the industry is facing. Naturally, we can reach a balance. And with people like Dr. Amar Shah and Dr. Ramesh Babu trying to reach insurance companies and explaining to us, because we were ignorant unless they come and speak to me and they ask me to participate in a conference like this. Honestly, we cannot understand about the modern advancements that are happening in vitro fetal surgery or transplantation or nanotechnology. So naturally now my homework is to see that, how I can expand my coverage and see that people who require all these treatments get some form of financial support. So when it comes to newborn cover, in India, usually insurance companies were waiting for the child to reach few weeks of age to ascertain that there are no internal anomalies or congenital external anomalies, and then start giving a cover. So we want to break that myth and start introducing a cover from day one, so that all types of admissions, be it for neonatal intensive care management or immediate surgeries, pediatric surgeries that are required, all these things have to be covered from day one. When a vehicle that comes out of a garage has to be insured, you should have a compulsory third-party insurance before we drive this vehicle on road. But unfortunately, a child born in India, it is not covered under insurance. So naturally, we should look at some innovative ways to cover. We from health insurance have only one apprehension. We collect from many and pay for few. And we are very scared about abuses, misuses, or huge losses happening. Otherwise, there should be no barrier for insurance companies to come forward and cover all these procedures. In fact, we from Star Health Insurance, since we have a big team of qualified medical experts, we feel that it is our duty to our country and to our profession that we should be the pioneers in innovating all these insurance covers for common citizens of this country. So we are trying to cover from day one health insurance for a child, provided the parents are covered with us for 2 years. So in the same way as Dr. Ramesh Babu was pointing out, in future, we may come up with a lot of cover, including immunization, metabolic screening, and in vitro surgeries, all these things. Naturally, insurance companies have to come forward and embrace these advancements. Only then they can sell their products. So it is a mutual advantage. The whole ecosystem can flourish only if we understand the advancements and come forward to create a cover for all those people who are born on day one. It's very, very bothersome to know that so many people in India are pushed to poverty because of health reasons, and they have been postponing their surgeries because of lack of financial support. So naturally, we have introduced that in one of our policies. I am very confident that after hearing from you and after you all gave me that opportunity to understand the advancements as a medical person in the insurance sector, I will be failing in my duty if I don't work on introducing cover for further advancements that are going to happen in this field, and also introduce newborn cover. Currently, we have in one of our policies. Going forward, we have to introduce this in more and more of our policies so that the whole industry should keep following. And end of the day, all insurance companies and all health insurance products should have attractive cover for people, for children born with congenital diseases. And this cover should be made available from day one. I'm very confident that we can closely work towards it. Thanks again for the opportunity to be with you and to learn a lot from you. And I sincerely pray the Almighty to give us extra strength, energy, because insurance is a game of large numbers. Only when more and more people come forward and take insurance, we can adventure into all these areas and introduce these things into our coverage. I thank you all again. Good luck. God bless. Bye-bye.
Yeah, please say something.
Dr. Prakash, it was wonderful to listen to you again. We had a long meeting last time when Dr. Suresh from Chennai had also joined. And as I had said at that time, that Indian Association of Pediatric Surgeons is with you for every single aspect of pediatric surgical care. Whatever services, whatever documentation, whatever help you need from the IAPS, we are there with you 1000%, not 100%, but 1000%. Every single member could actually help every single insurance company to come forward and provide an insurance cover for these babies who require a long-term care. Some of them actually can live a very, very normal life and a very productive life. And we would be failing in our duty that if we don't provide good care to these children. So I'm really thankful to you for breaking the ice with the insurance company. We have been struggling with this for many, many years in the past. And I'm really, really grateful for Star Insurance to come forward and help us in starting this process. And as I said, we all are there to kind of help you in marketing or whatever things that is required from IAPS. We'll always be there with you. I really appreciate all your efforts. Thank you very much for your kind help to the society and kind help to these children who need to be looked after well. Thank you, sir.
Thank you, sir. Bye-bye.
Thank you. Anybody else? Thank you.
Thank you, sir.
Unmute.
Yeah, thank you everybody for a wonderful CME today. The 47th National IPS Conference has started with a bang, and we had some fabulous session today. And it is very nice that we could actually have some sort of a hybrid meeting. And this is the first time that we are conducting a hybrid meeting in IAPS. Last year, because of COVID, we conducted everything online again for the first time. And this year we are conducting this as a hybrid meeting followed by the continuous online meeting for next 7 days. In fact, whenever I have spoken to my colleagues in different departments and different hospitals in Mumbai, everybody is aghast that we are going to have the national meeting for 8 days. Nobody has heard something like this before. And they are all very, very kind of pleased that pediatric surgeons are really taking great effort to try and educate each other as well as share their experiences and learn from each other. And this is something which we all will cherish and we all continue to do. So thank you everybody for sparing your time on a Sunday. And please take care of yourselves. Please take care of your family as well as your staff members wherever you work. And good evening to all of you. Bye-bye.
People will log out now or they'll stay forever?
They can stay.
They can stay.
So thank you, sir. I think it was a wonderful CME session, which we finished just now. And now we will be arranging and starting the felicitation program. We will take a 5 minutes break to arrange things, and then we will be starting the felicitation after that. So at 2:20, we will start the felicitation program. I will request everyone in the audience to be there. We are felicitating a lot of our IAPS senior awardees, our senior IAPS members, and other people who are available here. And we'll start at 2:20. Thank you. So this room will stay open. The link is same, and anyone can join. Thank you.
Yeah, so grab a chair and come at the front, please. Thank you, everyone. So we welcome all of you to this felicitation program here during the pre-conference CME of E-IAPSCON. So as you all know, for the last 2 years, we have been living in the era of pandemic where all the physical gatherings were prohibited. And we have executed all the due responsibilities and the functions of IAPS in an online manner. So this time, once the pandemic was fading away, we thought that this is a good opportunity to at least gather some of us, the senior people, the executive committee member, so that we can meet and greet and felicitate all these senior awardees with the IAPS. So with that, we had planned this meeting, and this meeting is otherwise being streamed live on IAPS YouTube channel also and on Zoom as well. So I'm sure there are more than 100 people who are actually watching this felicitation program, and I welcome all of them. I will hand over the mic to the president of IAPS, Dr. Ravindra Ramadwar, to welcome our chief guest, and then we'll light the lamp.
Thank you, Ravi. I think it has been a very testing time for all of us. Last 2 years have been really stressful for everybody. So I actually would like to really thank everybody who could make into the physical part of this meeting today. And as a important part of any function, we always have something called an inaugural ceremony, which starts with the lighting of the lamp. So today I have the great pleasure of inviting Dr. Mrs. Deshmukh, who has been my teacher, and the reason why I was not into surgery, I developed practicing for that, because she nurtured us in the initial years that I could progress in pediatric surgery. I'm really pleased that she has agreed to come here as a chief guest for the inaugural function, and she is going to be also present as a guest of honor during the inauguration of the IAPS conference. So, madam, can I request you to come ahead, please, and light the lamp, which you have lit in all of our hearts many, many years back. I would also request Dr. Datar sir and Dr. Bagri sir, senior most people in the audience, to come forward and help us in lighting the lamp. Yogesh, as a president-elect, please come.
ठीक है, अभी ठीक है, ओके ना?
So I think this is a very good opportunity to facilitate Madam Deshmukh, and she has been everybody's teacher and a very guiding force to all of us, all the pediatric surgeons across the country. I would ask Dr. Ramadua to felicitate her. For those of you who don't know, Madam Deshmukh is one of the very few people who has been the president of IAPS as well as the president of ASI. There are only three presidents of IAPS who have been the president of ASI as well. Madam Deshmukh is one of them. The other two are Dr. Durai Rajan and Dr. MS Ramakrishna. So that's a great achievement, madam. Yes, RK Gandhi. Sorry, I forgot. So IAP also. Okay, that's the information to be presented. So that speaks a volumes about her achievement and what she has done as a pediatric surgeon and for all of us. So thank you, madam. Thank you so much.
Nice of you to say so many words. Secondly, very happy to see all youngsters. One young girl met me downstairs when I was coming in, and she held my hand, thinking that I will not be able to climb the steps. I was very happy. This is the way the younger generation still respects elders. And we always start any function in lighting the lamp. I also brought a lamp for you. Keep it at home and say thank you. You light the lamp why? Because it takes away the darkness. And the lamp continues to go. In Marathi, we call it CME. CME is eye. what she does, she takes care of the child as you take care of our children and make them better and better. She takes care right from the CME program was excellent, very good. I have seen all CME programs all these years, but this was one of the best CME programs. They combined a lot of things. Here is Ram Samaj. He will agree with me that this was the best CME program ever organized. And it completely till the end. The best part was fetal surgery. How different, 81 it started. And now it has changed a lot. So I must give right on the back the president, the secretary, the office bearers, everybody who have contributed a lot to this conference, which is going to be one of the best conferences. Because one of my students, Dr. Karan, who is now in the central ministry, he is going to come to inaugurate. Is that right? Yes. Yes. He is basically he's a pediatric surgeon. He was with me and then he built a hospital. The hospital functioned well. He has got excellent pair of hands. But he decided to go into politics. And rightly so. Because unless and until the politicians are with us, the departments will progress. So he's chosen a right thing. And I'm very keen to listen to him, so I'm going to come function also. At that time, I will not speak, but I listen to him. Ram Samaj is here. Pagri is here. My own, though he is my student, but he is like my son. The Tata is here. His wife has not come. I thought she will come and I'll meet her. But he's both daughter and son. I'm very fond of him. Uma and Neil, both of them. I used to say he was a collector of stamps. So he used to collect stamps and I used to send him, as soon as I get a different stamp, I used to send him the stamp. I don't know whether he will remember that. Yeah. Rajiv Redkar is here. Rajiv is a fantastic person. Really. Because his father has inculcated very good habits. And this is what we call in Marathi samskar. The samskars of Rajiv Redkar are inculcated with him by his father and mother. I had gone for his marriage, but after that, I had never met his wife. So today he promised that he will bring her to my house. So Sareen is here. Sareen also I know him well because my colleague Dr. Shanti Talwar, who is a pediatric surgeon, she was trained in Chandigarh. She used to talk about him all the time. She said, I invited Dr. Sareen, but he has not come. He chose to go to.
I replaced her.
Now you replaced her.
1980.
But before that, you went to Ludhiana.
Yes, that was in Cincinnati.
Yes. So this is what the history is.
I may remind you, ma'am, way back in 96, Ram Samaj, myself, we were there for the interview for assistant professor where you were the external expert.
Okay.
So we were 5 of us. One of them is Roy Chaudhary, who works with me in very hardly. And 2 more.
Did I select you or no?
Ram Samaj was picked up. We were all close to 5 people were there and Ram Samaj was selected.
Because I was favorite of mine.
Oh, आपने सुना नहीं? बोला क्योंकि मैं मैम का फेवरेट वो तो मुझे बेटा मानती है तो बेटे को तो लेना था तो लेना था
सब लोग फेवरेट है
and one of them was Sharanji, the one who's in UK consultant Chalenderji and Gurpreet who's Dr. Ajmer Singh's son.
Yes.
So we five were there.
Ajmer Singh.
He's 96.
He's still the same.
Yeah.
As he appeared for the interview, he still looks the same.
Yes.
And, yes, I met quite a bit of young people. Just now, some are working in KM. We are in KM. Ramani. Good. Adi. Yes, now my first name. Everybody my first name. And this, Manju. Manju Silekar. Was in KM. She was in Nair first, and she was in KM. She was at Somaya, where I met her again. And I remember distinctly, we traveled to Alibag together. And that time, she had 2.5 hours journey. I'll be very hungry. So she brought a big basket of wonderful chocolates. And I ate practically all of it. She never felt that I would eat all these chocolate flavors. 2.5 hours drive. And that too, we left in the morning early to reach on time. Nice girl. Girls are always nice. We appreciate them. If a lady doesn't appreciate another lady, then there is something wrong. And if that happens, then it should be taken in the proper perspective. You must appreciate, must help, must see to it that she also rises further. So in our language, we say Ashirvad. And in Sanskrit, how the Ashirvad is given? Tushtirastu, Pushtirastu, Arogyavastu. What is most important of the three is Arogya. So all of you should be healthy, wealthy, and wise. That is what is my blessing to you. The pediatric surgery will continue. Having seen this CME program today, I feel pediatric surgery will surpass cardiac surgery. Because until now, cardiac surgery was remembered and was respected by everybody. Now pediatric surgery will be respected. And you will win. Whatever you do, you will win. Okay? Thank you so much for a long time.
मैडम एक संस्कृत श्लोक उसके बगैर तो आपका स्पीच कभी कंप्लीट नहीं होता है
क्या
एक संस्कृत श्लोक का हमेशा बोलते हैं
हाँ संस्कृत श्लोक ओके I will do that. Never get angry with anybody. In Sanskrit it is said krodhat bhavati sammohat. Sammohat smriti vibhrama. Smriti bhramshat buddhi nasho, buddhi nashat vinasho. At least Aditi will understand that because she is from the institution Palliative Vidyalaya, who has completed 100 years now. So we are very proud that a student has become a pediatric surgeon. Very good, Aditi. All the very best. Kavri, are you happy now?
I never heard a speech ending without a Sanskrit slope. So many times I heard it.
Today I thought nobody will understand Sanskrit now. But she will understand. Because she comes from the same place where I live, Vilipati.
I would, ma'am.
You
I take Gita classes every morning. It's in Sanskrit, so I have to learn Sanskrit now.
Then why don't you teach me online?
Sure. I can give you a link. I can give you a link. They teach you Gita in the morning and how to pronounce it right.
Yes, correct.
बहुत अच्छे से promote कर
Thank you, ma'am. Thank you so much for those enlightening words. And we will proceed with the rest of the ceremony now. So before we start the felicitation, it has been a common tradition for the IAPS authors. So anybody who is an IAPS member and has written a book, I think this is a very good platform for him to come and release the book in front of the rest of the members. Dr. Ramesh Babu has been a very active writer and a painter and lot many fronts. He has come up with a book on pediatric urology. So Dr. Ramesh, I would request Dr. Ramesh and Dr. Amar to join us for the release of the book. I would request Dr. Ramesh to just say a few lines about his book and what he was going in the target or
We felt that for the sake of postgraduates, we need a short handbook on pediatric urology. And myself and Dr. V.S. Chandrasekharan has compiled this book. And actually, this has been already published. And this is the official platform. We got a chance to release it. So actually, the first copy should have gone to Dr. Ramadhan, but already around some 150, 200 copies have been sold. But this is the occasion to introduce the book formally. So what I want to say is that this book is a summary for postgraduates to learn about all the basic pediatric surgical, not operative, but basic like classifications. What is latest? So I feel that this will be very useful for the exam going postgraduates to quickly revise, because books like Campbell are too difficult to read. They can read this first and then go to Campbell. So this will be a really useful handbook for common pediatric like antenatal hydronephrosis, the various gradings, and how to go about vesicular reflex, complex areas. All of them have been covered. Thank you so much for listening to this, Dr. Congratulations. Of course. Yes, you can. Yes.
Thank you. Thank you, Dr. Ramesh. We will move on to the felicitation now. So we'll start with the award ceremony now. Since last year, there was an award ceremony which was done online during the first E-IAPSCON, and there were senior awardees at that time. All the awardees were given the awards, the citations were read online, and the plaque was sent to them via speed post. Fortunately, I was with Dr. Ram Samut, so I had the opportunity of giving him the plaque in person in a departmental ceremony. We thought that since we are doing this ceremony this year, we should call them and give them an opportunity to be here on the platform of IAPS. And all the IAPS members should be able to see them in an actual physical felicitation. So we will start with the 2020 awards, that is the last year's award. So our first awardee is Professor Ram Samuj, who delivered the IAPS Mridula Rohatgi oration for 2020. Madam, please join us. Bajit ma'am. So the award carries a citation and a shawl. So Professor Ram Samuj is the professor and head of pediatric surgery at PGI Chandigarh. He's a very respected, reputed surgeon there, and he's been with us for almost, I've been with him for almost last 15 years, and he has been a guiding force for all of us. Thank you, sir. Thank you so much. Thank you very much. Thank you. Thank you, sir. Thank you. Madam का आशीर्वाद है और so our next awardee is Dr. Bagdi, Dr. Raj Kishore Bagdi. He got the IAPS T. Durai Rajan Gold Medal for the year 2020. I would request President-elect Professor Sareen to join us, please, sir. Thank you, sir. Thank you so much. So our next awardee is Dr. Vireshwar Bhatnagar. So he is not here. He has his own reasons, health issues and family issues, so he could not make it to this ceremony. We have already delivered him the citation plaque and the citation scroll. Maybe we'll go sometime and felicitate him at his home whenever I get a chance. The next awardee is Dr. Govind Datta for IAPS KC Sogani Award for the year 2020. Thank you. Please. Thank you, sir. Our next awardee is IAPS Puranchand Gupta Award for the outgoing president of IAPS for the year 2020, Dr. Ramesh Sanat Krishnan. He is also not here. He had all his plans to attend this meeting, but somehow at the last moment he had change in plans. But all our respects and regards are with him. The citation plaque has already been sent to him, and maybe whenever he is with us next time, we will felicitate him at that time. So this was the awards, major awards for the year 2020. We will start with the award for the year 2021. So our first awardee is IAPS T. Durai Rajan Gold Medal for the year 2020, which goes to Professor S.N. Kuril, Padam Shri. Professor Kuril is here with us. Sir, thank you for coming. Sure. Those of you who don't know, Professor Kuril is my mentor. Whatever in pediatric surgery that I know as of today is just because of him. And thank you, sir. You have been a guiding force. You have been a great teacher to people like me. And actually, you are the reason because of which many people have become pediatric surgeons, and I am one of them. Thank you, sir. Thank you so much. So our next awardee is IAPS R.K. Gandhi Gold Medal for the year 2021 goes to Dr. Kishore Panjwani. Dr. Kishore Panjwani is also not here with us. He initially had all the plans to attend, but somehow because of his health reasons, he couldn't make it. I will be in Agra soon with him, and we have planned a felicitation ceremony at his home. So we will do it at that time. So I'll go on to the next award, which is IAPS KC Sugani Award for the year 2021 goes to Dr. Dhananjay Basak. Dr. Dhananjay Basak also couldn't make it to this ceremony. And I am sure I will request the people from Kolkata to collect the award plaques and the scroll from me. And hopefully they will arrange a ceremony at their place to felicitate Dr. Basak. The next award is IAPS Puranchand Gupta Award for the outgoing IAPS President for the year 2021, which goes to our beloved President, Professor Partha Pritrim Gupta. He is also not here because he had a clash of schedule with a family program. But sir, we really missed you in this meeting. If I hope you are listening to this, and we really missed you. It would have been really nice to be here and give you all the felicitation in person. So we will hand over the plaque and the medal to Dr. Saha, I think, and then maybe there can be a felicitation ceremony in Kolkata, and hopefully we should be able to felicitate you in person. So thank you so much. There are two major orations which are delivered every year in IAPS. The first one is IAPS MS Ramakrishna oration for the year 2021, which goes to Dr. Mohan Abraham. Mohan Abraham sir is here with us. So Dr. Abraham will be delivering the oration on the conference days, and he has chosen the topic of BUR, where we are. He has got a vast experience in the field of pediatric urology, and I am sure that his talk is going to be enlightening for many of us. We all know that Dr. Mohan Abraham has been a pioneer in his field, especially recently in the field of fetal surgery. He is actually the only person who has made stride in this particular field, which is very, very difficult, sir. IAPS really appreciates you about the achievements and the things which you have done for all of us. You are truly an inspiration, sir.
One thing I want to say, Mohan and I are alumni of surgery department of CMC Ludhiana. So he used to be my mighty senior. Never worked with them, but we share that bond. Thank you so much.
So just one more additional information. The citation scroll outlines all the achievement of the awardees. We will be reading the citation scroll at the time of this ceremony during the oration. So that will be read out at that time. The next oration, which is the IAPS Mridula Rohatgi oration, it was awarded to Dr. K.L. Narasimhan. Dr. K.L. Narasimhan is a professor of pediatric surgery from PGI Chandigarh. He was one of the ex-faculty over there. Currently, he is based on Singapore. I'm sure he must be watching this ceremony. And I had spoken to Dr. Annette Jacobson a few days back and told her that we would like you to felicitate Dr. Narasimhan. And I had sent her the plaque and the citation scroll through courier. It has reached them. They are holding a ceremony on Monday, and they will send us the picture at that time. So thank you, Dr. Narasimhan, for all the work you have done in pediatric surgery, and you truly deserve all the respect which should be there as a pediatric surgeon for you, sir. Thank you so much. There were two other awards which were started during the tenure of the current EC, which was IAPS Amal Kumar Bose Lifetime Achievement Award. So this was an award which was started by Professor A.K. Basu. And last year, this award was awarded to Professor V.R. Ravi Kumar for the year 2020. He was the first awardee for that year. And we all know that he truly deserves that Lifetime Achievement Award beyond any doubts. And he has been the forefathers of at least my generation to guide us all for pediatric surgery. We have listened to him, his lecture on ABG, which was so simplified for such a complex topic, and so informative for our juniors to listen to him on the subject matter of ABG. So thank you, sir. I'm sure you're listening to this ceremony. Thank you for being there for all of us, and thank you for being there for pediatric surgery. This year's Lifetime Achievement Award was awarded to Professor H.S. Asopa in Agra. He was the second recipient of the award. Dr. Kishore Panjwani was kind enough to arrange a felicitation ceremony at his residence. He had health issues, and I had circulated the photograph and the videos of the felicitation ceremony in the newsletter. And he very graciously accepted this award, and it was truly an honor and pleasure for IAPS to bestow him with that award. So that was about the awards. This year, I was having a discussion with President Ramadwar, and we decided that the presidents of IAPS, so far there has been 47 presidents of IAPS, 48 including Dr. Sareen, and we decided that they should get a president's plaque. So it is something, if somebody has been the president of IAPS, he should have something for his wall which should specify that he has been the president. And we collected the names of those people who would be here physically and made the president's plaque. So I'll just speak out the names of the president plaque. So these are in no particular order. So please forgive me if there is a mix-up of senior versus junior. These are just random order which we are going. First is Dr. Ashok Basu is not here with us, so we will hand over the plaque to Dr. Subhashish Saha. He can deliver it. The second name is Professor S.N. Kuril. He was the president of IAPS for the year 2016 and 17. So I'll just say the names of the people who are actually present here. Dr. Rasik Shah, sir, please. Dr. Rasik Shah.
Thank you, sir.
Rasik Shah was the president on 2017-18 year.
13-14.
13. Okay, sorry, I missed it. Dr. Ketan Parekh. So, yeah, Dr. Partha was the president last year, but he's not here. Then we are left with Dr. Ravindra Ramadwar, who is the current president, so he deserves one. Dr. Ramadwar. So now the next part of this ceremony is about the EC members. So we were very fortunate to have a very dynamic team of EC members, total 19 of them, and all the elected executive committee zonal members, they were full of energy. Everybody was wanting to do something or the other and take the responsibilities. They were very prompt in whatever responsibility they were taking and completing the task. And I will be presenting the secretary report during the conference general body meeting. And at that time, I will be presenting all the work that has been done by the EC in the last 2 years. And I'm sure all of you will appreciate the quantum of work that we have done and the efforts that we have made in the direction of progress and towards the betterment of pediatric surgery at that time. So I would thank all the EC members. It has been a great pleasure working with all of you. And I will again speak out the names of all the EC members, again, not in any particular order, to receive a plaque of thanks. You may say it as a plaque of remembrance for all the work you have done. So I'll start with, first is Dr. Manjusha. I'm also disbursing the COVID certificate for her. So this time we had called out for all the people who have done COVID related work during the pandemic. And this is an effort by IAPS to recognize all the work they have done for the pandemic. Thank you. Thank you, Dr. Manish. Dr. Shilpa. Dr. Shilpa Sharma. So Dr. Shilpa compiled the COVID guidelines which were published in the Journal of Indian Association of Pediatric Surgeons. And she was very active during the entire 2-year period, contributed very actively. Thank you, Dr. Shilpa. Next is Dr. Rajiv Redkar. Thank you, Dr. Redkar. Next is Dr. Ramesh Babu. Dr. Ramesh has done a lot of work in that field of insurance. We have heard from him in the last session. He made the STG guidelines, which was really important, a very important publication from IAPS. Thank you, Dr. Ramesh. Dr. Subhashish Saha. Dr. Anand Aladi is not here, so we'll skip that. Dr. Arvind Sinha. Sir. Dr. Vivekanand Jindal.
May I say a word? I'm very proud to say that Shilpa had also started her pediatric surgeries journey from my department. And Arvind was my first MCA student, so I almost take him like my son. My hands shook only once in doing pediatric surgery ever in life when I was operating on his son just for a herniotomy.
Thank you, Dr. Jindal. Dr. Vijay Upadhyay. Vijay Upadhyay. Dr. Rishi Dwivedi. Rishi has been the treasurer of IAPS. He has all the money, so he's the most important person. Dr. Soni Lingdo. Dr. Prakash Agrawal is not here, so we'll just give it to Dr. Ramesh and he can give it to him. Dr. Yogesh Sarin has been the president-elect, in the capacity of president-elect in the EC. So he definitely deserves one. He will have the president's plaque next year. Sir, it is here with me, but officially I cannot give it to you now. So it will be there next year for you.
I just wish to make another comment. This is the third attempt that I became the president. And one of the advantages of this going through this campaign 3 times was that I had a lot of blessings from my seniors. I remember calling them up for reward, like Dr. They would talk to me half an hour, 45 minutes. You know, Dr. Datta, they will talk about 20 minutes and keep talking. I mean, I really relish those moments. And year after years, I'm seeing the blessings, and that was blessing in disguise.
So the last 2 people are the secretary and the joint secretary. And for the joint secretary, I must say that he has been a tremendous amount of help for me. And without him, it would have been a really difficult 2 years for me. He has been so much helpful and he has taken most of the responsibilities. He has actually made people realize that how important the post of joint secretary is. I tried a lot to convince him to file for the secretary post, but somehow he would do it later, not now. So thank you, Amar. Thank you so much. You have been a great friend and a great colleague for this job.
Yeah.
I think I've been extremely fortunate, as is Dr. Gupta, to have this EC and two very young, dynamic people to help us all throughout. One of the finest secretaries IAPS ever had, Mr. Ravi Kanoji. I take a great pleasure.
On behalf of all IAPS members, I really congratulate them.
Thank you.
We are because of these students. So whatever we could achieve is probably because the entire team has been behind us, helping us. And actually, whatever we mentioned in the EC meeting was carried forward at the drop of a hat. It was fabulous performance. Thank you very much, all of you. Really, really appreciate it.
I think we should have a process CME coordinator or something, and we should take over that. Honestly, because this time that we had so many CMEs online platforms.
I think let's not impose on the next EC, otherwise our president-elect might object.
वो मेरा सीनियर है यार, जो बोलेगा डॉक्टर देवधर एंड डॉक्टर कुछ भी बोलेंगे तो मानना ही पड़ेगा, दो
So I think that concludes the, just one last thing remaining. As I said that IAPS gave away COVID warrior certificates to some of their members. We called out on the IAPS Google group that whosoever who has worked in the pandemic towards the COVID related work, they should inform us. And IAPS will be very happy to grant them the certificates. We handed over some of the certificates here, and some of the certificates are there. Dr. Ramsamut has the certificates in our department, which we will distribute during a ceremony with the officials over there. We have some of our junior friends over here from Mumbai. Aditi is here. I think she can receive those COVID certificates on behalf of rest of her departmental residents, senior residents, junior residents. So whatever name that were given to us, we made a certificate out of it. And I would request Aditi to come and collect it, her certificate and behalf and for the others as well. Aditi, please come.
One more.
Thank you. So that concludes our, yeah, so that concludes the ceremony now. I would request everybody present here to come outside for a group photo. And then after that, we'll start our EC meeting. So we'll have a group photo for everybody and then an EC photo later on, once the EC meeting. Achha, we'll do it now. So we'll start with a group photo and then after that, we'll take an EC photo immediately after that. So we can go out in the lawn so that we have good light and take a photograph over there. Thank you.
Thank you.
Now for those people.
So thank you. Yeah, thank you everyone for all of those who have attended this ceremony.